day for the Best of Oncology Cancer Care Conference hosted by Prince Sultan Military Medical City. It's my pleasure also to present moderator for the first session today, Dr. Abdulrahman Jazia, Professor of Oncology and Head of the Oncology Department in King Abdulaziz National Guard Medical City, Riyadh, Dr. Ahmed Abdul Warith, Medical Oncology in King Khalid University Medical City, Dr. Samir Shahata, and Dr. Mirvat Mahrous. To make it short, and ask the moderator to take the stage. Thank you.
Assalamu alaikum. Good morning, everybody. I would like to welcome you all to this distinct meeting. And it's my pleasure to introduce the first speaker. But before I do that, I would like to thank the organizing committee for putting such a terrific program. And I would like to encourage everybody to put questions in the QA panel, please. Without any further delay, I would like to introduce Dr. Turki Al-Faya. Dr. Turki is one of the key opinion leader in lung cancer in Saudi and in the region. He is a consultant medical oncologist at Princess Noura Cancer Center at King Abdulaziz Medical City National Guard Health Affair Jeddah. Dr. Turki will be talking to us about early stage management of non-small cell lung cancer, touching specifically on the EGFR mutation management. Dr. Turki, the stage is yours.
Assalamu alaikum. Sabah al-khair. Thank you so much for the invitation, and special thanks to Dr. Abdulaziz Al-Hamad, Dr. Mirvat Mahrous, and to Prof. Abdulrahman Jazia, and all other panelists. So I'm going to discuss the updates and the early stage disease of non-small cell lung cancer. So we all know that we are dealing with a kind of aggressive type of tumor compared to other type of cancers, and unfortunately, majority of our patients present late with lung cancer. Only 30% of our patients can present with early stage disease where resection can be done, or at least even discussion about resection or concurrent chemoradiation for curative intent. Despite that, you see the numbers of survival at 5 years are very disappointing, except probably for stage 1. However, if you look at stage 2 and stage 3, the number of the percentage of survival dropped very significantly. This is the scope of discussion today. So we are discussing the stage 1, the tumors that are located in the lung without lymph nodes, or stage 2, the tumors that are located in the lung with hilar lymph nodes, or stage 3, the tumors that has hilar and ipsilateral mediastinal lymph nodes. And keep in your mind that this is there are some changes in the 8th TNM staging system, minor stages in the size of the tumors. So in our daily life, when we see a patient with early stages, we take this case to the tumor board for discussion. And if this case is resectable, then we will send the patient for surgical resection. However, in some occasions, you may need to consider neoadjuvant treatment in some occasions, hoping that we can convert the unresectable case to resectable. Especially in patients with a chest wall invasion with the hilar lymph nodes only, or those with a single stage and into that we believe maybe surgery will help, or in the superior sulcus tumors where chemoradiation can help. Then we follow this treatment with resection. In any event after surgery, the thing that really dictate on us whether to offer adjuvant treatment or not is the pathological staging, as well as the comorbidities and the post-operative recovery. So when we offer adjuvant chemotherapy, we offer them based on multiple large clinical trials. At least we have 5 clinical trials. All are positive trials with positive p-value. And it all suggested that adjuvant platinum-based chemotherapy after surgical resection will help in reduction of will help in improvement of overall survival. But what is the most important actually piece of evidence is the LACE meta-analysis that included all the 5 clinical trials that was in the previous table. And in this meta-analysis, the benefit was about 5.4% in favor of the adjuvant chemotherapy. And also we have the Cochrane meta-analysis, which is a more updated one that showed a 4% improvement in 5-year survival when adjuvant chemotherapy is offered. From the LACE meta-analysis, we learned that it is detrimental to give chemotherapy to stage 1A. And for stage 1B, it is area of discussion. Some high-risk patients may benefit. However, the majority of the benefit was seen in the bigger tumors, stage 2 and stage 3 disease. They also suggested that cisplatin venirabine is the best. However, we know nowadays that also cisplatin and pemetrexed is equivalent and less toxic option for the non-squamous histology. And unfortunately, when we offer adjuvant chemotherapy, some patients may not really tolerate to continue the 3 months treatment. 1/3 of patients may drop the treatment, but more important that there is about 50% in the worldwide populations cannot receive adjuvant chemotherapy. This is a data from a large retrospective analysis from Europe, showing that 52% could not receive adjuvant therapy for many reasons. One of them is the complication or delay in surgery recovery, as well as poor performance status likely related to the post-operative complications. And also another issue is that the recurrence is high. So if you see the stages, when you get a bigger tumors, the risk of recurrence is higher, and the majority of patients will have a recurrence either in the bone, liver, lungs, but the most important area is the brain, where the prognosis become very guarded and the quality of life become very affected. There is a data saying that local regional recurrence is associated with a longer post-recurrence survival. So if the recurrence happened in the lung, then probably we are dealing with a longer post-recurrence survival compared to other distant metastases. So talking about the EGFR mutation, because this is the hot area for discussion nowadays, the prevalence of mutation across all stages seems to be the same and not affected by the stage, at least from a systematic review and also meta-analysis. So in the meta-analysis, 32% of EGFR mutation in all population. What really matter here is the geography. So you see Asian population seems to have higher EGFR mutation compared to others, and this is well known to all of us. And also in this systematic review, the Asian and Pacific area seems to have the highest rate. So stage does not matter. What matter really actually is the geography. These are the many clinical trials evaluating EGFR TKIs in the adjuvant setting. We don't need to really go through all of these trials, but one of the important trials is the SELECT, although it is phase 2, but it was designed nicely to give erlotinib after chemotherapy for 2 years, and there was a positive DFS benefit compared to the historical data we have. RADIANT is actually a negative study that included erlotinib versus placebo after chemotherapy. So it was a DFS benefit. Sorry, there was no DFS or overall survival. One of the important trials that we will discuss is the CTONG trial, the Chinese or the Asian trial that was presented in the ASCO a few years ago, and it was initially positive, then the updated outcome is not. BR19 is a data that included gefitinib after 2 years of chemotherapy, and unfortunately this study, despite having a large number of patients and phase 3 trial, was negative when it comes to DFS or overall survival. So a meta-analysis included all of these trials in the previous 2 tables, about 5 trials, and DFS in the EGFR mutated non-small cell lung cancer was significantly in favor of TKIs. However, the overall survival was not positive. Keep in your mind that there is a heterogeneity of these trials. Some of these trials used TKIs compared to chemotherapy, and some of them used TKI after giving chemotherapy. So hard to really draw conclusion when it comes to survival. So I'll discuss in few slides the CTONG 1104 trial, which is a trial that was presented 2017 and also updated this year in the ESMO. In this study, patients from Asia were staged stage 2 and 3A pathological staging, so it means N1 or N2 disease, randomized to gefitinib or standard of care cisplatin and vinorelbine. Primary endpoint was DFS. I also presented the OS and the 3-year, 5-year DFS in the ESMO. So initially in 2017, it was positive with about 10 months difference in favor of gefitinib, and this is the DFS at 2 years. However, the updated 3-year and 5-year DFS rate was not really significant. So you see the curves. Still, if you see it, statistically, they are significant. However, you see the curves are really start to superimpose each other, especially at 5 years. And this is for the intent to treat population and also for the per protocol population. The survival data, this is the first presentation, and there was unfortunately no survival benefit from giving gefitinib over chemotherapy at 5 years. So a patient who had the gefitinib and then had a recurrence, there was about 57% of them received subsequent TKIs. There was more patients received TKIs in the chemotherapy arm. What's really important here is that the response rate in the gefitinib arm who had a subsequent osimertinib was about 55% compared to other TKIs. This is an important slide because it tells us the survival, and keep in your mind that this is a post hoc analysis. It tells us the survival of the groups who progressed on gefitinib and received subsequent TKI. The median OS is still high, not reached. And also for the group who had the chemotherapy then progressed, they had a very good benefit from TKIs with median OS of 62 months. And unfortunately, the two groups who did not receive any further TKIs did very poorly. And they also suggested that the more duration of adjuvant gefitinib is associated with better survival. So this study initially positive. Still, there is a DFS benefit. However, there is no overall survival from adjuvant gefitinib. For the ADORA trial, this is a phase 3 trial that is an important trial and was presented in the ASCO this year and also updated in the ESMO. And the difference here is that they included stage 1B, so smaller tumors, and patients were also offered chemotherapy. This is another difference. And after chemotherapy, patients were randomized to osimertinib or placebo. Primary endpoint was DFS. There are many other secondary endpoints that has been evaluated. This is the baseline characteristics. The issue here is that there are also about 40%, 35 to 40% of patients were non-Asian in each arm, and about 55% of patients in each arm received adjuvant chemotherapy, which is actually a lower percentage than what we expect to see and to have in our daily practice. So the disease-free interval with the stage 2 and stage 3 was presented, and it was very impressive. So separation in the curves right away. And at 1 year, only 3% had a recurrence in osimertinib compared to about 38% in the placebo arm. At 2 years, 10% recurrence compared to 66% recurrence in the placebo arm. And at 3 years, 20% compared to almost 70%, 72% recurrence in the placebo arm. The hazards ratio is a 0.17, very, very low, and it was statistically significant. When they included stage 1B, so the whole population, still the benefit is very impressive, and the magnitude of benefit is very high over 1 year, 2 years, and 3 years. The benefit is seen across all subgroups, including stage 1B. However, the benefit is probably less when you compare it to other stages. And for the patient who received adjuvant chemotherapy or no chemotherapy, there was also benefit. This is just a dissection of the DFS based on the stage. So the magnitude of benefit is clear in stage 2 and stage 3, with a less benefit in stage 1B. However, statistically, it was positive. Now, the early overall survival was presented in the ESMO, and unfortunately, we cannot see any survival difference between the two arms at 1 year. However, the maturity data is only 5%, and probably we need a longer follow-up. The safety is we all know that this is a very fairly tolerable medication. About 11% in the osimertinib arm required to discontinue the treatment due to side effects. The pattern of disease was presented in the ESMO, which is important to us because based on the pattern of disease, you can really say whether this medication is important to be given or not. So for the osimertinib arm, there was a 62% of the patient who had a recurrence. They had the recurrence locally, with only 38% had it very distant. However, in the placebo arm, the majority of patients had a distant recurrence compared to 39% with local recurrence. Majority of the recurrence happened in the lungs and lymph nodes with the osimertinib. Only 1% had it in the brain compared to 10% of the patient who had a disease recurrence in the brain in the placebo arm. This is the CNS DFS that was presented also in the ESMO. So it was very impressive. This drug, as we know, that crossed the blood-brain barrier, and there was at 1 year, 0% of recurrence in the brain. At 2 years, there was a 2% only recurrence, and also at 3 years. So very effective medication in preventing the DFS in the brain. This is the updated NCCN guidelines released 2 weeks ago. So you see they are putting actually the adjuvant osimertinib in stage 2 and stage 3, also in stage 1B to consider it. And the consideration of osimertinib is all after chemotherapy. So I think chemotherapy is very important to consider it first before we offer osimertinib. And in the options here, they are writing that osimertinib in the EGFR mutated cases should be offered after previous adjuvant chemotherapy, or if patient is ineligible to platinum-based chemotherapy. So is there any flaws with the ADAURA trial? I think the trial is well designed, and overall they have a well-balanced arms. The only concerns is the adjuvant chemotherapy. It seems, despite they are very equivalent between the two arms, but the percentage is lower than what we expect, and this has been mentioned. The other issue is that we do not really know what is the status of the radiation, adjuvant radiation for those patients, especially if they have a positive margins or into disease. And there is nowadays the discussion about the usage of port, whether it is important, whether it is beneficial or not. But at least for the margins, we really do not know what happened to those patients. And also one of the issues is the PET scan was not really mandated. This is a very common to see in the global trials where a lot of patients comes from different areas of the world, and sometimes majority of these fancy modalities may not be really available. The importance of PET scan here is really to make sure that we are really not understaging our patients. So giving osimertinib for 3 years, probably for stage 1B, maybe there is over treatment here because some majority of the time over stage 1B may not need even chemotherapy. So we are curing those patients by just surgery. The other issue, as I mentioned, is about 10% discontinuation in the osimertinib arm, despite saying to our patients that this medication is very fair and very easy, but there was a 10% discontinuation. The most important issue here is the financial burden of giving expensive medication for 3 years. But having said that, when you look at the curves, you cannot really deny that there is a significant DFS benefit, and you cannot really ignore it to just say because of the financial burden or because of the toxicity. So they choose DFS as a primary endpoint, and whether it's translating to overall survival or surrogate for survival or not, we don't really know. But at least from the FDA, they approved DFS as a surrogate marker. And but the concern is that maybe when we give adjuvant osimertinib, we are actually delaying relapse. And once we stop the osimertinib, relapse will happen. So we are not really curing, we are just delaying the relapse. If you look at the curve of the ADAURA trial, there was a nice separation, but we really do not know what's going to happen at year 4 and at year number 5, whether these curves will meet. Because if you look at the curve down here, the gefitinib curve from the CTONG trial, at 3 years, the curves start to close, to become very closed. So if this is the case, then maybe just osimertinib is enough at the time of recurrence, and we cannot really cure patients. Then if patients progress on osimertinib, these are questions that comes to my mind. If patients progress on osimertinib in the adjuvant setting, then what should we offer when patients relapse? Are they going to benefit from, again, offering osimertinib? We don't really know, but probably the answer is yes, because we have data from the phase 2 SELECT trial. When patient had a relapse after erlotinib and re-challenged with erlotinib, there was a 45% response. And also we have a bigger data from the CTONG trial. The patient on gefitinib who had a relapse and given another TKIs had a very good median OS. So I think we need a longer follow-up to see the curves status of the ADAURA trial. Now, should we offer adjuvant osimertinib without really knowing the OS data? It is area of discussion, but if you look at the curves, the hazard ratio is very low for DFS, and it was unprecedented. And I never see, I'm sure all of the experts that are attending with us today never see curves like this in lung cancer. So you cannot really ignore this data. The other issue is that there are many patients on the placebo arm had a recurrence at 2 years, especially for the bigger tumors. So, so this is really important to put in your mind. The other issue is the clinical value of giving osimertinib, because when you give osimertinib, you are reducing the risk of distant metastases, mainly brain metastases, bone mets, pleural effusion, and liver metastases. These are the metastases that put patients under more admission, and it is morbid, very morbid type of recurrence. So if we are able to reduce these things, then it is very valuable to use osimertinib in the clinical setting. So while waiting for OS, I believe delaying the time of recurrence, especially in the areas where patients become very sick, is very important. And we really need to consider adjuvant osimertinib after careful discussion with our patients, and also after chemotherapy. So chemotherapy is still very important modality, and then we offer osimertinib after that. So with that, I will conclude my slides. Thank you.
Thank you, Dr. Turki, for doing the presentation on time, and very extensive and nice comprehensive review. Now I'll turn the mic to Prof. Abdelwarith to introduce our next speaker.
Okay. Good morning, everyone. It is my pleasure and my honor to introduce my colleague, Dr. Hassan Ghaffar. He is known for all of the oncology community in the Gulf and in the Arab world. Great experience in lung cancer. He's currently a consultant medical oncology in Sheikh Khalifa, United Arab Emirates. He will enlighten us about what's new in treatment of stage 3 lung cancer. Dr. Hassan, the mic is yours.
Thank you, Mr. Chairman, Dr. Ahmed, for this kind introduction. Good morning, dear all. I'm really delighted to be here with you today, and thank you for the scientific committee for giving me that opportunity, Dr. Amirvat, Dr. Jazia, and the other members. So thank you. My task for today will be just share with you the data for unresectable after you heard about those patients with resectable lung cancer. Very nicely from Dr. Turki. So unresectable stage 3 non-small cell lung cancer management updates. As you all know, the WHO in 2012 reported more than 14 million new cancer cases. And out of those, 8.2 million mortality, which considered the highest or the #1 cause of death worldwide. 1/5 of those patients who died, they died from lung cancer. If you see the figures for the incidence and the new cases of lung cancer, 1.8 million worldwide, versus those who died from lung cancer, we see the figures are very close. So we are not really curing that much patients from lung cancer. Most of those lung cancer, eventually they die from advanced disease. And this has not been changed for a long time. And it is a great burden to the community, as you see that lung cancer is equal to those who died from prostate, breast, as well as colorectal cancer altogether. If we take stage 3 lung cancer, locally advanced disease, 1 out of 3 patients, they presented with that stage. But we know also that this is a really very heterogeneous group. We know that the N1 is, most of those patients are resectable, while N3, most of them are non-resectable. While the problem is mainly in the N2 disease, where the management are really controversial, and it is very complicated. It is the tumor burden, it is the station of the N2. So there are a lot of variability within this N2 disease. Again, if you go and discuss it with a surgeon, especially if he's a good expert surgeon, there is nothing non-resectable. Most of those, they are resectable, but that resection, is it complete? Are we doing help for those patients or not? So these controversial issues usually should be handled very comprehensively in a multidisciplinary approach and very good evaluation, baseline evaluation, in order to tailor that treatment accordingly, whether for resection, neoadjuvant, or definitive concurrent chemoradiotherapy. So the resectability is not only in N2 disease, how bulky the disease in N2, have the tumor spread beyond the nodal capsule or not, if there is any multi-station nodal involvement, but there are many other variables that related to the patient, where performance status, comorbidities, lung function, age, make those patients unresectable. If we see for long duration, as we treated those patients with the standard of platinum doublet with concurrent chemoradiotherapy for stage 3 unresectable non-small cell lung cancer, we see the 5-year survival are really very dismal, only 15%, 15 to 20% within the category of stage 3B to 3C, they survive 5 years. And this has been stationary for a few years. So there is really unmet need for this group of patients. If we review the standard of care and we see the radiation and the concurrent chemoradiotherapy, we see the meta-analysis. We had like more than 22 trials, including around 4,000 patients, where they compared sequential concurrent radiation chemotherapy versus radiotherapy alone. There was an absolute benefit of 2.6%, and this was statistically significant. Again, when we compare concurrent chemoradiotherapy versus radiotherapy, the magnitude of absolute benefit was 3.2% and also was statistically significant. When we compare the concurrent chemoradiotherapy versus the sequential, the absolute benefit was 5.7% and was statistically significant in overall survival. There was improvement in progression-free survival. The risk of locoregional progression were much less, but there was no difference in the rate of distant progression. But again, the esophageal toxicity were much higher, but there is no additional acute pulmonary toxicity. So the concurrent chemoradiotherapy was the standard of care after this meta-analysis. What about the dose of radiation? So if we push this dose of radiation higher, do we get a better benefit? The standard dose of radiotherapy is around 60 gray. So if you push it for 74 gray, and this was the study of RTOG 617, it's a phase 3 trials, stage 3 non-small cell lung cancer. Around 544 patients received the standard chemotherapy, carboplatin, paclitaxel weekly, and they were randomized to the dose of 60 gray versus 74 gray, and whether to add additional targeted therapy, cetuximab versus no cetuximab. Now, when you pushed higher the radiotherapy, there was more mortality, so the outcome was poorer. And the major problem from this probably is related to the cardiac toxicity, and there were more toxicity. So the standard of care for dosing with concurrent chemoradiotherapy is 60 gray. Also, there was a secondary analysis for almost 482 patients comparing the 3D conformal technique with IMRT. The outcome, the 2 years overall survival and the distant metastasis-free survival were similar, but the toxicity profile were much favorable with the IMRT. Cetuximab did not add any additional value to the treatments. What about induction therapy for those patients? Induction probably should be used carefully in tumor that probably very difficult to compass the safe radiotherapy with Porter without unacceptable toxicity, or if you are giving it as a neoadjuvant for potentially resectable patient, and then to be followed by either definitive concurrent chemoradiotherapy or subsequent radiotherapy alone, depend on the patient condition. But induction chemotherapy prior to concurrent chemoradiotherapy should not be routinely used because of the toxicity without any survival advantage, and this has been studied in the KLGB trial. What about the consolidation strategy in stage 3 non-resectable colorectal cancer? There was 2 phase 3 trials addressing, the first one addressing docetaxel after concurrent chemoradiotherapy. So 3 cycles of docetaxel was offered to the patient after concurrent chemoradio with platinum etoposide regimen with the 60 gray, and randomized to 3 cycles of docetaxel versus observation. So there was no benefit from disease, from progression-free survival or overall survival, but the toxicity were much higher with the chemotherapy consolidation arm. The second trial, and this is an Asian study, they combined cisplatin, docetaxel 3 cycles as adjuvant after concurrent chemoradiotherapy, and they use 66 gray radiotherapy. Again, you don't see any advantage from progression-free survival or overall survival. So adjuvant treatment after the concurrent chemoradiotherapy is not recommended. What chemotherapy regimen used concurrently with radiation? The most widely used in study was cisplatin etoposide, but we know also weekly carboplatin paclitaxel, and recently carboplatin or cisplatin pemetrexate for patients non-squamous histology. They have the same efficacy with much less toxicity. What about prophylactic cranial irradiation? This is not recommended in routine consideration for stage 3 non-small cell lung cancer because there is no survival advantage, and this was studied in RTOG 214. Almost 356 patients were included in that trials, and they were randomized for prophylactic cranial irradiation 30 gray in 15 fraction. There was reduction in the brain recurrence from 18% to 7.7%, but the 5-year survival were almost similar with 25%. So it is routinely not recommended. What about the immunotherapy in adjuvant setting for those patients after concurrent chemoradiotherapy? The rationale for that mainly because of the synergistic effect between concurrent chemoradiotherapy and the immunotherapy when it's given an adjuvant, which is highlighted in the blue line. If you give concurrent chemoradiotherapy alone or immunotherapy alone, or give a placebo, so the synergistic effect when you integrate these together, and this is in the murine models. And if you see on the other graph on the left side, you see that if you expose this murine model to chemotherapy versus radiation, there is an upregulation in the PD-L1, and this is probably the reason for the synergistic effect when you give first concurrent chemoradiotherapy and then followed by immunotherapy. So most of those patients are upregulated and sensitized to immune therapy. This is the design schema for the Pacific trial. So patients were included locally advanced unresectable stage 3 non-small cell lung cancer. At least they have to receive 2 or more platinum-based chemotherapy concurrently with radiation, and no progression upon completion of the treatment. Their performance status were 0 to 1. 713 patients were randomized. They were stratified according to their age, sex, and smoking history, and the randomization was 2 to 1. The patient were, if they did not progress after the treatment, they can be included or randomized within 6 weeks from completion of the concurrent chemoradiotherapy. And they used Durva 10 milligram, the standard dose, every 2 weeks for a total of 12 months. The primary endpoint was a progression-free survival, and this was a blinded, independent reviewer by RCC criteria and overall survival, and there was several secondary endpoint tested. Just this is to highlight that the progression-free survival, when you use the concurrent chemoradiotherapy, we use it before the starting radiation, but in this study, they used the progression-free survival from the enrollment. So it was within the first 6 weeks after completion of concurrent chemoradiotherapy. So this is why we see the probably the placebo arm have a shorter progression-free survival than the standard. The patient included if they received it concurrent chemoradiotherapy, but for those patients who received adjuvant treatment, they were excluded from the trial because probably most of those patients have a higher rate of pneumonitis and lung toxicity. So only those patients who were excluded, but if the patient had induction followed by concurrent chemoradiotherapy or from upfront concurrent chemoradiotherapy, they were included in that study. If you see the baseline characteristic were well balanced between the two arms, we see around stage 3A around 50%, stage 3B 44%, balanced squamous histology also versus non-squamous 50-50. Most of those, even the smoking history were balanced, male to female, 2/3 of those patients were male, and age were balanced. If you see those patients also from adjuvant, only less than 1% they received adjuvant chemotherapy. Induction chemotherapy, 1/4 of those patients receive it, while the rest receive concurrent, all of them concurrent chemoradiotherapy. If we go for the PD-L1, also status were well balanced between the two arms. Also, they included patients with EGFR mutation. You see that around 6% in each arm, they were EGFR mutant population. And unknown population around 1/4. So those patients were not tested for EGFR mutation. This is the primary endpoint, which is published in the New England in 2018. It showed a significant improvement in progression-free survival. So it's almost triple, 17.2 months versus 5.6 months. As I mentioned, 5.6 months because they started after the concurrent chemoradiotherapy. So if you include it, then probably it will be like 8 to 10 months, which is the standard duration of progression-free survival for those patients. If we take the subgroup analysis for those patients, we see the PD-L1 status, whether more than 25 or less than 25, were similar, although those with higher PD-L1, they are has higher chance to respond. Unknown is the same. So all the subgroup analysis, they get benefit. Probably the mutant population, because they are small percentage, 6%. Again, there is in favor, but it is a wider crossing the line. If we take the overall survival, again, there was a trend for improvement and the hazard ratio of 68. At that time, the survival was not mature because the median survival was not reached with the Durva. This is the update in the last ESMO. It's showing a sustained improvement in progression-free survival, and you see the plateauing of that line after the 3 years. If we take the overall survival, it's mature, 47-month median survival with the investigational arm versus 29, and the separation continue the same after a longer follow-up. Again, the subgroup analysis, and if you see that they took initially more or less than 25, which is a pre-planned stratification, but an exploratory post-hoc analysis, they took further categories of more than 1, less than 1, and between 1 to 24. Again, it shows the higher the percentage, probably the higher the chance to respond, but all of them, they respond. Probably those who are less than 1, slightly they are crossing the line, but the trend to respond also is there. Again, with the EGFR positive, you see the same behavior. Here, just also to mention that those patients probably with the platinum, the overall survival were more significant than the carboplatin population. And whether the dose of less than 60 versus more than 66, they are all have the same progression-free survival and overall survival. If we take other secondary endpoint, and this is objective response, it is really significant with almost doubled from 16 to 28. And mainly most of those are partial response, which is increased from 15% to 27%. Now, time to distant metastasis has been significantly improved across different sites. So lung, lymph node, and even brain has been improved from 11% to 6%. So immune therapy, it improved all the distant site metastasis. What about the safety? There was no unexpected toxicity from the immune therapy. If you see that grade 3 and 4 toxicity is almost close to each other, mainly the pneumonitis were slightly higher, 24% to 33%. Discontinuations from 10 to 15%. So comparing with the placebo is not that much higher percentage for those patients. Again, if you see that the patient who are still in the treatment, 42% in the Durva arm versus 30%, and the majority for those who discontinue the treatment in the Durva were secondary to the progression. As we mentioned, only 15% secondary to the toxicity of the treatment. What about patient-reported outcome with the Durva after consideration? This is the baseline characteristic. If you see that those patients with the key symptoms and physical function and the global status, you see that cough, dyspnea, chest pain, fatigue, and appetite at the baseline, as well as physical function and global function at the baseline. And you see that all of those are maintained during the treatment, so there was no extra toxicity from adding Durva for adjuvant treatment for the first 1 year. So the summary of the Pacific was Durva for the first time demonstrated statistically significant improvement in progression-free survival versus the placebo, and the median improvement was almost 11 months at the planned interim analysis as well as in the updated one. Progression-free survival with Durva was observed across all the pre-specified subgroup. Durvalumab demonstrated a clinically meaningful overall response rate, as we mentioned, from 16 to 28%. Patients receiving Durva had a lower incidence of new lesions, distant metastasis, and the safety profile of Durva was as expected with all other immunotherapy. If you see the NCCN guidelines, again, for most of those who receive definitive concurrent chemoradiotherapy, Durva, you see it as a category 1 in the adjuvant setting in all those patients, whether it's N2 or N3 disease. Now, the question, as probably taken again from far from Dr. Turki, you see the question is still what we will do with those with EGFR mutant patients. The data, although the numbers are small, but there are a trend towards improvement with the immunotherapy. We don't have data for stage 3 unresectable patient with osimertinib, but with very strong data emerging from the early stage 1 to 3 disease resectable are very encouraging. But again, as he mentioned, the survival is still questionable, and we don't know the clinical scenario whether to add this anti-EGFR therapy to immunotherapy or to replace it. So currently the standard of care is to give all those patients, whether you test it or not, the immune therapy, because this is the only solid data for those patients. We need probably further data in this category for the anti-EGFR therapy, whether it's in combination or a single agent. And I should not forget the great effort, and I really need to congratulate Dr. Jazia for establishing really a guidelines for those very complicated and really need a multidisciplinary. So he established a guidelines and he publishes in very respected journals. So thank you for your great efforts and joining the efforts from different country. So thank you, Dr. Jazia. And by this, I finish my presentation, and thank you very much.
Thank you, Dr. Jafar. We move to the next speaker. And this will be Dr.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Ahmed Abdelwaris, my professor. Now it's my pleasure to chair this excellent scientific conference, and I would like to thank the scientific committee, Professor Abdelaziz and Professor Mirvat, for inviting me. Actually, I enjoyed yesterday by high level of scientific content and discussion. And now it's my pleasure to introduce Professor Abdelaziz Al-Hamad. He is consultant of radiation oncology in Prince Sultan Medical City. And he is also the director of oncology department and the chairman of Oncology Care Conference this year. Dr. Abdelaziz will talk about very hot topics in non-small cell lung cancer post-operative radiotherapy. There is no hope for more benefit or not? Dr. Abdelaziz.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين من بعد. I'd like to thank Dr. Samir for this nice presentation. However, I'm not a professor. I don't hold any academic title. I'm just consultant for radiation oncology.
I said consultant. Professor. You will known to us, Dr. Abdelaziz.
I hope this screen is clear for everyone.
Yes, we can see it.
Okay. So I'd like to special thank for Dr. Mirvat, who always try to put me in the tight corner in this confusing presentations about the NCCLP or radiation. This is mainly for the N2 disease. Just an introduction about the lung staging. I'm not going through it. Just to a reminder of the TNM staging. The area which more preferably peripheral lungs cancers, usually more resectable. When we go more central, stage 2A, stage 2B, and usually this is the area where we talk about with the N2 involvement. For the investigation of staging workup, historically for N2 level, we used to prefer to go with the mediastinoscopy. However, for level 4, 5, and 6, we use mediastinoscopy versus Chamberlain procedure. Now more income questionable about the PET-CT scan, and the value of the PET-CT scan is a kind of replacing for this two procedures. For early stage lung cancer, we talk about stage T1, T2, N0, or N1. It's the role of radiotherapy very clear. If the patient is operable and he underwent complete resection, there is no role for RT. If there is incomplete resection or positive margin or found to be upstaging, then we afford the adjuvant radiotherapy. For non-operable, there is radical radiotherapy with or without chemotherapy. The trial for that, maybe the major one is sequencing of the postoperative radiotherapy and chemotherapy for local advanced or incomplete resection by Dr. Francis, who showed that when achieving R0 status for N0 or N1 diseases, there is no benefit of giving radiotherapy. It's only when you have R1 or 2 or upstaging like N2 status. For locally advanced lung cancer, again, talk about T0 to 3, but N2, M0. When we talk about the complete resection, that we have two options: adjuvant radiotherapy plus minus chemotherapy, versus now the new option is observation with or without chemotherapy. If you decided to go for the evidence for the adjuvant radiotherapy, I think the paper from Bradley, it is a phase 2 trial of postoperative adjuvant paclitaxel, carboplatin, and thoracic irradiation for stage 2 and stage 3A non-small cell lung cancer, which showed that it was one single arm trial. However, they tried to compare the result or the outcome with the ECOG. Here we go just briefly about the type of the surgery. It's almost like every other things: lobectomy, sleeve lobectomy, bile lobectomy, and rarely use pneumonectomy. The status of lymph node dissection, sampling, like this. And the curve is the upper curve is the one from the trial. It is showed the outcome is about 60% within 5 years. This is the RTOG versus the data from ECOG, where there is no radiation being given, and there is like increasement about the median survival is about 56.3 months for the adjuvant radiotherapy versus 33.7. That's where they took historically the role of adjuvant radiotherapy for N2 diseases. Recently in ESMO, they presented the LungArt phase 3 trials. It is a European trial, mainly in France and UK, and they want to compare the standard of care conformal postoperative radiotherapy 54 gray in 5.5 weeks versus the control arm, which is observation or further chemotherapy. The primary endpoint was disease-free survival. The secondary endpoint was overall survival, pattern of relapse and local failure, and second cancer and treatment-related toxicities. So in the beginning, and then when they designed the trial, they thought that they need 700 patients to show 10% improvement of 3 years disease-free survival. However, in 2017, in the midterm, they decided to go only for reduce the number of the patients up to 500 to show 12% difference in the 3 years disease-free survival. Bilateral test, the power of 80%, alpha is 5%, analysis with median follow-up of 4 years. Hypothesis, and they decided 42% 3 years disease-free survival for the post-operative radiotherapy versus 30% in the control arm with hazard ratio 0.72. They used the Cox model for analysis and for intention to treat. The data cutoff was done on 31st of May 2019 when they have 296 patients in event. They recruited at that time 500 patients from August 2007 till till July 2018. They recruit 249 patients in the control arm versus 252 patients. Mainly the patients were in France, 85, while the 10% in the United Kingdom. In the small table here, you see the patient distribution. Belgium had 1, Germany has 15, Switzerland has 8 patients. Out of the postoperative radiotherapy arm, 11 patients was not included because they didn't receive either radiation or the full dose of radiation, while the control arm 3 patients was excluded due to there was no follow-up for them. So they end up with 487 patient analysis for safety, with median follow-up is 4.8 years. As you see, the patient characteristic demography almost similar on both arms. The gender, male, which is usually due to the positive or heavy smoker, 66% in both arms. The age is median is about 61 both arms. Smoking status 90 versus 92. The TNM staging is no N2 versus single N2 or multiple is almost similar between two arms. Histology, adeno versus squamous cell carcinoma, as again, it's almost similar, 76 versus 20 in the control, while it's 70 versus 23. The adjuvant chemotherapy, either pre-op or post-op, is 96 in control and 96 in post-operative therapy, while the pre-op chemotherapy alone is 12% in the first arm control and 14% in the post-operative radiotherapy. Pre-treatment PET-CT scan, they 90% in the control arm, they got it, versus in the post-operative therapy 92. However, there was no comment in the trial about what's the how to identify the positive PET-CT scan in the size and SUV. Again, the TNM staging is, as you see in the schedule, is almost similar on both arms. The type of surgery, lobectomy, it was 81% in the first arm versus the post-operative therapy 78. By lobectomy is 7% versus 8%. Pneumonectomy 10% in the control arm, while it was 12 in the post-operative radiotherapy. Subpleural resections 2% in both arms. The largest the size of the tumor, the largest size is about 3.4 centimeters versus 3.3 centimeters. The down staging is similar, is again similar between the two arms, as you can see in this table. Getting to the radiotherapy information, the thoracic radiation, 241 patients, 96 out of all the patients. Early termination, 7 patients, 3 progression and 2 toxicities. Total received dose is in gray is 54 gray, both arms. The lung V20 is 23% in both arms. Median lung volume is median lung dose is 12.7 gray. The median heart dose is 13.4 gray, and the heart 53 is 15%. The post-op radiotherapy technique, mainly it is the 3D conformal, is almost 90%. IMRT is 11%, and this is usually not the standard of care. IMRT, now we use what we call it the gating, which is more useful. But the IMRT in the lung is used not really adapted in most of the advanced centers. 26 3 patients was not really specified, but most likely they are they've been used the 3D conformal technique. Coming to disease, the primary endpoint, as you see, the two curves almost overlapping each other. For the median disease-free survival for the control was 22.8 versus in the post-operative therapy is 30.5, not significantly difference. The 3 years disease-free survival was higher in the control, higher in the post-operative radiotherapy, 47.1 versus 43.8%. Again, it was not significantly high between the difference. Coming to the disease-free survival, all the events, mediastinal relapse was higher in the control group, 70%, versus 70 patients, which is 46.1%, versus 25% in the post-operative therapy, which is expected. The brain metastasis and other metastasis was higher in the post-operative radiotherapy. The death rate was 14.6 in the post-operative radiotherapy versus control. Again, there was no specification. Is it related to the diseases, progression, or something else? The disease-free survival, the intention to treat based on the institutional, the site, and adjuvant chemotherapy, and N2 and the histology. As you can see here, between it's almost for the issue or for the as a variation for treatment. More the patient has the size or the N2, usually the intent to treat was reduced. the pre-chemotherapy. And with co-down for the pre-treatment PET-CT scan was encouraged for every center has it or has the access to it, versus less patient who couldn't get the PET-CT scan. Coming to the secondary endpoint, overall survival, again, there is no difference between the two curves, almost overlapping over each other. And the control arm is 68.5 versus 66.5% in the post-operative radiotherapy, not significantly. Causes of death, progression of the or recurrence was 86.1 in the control arm versus almost 70% in the post-operative radiotherapy. Cardiopulmonary toxicity, which most likely related to the treatment, 60.2 in the post-operative radiotherapy versus 2% in the control arm. Second primary is 1% in the control arm versus 5.1%. Related toxicity 0% in the control arm versus 3% in the post-operative radiotherapy. Other issues is almost 11% the control arm versus 6.1% in the post-operative radiotherapy. In general toxicity was we go directly for the grade 3 and 4 was almost kind of versus 23 in the post-operative radiotherapy. Early toxicity grade 3 to 4 is higher in the post-operative radiotherapy, is 11.6 versus 7.7. Late grade 3 to 4 toxicity was again higher in the post-operative radiotherapy, 14.6 versus 8.9. Going to the higher grade 5 is early toxicity was non-recordable in the control arm, 0% versus 1.2% in post-operative radiotherapy. In the late toxicity, grade 5 is 0.8% in the control arm versus 1.2 in the post-operative radiotherapy. As the comment, mainly the late toxicity was in the control arm was depression or respiratory failure, versus acute pulmonary edema or respiratory failure or death unspecified. Second, cancers, at least other late cardiac pulmonary toxicity, grade 3 to 4 in control arm was 4.9 versus almost the double, 10.8% in the post-operative radiotherapy. Talking about the second cancer, mainly is about 7.2% in the control arm versus 11.1. 22% of the cancer, the second cancer in the control arm was lung, while it was almost 40% in the post-operative radiotherapy. Again, there was no correlation between the field of radiation and the duration and the dose, and just that's which this is expected. And also no information about the patient if they stop or quit smoking during the radiotherapy or the treatment. The difference between for the favor of post-operative radiotherapy is the progression, recurrence, mainly the mediastinum. For everything else, it was favorable for the observation of radiotherapy. Talk about cardiopulmonary, secondary primary, and treatment-related toxicity. So the conclusion for the trial, the lung RT is the first European randomized trial evaluation. The post-operative radiotherapy after complete resection, patients selected predominantly with PET-CT scan and having received neoadjuvant chemotherapy. 3 years disease-free survival, 43% in the control arm versus 47.1 in the post-operative radiotherapy. It was expected than what they planned in the beginning. The mediastinal labs was reduced 46 in the control arm versus 25% in post-operative radiotherapy. Post-operative radiotherapy was associated with non-statistically significant 15% increase in disease-free survival among stage 3A or N2 patients. Safety issue, more toxicity observed in the post-operative radiotherapy, especially cardiopulmonary that need further explorer. Conformal post-operative radiotherapy cannot be recommended as standard of care in all completely resected stage 3A and 2 patients. Further analysis are planned for. Just before concluding, a question to be answered is the pre-op diagnostic and 2 for neoadjuvant chemotherapy. What's the standard of care in countries like Saudi Arabia? We have discrepancy. Centers have PET-CT scan and more advanced imaging technology versus not. Availability of surgeon to perform mediastinoscopy or Chamberlain procedure. The value of PET-CT scan and what we said is like to reach a level of care or standardizing the PET-CT scan reading. Correlation between the diagnostic imaging and sampling during the OR. We know that sometimes we do PET-CT scan, but the thoracic surgeon end up doing sampling from different stations. So we really don't know if the thoracic surgeon or the interventional radiologist go after the things we suspect of disease on it. Feedback from the thoracic surgeon themselves. The conclusion for non-small cell lung cancer post-operative therapy is controversial and now more controversial. I believe for centers with less imaging availability, mainly the PET-CT scan, less expert in the nuclear imaging, and limited or less expert thoracic surgeon, interventional radiologist to perform good sampling. I think post-operative radiotherapy will be more safe to carry on and to continue. For centers with high technology or imaging and more expert in nuclear medicine or aggressive surgical intervention, post-operative therapy could be omitted. Thank you.
Thank you, Dr. Ahmed, for your excellent presentation for a controversial subject. Your presentation was excellent, and I think it brings more questions than answers. This will go with our program, and it is my pleasure and honor to introduce Professor Rabab Ghaffar. She is a dear colleague of mine. She is well known for everybody in the region and in Egypt, as well as in the Gulf area. A pioneer in thoracic oncology, a founder of thoracic oncology group in the Cairo University, NCI. She is also a member of the ERTC group since long time, shared in many randomized controlled trials that has impact on our plans and vision of how to treat lung cancer. Dr. Rabab Ghaffar believed in lung cancer while everybody was just thinking that it is incurable disease. And there's also a long list of students and the juniors that have a lot of benefit from her. Without further delay, we'll have Dr. Rabab Ghaffar enlighten us about the role of chemotherapy and drugs in ALK rearrangement fusion gene of non-small cell lung cancer. Dr. Rabab. So we'll have her video loaded now, and I hope this will be soon.
To this important meeting of BOCC in Saudi Arabia. And my name is Rabab Ghaffar. I'm working as a professor of medical oncology at NCI Cairo University. My talk will be on non-small cell lung cancer ALK rearrangement management in the year 2020. These are my disclosures, and the agenda will be introduction, first generation ALK inhibitor, mechanism of resistance, second generation drugs such as alectinib, ceritinib, bricatinib, and incertinib, third generation drugs such as lorlatinib and repotrectinib, best sequence of ALK inhibitors, and my conclusion. So to start with, EML-ALK fusion was identified in non-small cell lung cancer in the year 2007 with inversion within the chromosome 2, resulting in fusion of EML4 and ALK gene. So this ligand is independent activation and the transforming activity. And this ALK gene rearrangement in non-small cell lung cancer was found to be in 3 to 7% of non-small cell lung cancer, typically in adenocarcinoma histology, in younger patients never or light smokers, and there are many variants to be described in lung cancer. The diagnosis of ALK gene rearrangement was first by FISH, the break apart. We have also PCR, but the most common one used is the immunohistochemistry that is well approved now to diagnose the ALK rearrangement. This slide shows the treatment landscape in ALK-positive non-small cell lung cancer. As I said, it was identified in the year 2007 as a driver for non-small cell lung cancer, and very rapidly there was an approval of a drug known as crizotinib. This was the first drug to be used as ALK inhibitor in the year 2011. This was followed by ceritinib in the year 2014, followed by brigatinib in the year 2017, and also alectinib in the year 2016, lorlatinib in the year 2018. So we start with the first generation, and there is only one drug approved, which is the crizotinib. This slide shows the summary of the ALK-positive trials for crizotinib in non-small cell lung cancer. It was first used as any line of therapy, and then used as a second line and beyond, and after this as a second line, and lastly as a first line. So if you look to those profiles starting from 1001 to 1014, which is the first one therapy, you will find that the response rate was ranging between 60 and 74%, the progression-free survival between 8 and 11 months, and the overall survival at 1 year is 70 to 84% in profile 1014, and this was the best. Again, if you look to crizotinib versus chemotherapy, it's evident from the profile 1014 that crizotinib was PFS 10.9, that is 11 months, versus for chemotherapy only 7 months. And this was confirmed by another profile study, which is profile 1029, that was published in the year 2018, and this was again crizotinib progression-free survival. The median was 11 months versus chemotherapy around 7 months. So this study was confirming the first-line therapy with crizotinib in 1014. The updated results from 1014 study, which is the first-line therapy with crizotinib versus chemotherapy, proved that, again, here, the median overall survival for crizotinib was not reached, and for chemotherapy it was 47.5, and I believe this was because of the crossover of the drug. So, what are the mechanisms of resistance to crizotinib? We perfectly know that there are many mechanisms of the resistance acquired after using a crizotinib. It may change to MET, it will change to even small cell lung cancer, it may change to many other ALK mutations. But what is important in the resistance is that after crizotinib, there is cumulative development of brain metastasis, and the kinase domain resistant mutation mainly in ALK is the G1202R. So it was a must to find other drugs that work as anti-ALK therapy for the treatment of those cases. And we have second generation ALK inhibitors now. We have alectinib, we have ceritinib, brigatinib, and ensartinib. So the first one is alectinib. And alectinib was first used for cases that had received previously chemotherapy, platinum-based doublet, and also they have received crizotinib. And in this case, the cumulative incidence of progression at 6 months was for alectinib only 11%, but for chemotherapy it was 48%. Highly statistical difference between both. And if you go to the clinical efficacy of alectinib as second generation and all the other drugs like ceritinib or brigatinib, after using crizotinib, so we have crizotinib resistant patients, the objective response rate of ceritinib ranged between 38 and 56%, the alectinib 48 and 50%, and brigatinib was between 50 and 70%. If you go to the progression-free survival for ceritinib, it was around 6 to 7 months. For alectinib, 8 to 9 months, and brigatinib, there were many studies proving that it's around 12 months. What about the intracranial response rate, which is very important for second generation ALK inhibitors in the cases having resistance, being resistant to crizotinib? So the CNS activity of second generation ALK inhibitors in crizotinib resistant patients prove that the intracranial objective response rate was for ceritinib 45%, alectinib 64%, and brigatinib ranging between 53 and 67%. Highly positive. What about the first line therapy? We start with the first line alectinib versus crizotinib. Actually, we're having ALEX studies, and we have the J-ALEX and we have the ALEX study. Now, final analysis of the ALEX study using alectinib versus crizotinib proved that the median progression-free survival for alectinib was not reached, but for crizotinib it was 11 months, which is very highly significant difference. And if you go to the final analysis, the median progression-free survival was 35 months, and for crizotinib 11 months, with a very high p-value between them. Now, what about brain metastasis, which we care of? The brain metastasis for alectinib versus crizotinib, wherever you have baseline brain metastasis or you do not have baseline brain metastasis, the hazard ratio is 0.37 or 0.46. And in both cases, it's very highly significant p-value between alectinib and crizotinib. And then another study, which is Alicia study from the Asian part of the world. And this is a phase 3 trial in Asian patients, seeing the progression-free survival. And progression-free survival here also was very significant difference between both with median progression-free survival, not reached for alectinib versus crizotinib 11 months, with a hazard ratio of 0.2 and a very high significant value. The second drug of the second generation ALK inhibitors is ceritinib. And for ceritinib, progression-free survival, ceritinib was done versus chemotherapy the way crizotinib was done versus chemotherapy. And if you look to the differences in ASCENT-4 study, ceritinib, the median progression-free survival was about 17 months versus chemotherapy only 8 months. And for crizotinib, it was 11 months for versus chemotherapy 7 months. So here also found that ceritinib may be better than crizotinib. The third drug in the second generation is brigatinib. And here the study is also brigatinib versus crizotinib. And the progression-free survival in this curve shows that for brigatinib, the median progression-free survival was still not reached, but for crizotinib, it was like 9 months. And if you come to the 1-year progression-free survival for brigatinib, it was 67% versus only 43% for crizotinib, highly significant difference with a hazard ratio 0.49. What about intracranial progression-free survival? Intracranial progression-free survival for brigatinib versus crizotinib was found to be highly significant when you have brain metastasis at baseline with a hazard ratio 0.27 and a very high p-value difference. Again, the response rate in patients with brain metastasis for brigatinib and the alectinib versus crizotinib. Here you see in this slide the ALTA trial using brigatinib and versus crizotinib, and the ALEX study using alectinib versus crizotinib. And here you see the response rate for brigatinib 78% versus crizotinib 29%, and alectinib 81% versus crizotinib 50%, with a hazard ratio for brigatinib 0.27 and a hazard ratio for alectinib 0.4. The first line alectinib versus crizotinib and brigatinib versus crizotinib in general head-to-head trials of TKI, we have for alectinib the J-ALEX and the ALEX studies, and we have for brigatinib the ALTA study. And for J-ALEX, the alectinib versus crizotinib, we have a PFS that was not reached versus 10 in crizotinib, and the objective response rate was 91.6% versus 78.9%. If you come to the ALEX study, again using alectinib versus crizotinib, the progression-free survival was 25.7 months versus 10.4 months. And the objective response rate was 82.9% versus 75.5%. While for brigatinib, the progression-free survival again was not reached versus crizotinib 9.6, and the objective response is 76% versus 73% for crizotinib. Lastly, the ensartinib, which is the last drug in the second generation. It is a new drug just presented recently, and it's not yet approved. But ensartinib versus chemotherapy, the trial have shown that the median progression-free survival for ensartinib was about 26 months versus only 13 months for crizotinib. High value, a p-value was very significant, and the hazard ratio was 0.5. To summarize, the median progression-free survival in first and second generation ALK inhibitors for TKI-naive non-small cell lung cancer, you see here the profile 1014, which is crizotinib versus chemotherapy, and the median progression-free survival was around 11 months, with the hazard ratio 0.45. For ceritinib, the median progression-free survival was 16.6, and the difference hazard ratio was 0.5. For alectinib, it was not reached, and the hazard ratio was 0.34, or in the other ALEX study, it was 26 or maybe 35 versus crizotinib, and the hazard ratio was 0.5. Again, brigatinib versus crizotinib, the PFS was not reached for brigatinib, and the hazard ratio was 0.49. Finally, ensartinib, we have like median progression-free survival 27 months, and hazard ratio is not available. Now, what about the third generation ALK inhibitors? We have lorlatinib, which is well approved now, and we have repotrectinib. Lorlatinib is a third generation potent, selective, CNS penetrant ALK TKI, and also ROS1. And there are many studies using lorlatinib now, and this is the design and the patient population of the studies. You use it as second line, you use it after crizotinib, you use it as the non-crizotinib ALK-TKI. Many studies will use it after ALK-TKI and then chemotherapy and then lorlatinib. So the design changes and lorlatinib now is used in many trials. Lorlatinib after second generation ALK-TKI, this shows the results. ALK resistance mutations in tumor tissue predict the response to lorlatinib after second generation ALK-TKI. So if you have used the ALK generation second TKI and then you use lorlatinib and you have ALK positive, you will have a median progression-free survival of around 11 months. But if it is ALK negative, so you median progression-free survival will be around 5.4 months. And the study, well approved for lorlatinib, is known as CROWN study. What is CROWN study? It is a phase 3 randomized open label study for lorlatinib versus crizotinib as a first line in ALK positive non-small cell lung cancer. And you see here we differentiate between lorlatinib and crizotinib. And the result of PFS for lorlatinib versus crizotinib, as you see in this slide for the CROWN trial, have proved that the median progression-free survival for lorlatinib was not reached, but for crizotinib was 9.3 with a hazard ratio of 0.28 and a very high positive p-value. What about the intracranial response rate of lorlatinib versus crizotinib? In cases of brain metastasis, we have the responders for intracranial objective response rate for lorlatinib was 66% versus crizotinib only 20%. And again, the CR was 61% versus only 15%. If you have a measurable brain metastasis at baseline, this response for intracranial response was for lorlatinib 82% versus crizotinib only 23%, and the CR was 71% for lorlatinib versus only 8% for crizotinib, proving that this is a very, very effective drug to be used for metastasis in the brain. Not only that, but the intracranial time to progression of lorlatinib versus crizotinib again proves that this is the median time to CNS progression for lorlatinib was not achieved, but for crizotinib it was around 16.6 months with a hazard ratio of 0.07 and a very high p-value between lorlatinib and crizotinib with regard to the intracranial time to progression. Coming to the overall survival of lorlatinib versus crizotinib, you see in this slide that the median overall survival was not reached in both, whether lorlatinib or crizotinib, so we cannot say anything, and the hazard ratio is 0.72 for the present time. It is still being issued. So it is important to have a baseline brain scan for each patient of having ALK positive patient. So here the study in ALEX using alectinib versus crizotinib, again the progression-free survival is 25.4 months versus only 7.4, and the progression-free survival if you do not have brain metastasis was 39 months for alectinib versus 15 months for crizotinib. Again, very significant value between them. If you go to brigatinib, the progression-free survival if you have brain metastasis was not reached, and crizotinib it was 5.9 months. If you go to no brain metastasis, there was 29.4 versus 12.9 with hazard ratio of 0.57. Again, if you go to the CROWN study of lorlatinib, you will find that the PFS had a hazard ratio of 0.2, and if there is no metastasis, it was 0.8. 32. So all second generation or third generation were very important to have brain scan and compare the two crizotinib. All of them were very important. The last one in the third generation was repotrectinib, and repotrectinib is a very new drug. This is a phase 1 study of next generation ALK-ROS1 TRK inhibitor, which is repotrectinib, in patients with advanced ALK or ROS or TRK plus in cancer of the lung. And you see here that it may be a significant difference between this third generation and the first one, but it's still image. The side effects of next generation ALK-ROS inhibitors is present on this slide. And you see that the second generation and the third generation ALK inhibitors have some differences in the side effects. So for alectinib, we have anemia, myalgia, raised bilirubin, weight loss, musculoskeletal pain, and photosensitivity reaction. For begatinib, we have a raised creatine kinase, cough, hypertension, raised lipase, and what's important is pneumonitis. For ensartinib, it's still not known about it, but there is rash, pruritus, and pyrexia. For lorlatinib, we have hypercholesteremia, hypertriglyceridemia, weight increase, peripheral neuropathy, cognitive effects. And for entrectinib, no randomized data, but we know that there is fatigue, constipation, dysphagia, edema, dizziness, and diseases. Elevated transaminases are very common in all ALK TKIs and often difficult to separate the toxicities from clinically significant toxicities. So these are the side effects for all the TKI that we have. So when you treat your patient, you have to treat the patient according to his status. And very important to know that this is the impact of subsequent therapy on overall survival. You have ALK TKI versus treatment other than ALK TKI. The best is to receive TKI followed by ALK TKI again, like crizotinib followed by any ALK TKI. It's not wise at all to use no crizotinib or other than ALK TKI, or crizotinib followed by any follow-up other than ALK TKI. You lose the effect of your ALK TKI. And if you use chemotherapy, you use ALK TKI after it. This is the difference between them, and the best is to receive first crizotinib or any ALK TKI followed by any ALK TKI. Accordingly, we have this algorithm for ALK-positive non-small cell lung cancer. The first generation crizotinib, if there is progressive disease, we go to second generation. The second generation, we have the ceritinib, alectinib, brigatinib, and ensartinib. And if there is progressive disease, we have to go to third generation. And if there is third generation problem, we now do not know what to know. But if there is a biopsy from the lung lesion and you have a mutation that will respond to any of the prior ALK TKI, you can use it again. So is there a best next generation ALK inhibitor to choose from the first line and the second line and the third line? Again, ceritinib, the study that is well known to be compared to chemotherapy, ASCEND-4, the response rate was 72.5% to the PFS 16.6, CNS metastasis at baseline 52%, and the intracranial response 73%. Again, for alectinib, if you compare all of them, ceritinib, alectinib, brigatinib, ensartinib, lorlatinib, I believe that alectinib as a second generation has the best response and also PFS was 26 months. CNS effect was 38.42, and the intracranial response H 1% is a very good drug to be used. I know that maybe insertinib is not yet very well approved and it's still premature, but we know also that progression-free survival for crizotinib is ranging between 9 and 12.7 months with an objective response rate 58 to 75% and intracranial response rate of 21 to 50%. So what do we adjust as the best sequence? Profile 1014, send 3 crizotinib followed by seritinib will give you a 11 month plus 6 months, that is 17 months. Ascent 4, seritinib is 16.6 months. Profile 1014 crizotinib followed by brigatinib is 11 plus 13 months, that is 24. Profile 1014 followed by alectinib, 11 plus 10 months is 21 months. But if you look, you see Alex study and start with alectinib from the beginning, you will reach about 26 months progression-free survival as I mentioned. So what to give after this second generation ALK inhibitor that you have chosen? We have the third generation, as we said, lorlatinib, and lorlatinib has become a standard therapy after second generation TKI, as you see from this slide, so improving the survival of the patients. So will the choice of first-line ALK inhibitor impact on spectrum and type-resistant mutations and mechanism? Because you have different mutations and mechanism resistance between using crizotinib and using seritinib and using alectinib, etc. Will this change your way of treatment of the patient? Studies have been ongoing for that and planned and ongoing for ALK plus non-small cell lung cancer. And you see that according to the genotype, they use either lorlatinib, seritinib, or lorlatinib, alectinib, or lorlatinib, crizotinib, and others. And all these are under investigations with the phase 4 study, second line lorlatinib, post second generation, and second line post crizotinib, and EORTC study, and adjuvant trial, which is alectinib, this is ALINA study. Ongoing drug development, many studies are now searching for immune checkpoint inhibitors with ALK positive cases, VEGFR inhibitors with ALK positive cases, chemotherapy with ALK TKI positive cases, targeted therapy other than ALK with ALK positive cases. All these are under trials and immature studies actually. In conclusion, we go to NCCN guidelines, and this is the last version of NCCN guidelines, proving that if you have ALK rearrangement positive, and you discover it to first-line systemic therapy, you have to use an ALK therapy, and the preferred one was alectinib with category 1. Yes, you can use picatinib, you can use seritinib, you can use even crizotinib, no problem. And for ALK rearrangement, where you have treated by chemotherapy first, you can wait until you do the reevaluation of your patient, or you can shift to alectinib as preferred line of therapy, or brigatinib or seritinib, or again crizotinib. Now, what about if progression on alectinib or brigatinib or seritinib? I mean, second generation ALK inhibitors. If the case is asymptomatic, you can use local treatment together with continuation of alectinib or brigatinib or seritinib. And if it is in the brain, again, use local therapy and continue the use of alectinib, brigatinib, or seritinib. But if you have a systemic problem, isolated lesion, again, you use local and continue alectinib, brigatinib, or seritinib. But if you have multiple lesions, you have to shift to another ALK inhibitor, which is up till now lorlatinib, or to shift to another systemic treatment. Finally, if you have the progression on crizotinib, again, if you have it asymptomatic, you go with local treatment and continue crizotinib, or shift to alectinib, brigatinib, or ceritinib. If you have symptomatic in the brain, you use local treatment and continue your treatment, or shift to alectinib, brigatinib, or ceritinib. If you have a systemic treatment, you isolated lesion, you use local treatment together, and you continue crizotinib. Or if you have multiple lesions, you have to shift to alectinib, brigatinib, or ceritinib, or another systemic form of therapy. Finally, I would like to thank you very much and wish you a very fruitful meeting, and thank you very much.
I would like to thank Dr. Prof. Rabab Jafar for this nice comprehensive presentation, and we'll move on to the next speaker. Please try to write your questions, answer in the QA box. It's my pleasure to introduce Dr. Ahmed Al-Lehebi, who is a consultant medical oncologist at King Faisal Specialist Hospital Research Center in Jeddah, and he is an active Saudi Lung Cancer Association member, working with us on different projects. Thank you, Dr. Ahmed, for being part of the team. Dr. Ahmed will be presenting the IO combination upfront debate. Dr. Ahmed, the stage is yours.
Thank you very much, Professor Jazzy, for the kind words. And I really would like to extend my gratitude and my appreciation to the organizing committee. And special thanks to Dr. Mirbat Mahrous for the kind invitation to this meeting, as well as to Dr. Abdelaziz Al-Hamid. So without any further ado, so my talk basically is going to be about the dual IO combination upfront, and it's going to be a debate. So I have to come up with some plans and some points to kind of twist your mind towards the dual combination being such a good option, presumably for the future. So the main objectives of the talk is to identify the new studies in the management of metastatic non-small cell lung cancer, and to identify new potential IO drugs for the treatment of metastatic non-small cell lung cancer, and to recognize the potential role of dual IO therapy, and to identify the key differences in favor of IO alone versus dual in combination with chemotherapy or vice versa. So these are the main studies that we'll be talking about, which will be Checkmate 227, Checkmate 9LA, and Mystic study. And we all know that the Mystic study was a negative study, but I have to talk about it because it's part of the dual IO combination. So first of all, we're going to talk about the Checkmate 227, and we already know that the Checkmate 227 looked at nivolumab plus ipilimumab, and the main population that they enrolled were metastatic non-small cell lung cancer, both squam and non-squam, and they were, as we said, stage 4 recurrent disease, no prior systemic therapy given, no drivers mutation were allowed, no untreated CNS metastases with an ECOG of 0 to 1, and they were stratified according to histology. There were two main groups, with the part 1A group basically being PD-L1 expression of more than equal 1%. And in that group, there were about 1,100 patients. And in the second group, it was a PD-L1 less than 1%. So they were all randomized 1:1:1. In the first group with a PD-L1 more than 1%, it was Nivo plus Epi versus chemo versus Nivo. And in the second group, it was Nivo plus Epi versus chemo versus Nivo plus chemo. And the primary endpoints that they looked at basically were PFS in high tumor mutation burden patients, and overall survival in the PD-L1 population of more than equal 1%. So these are the baseline characteristics. I'm not going to go into depth into it, basically, but they all are well balanced between both groups, as we can all see here. And this is a very important slide. I think that in the Checkmate 227, it defines the role of dual IO, basically. And you can see here the 3-year overall survival was in favor of Nivo plus Epi versus chemotherapy, especially in PD-L1 more than equal 1%. But you can see here initially, like at the 6 months mark, there's an initial dipping of the curve. When that initial dipping was in favor of chemotherapy, which is the gray line here, as opposed to the brown line, which represents nivo plus epi. And this reflects that the response rate is not actually as good when it comes to if you want to treat patients who, let's say, have a visceral crisis and you want to control the disease early on. However, the median overall survival in PD-L1 more than equal 1% was 17.1 months versus 14.9 with a hazard ratio of 0.79. And when they added in the nivolumab alone, again, there was significant benefit, about 15.7 with a hazard ratio of 0.90, but still that's in the PD-L1 of more than equal 1%. When it comes to the PD-L1 less than 1%, this is where the CheckMate 227 gained its reputation and gained basically its kind of advantage in this population of metastatic non-small cell lung cancer. And you can see here that the median overall survival in PD-L1 less than 1% was almost equal to the one who were positive, with a 17.2 months with a hazard ratio of 0.64. Still, there was that dipping of the curve that you can still see there initially when dual immunotherapy was used alone without chemotherapy. How about PFS? So basically on the left-hand side, that's the PD-L1, the PFS and the PD-L1 more than equal %. I can see here basically that there is slight basic benefits that's almost similar, which is 5.1 to the chemotherapy 5.6. And if it was PD-L1 less than 1%, it's about the same with 5.1 versus 4.7 versus chemo. And that's the overall response rate. And we can all see here that basically with PD-L1 more than equal 1%, nivo plus epi had a response rate of percentage of 36.4, as opposed to the PD-L1 less than 1%, the nivo plus epi had 27.3% response rate as opposed to chemo versus nivo plus chemo. The safety summary, as you can imagine, when we add dual immunotherapy, there is going to be a slight adverse event reaction that's a little bit, it's going to be as a disadvantage to the combination when compared to either chemo alone or nivo alone or nivo plus chemo, because of the combination of immunotherapy alone, basically. And you can see that the grade 3 to 4 was about 12% in this population as opposed to the rest. And we're going to talk about that later on as well. So in this subgroup analysis, like everyone gained benefit of the dual immunotherapy treatment versus chemotherapy, except the ones who were not smokers, and that's attainable to the mutational burdens that these patients have, basically, and as you all know. And this is the same concept that we know with any immunotherapy treatment. And it was a little bit not in favor of liver metastatic patients, and they usually do worse than their counterparts of having liver-free disease. So moving on to CheckMate 9LA, and this is just a sequel of the CheckMate 227. When with the initial dipping of the curve basically occurred, they thought of adding in chemotherapy to the dual immunotherapy just to eliminate that dipping of the curve. Again, this study was done in stage 4 recurrent non-small cell lung cancer, free of Jarvis mutation, no prior systemic therapy, ECOG was 0 to 1, and the PD-L1 basically was either stratified according to PD-L1 less than 1% versus more than equal 1%, sex and histology of squam versus non-squam. And they were randomized 1-to-1, and basically they were able to randomize 719 patients, and they were equally distributed. So the first group, which is the experimental group, nivolumab plus ipilimumab, and I have to draw your attention to the dose of ipilimumab that was used, which was 1 milligram per kg, Q6 weeks, plus chemotherapy every 3 weeks for 2 cycles, versus the other group was basic chemotherapy for 4 cycles, with an option of pemetrexed maintenance in the case of non-squamous non-small cell lung cancer. Primary endpoint was overall survival. Secondary endpoints were PFS, overall response rates, and efficacy by tumor PD-L1 expression. So as you can see here, that's the overall survival at the interim analysis. And you can see that the initial deepening of the curve that took place basically had resolved when they added the only 2 cycles of chemotherapy. And the overall median overall survival was 14.1 months versus 10.7 for chemo, with hazard ratio of 0.69. Again, that's the updated overall survival, basically. And you can see it's 15.6 versus 10.9, the hazard ratio of 0.66. I have to draw your attention again to the initial deepening of the curve that we had seen with the CheckMate 227 that's had resolved now, and they added only the 2 cycles of chemotherapy. And you can see here that that's the frost plot graph, and everything is in favor of the dual immunotherapy plus chemo, and all the PD-1 expressors, basically either positive or negatives, gain benefit of adding the dual immunotherapy plus chemotherapy. As you can see here, that the never smokers didn't gain much benefit, as we all know, because the mutational burden and liver metastatic disease usually do worse than their counterparts, as we said. And that's a response rate. And you can see here is 38% versus 25%. So it's in favor actually of a dual immuno plus chemo. And the duration of response is 11.3 versus 5.6 in favor of the experimental arm. And the adverse events, and it's about 30% in terms of the adverse events in grade 3 or 4 for nivo plus epi along with chemo versus chemo alone, which was higher, about more than 40% in that case. So that's a table to summarize the 2 studies. Basically, I'd like to draw your attention to the overall survival in case of the PD-L1 less than 1% of the CheckMate 227, which is 17.2 months. And when you look at the counterpart of the CheckMate 9LA, the all population got 15.6. They were, so because the whole study is not out yet, so I wasn't able to draw the exact number of the PD-L1 of less than 1%, but there was significant benefit when the nivo plus epi along with chemo was given. And most importantly are the adverse events. It's about 33% for the CheckMate 227, and it was about 30%. The exact figure is not out yet because the study is not out, but I have shown you the graph, and it's about that. So that's a very important point to make out for later on argument. So the MYSTIC trial, we all know the MYSTIC trial. It was a negative study basically because it did not reach its endpoint, but I have to mention it because it's part of the dual immunotherapy. And we all know it's a phase 3 randomized open label multicenter study. It was that looked at first-line treatment of patients with EGFR and ALK non-rearranged stage 4 non-small cell lung cancer, so drivers mutation-free, and they were able to enroll about 1,100 patients, and they were stratified according to PD-L1 expressions of less than 25% versus more than equal 25%, and they were stratified according to histology. So they were able to randomize patients to 3 groups, either durvalumab alone versus durvalumab plus tremelimumab, which is a CTLA-4 inhibitor, and then versus platinum-based chemotherapy. And there were a couple of handful of endpoints that looked at, but primarily they looked at PFS for durvalumab plus tremelimumab versus chemo, or overall survival, or overall survival for durvalumab versus chemo, as opposed to durvalumab plus tremelimumab versus chemotherapy. And the secondary endpoints were PFS and their counterparts, basically. So that's the baseline characteristics for the population, and they were well randomized, well balanced between all groups. I'd like to draw your attention to the bottom table where it actually explains the intention to treat population, and they were all well balanced in terms of the PD-1 expressions of more than equal 1%, more than equal 25%, or more than equal 50% across all groups. So that's the overall survival. When it comes to durvalumab versus chemotherapy in PD-L1 more than equal 25%. And as you can see here, that initial deepening of the curve, actually it lags for longer than 6 months, for about 9 months before they came across, and you can see some favorness of the durvalumab. And you can see the median overall survival is 16.3 versus 12.9 with a hazard ratio of 0.76, so with a significant p-value. One important point to be made out here is that whenever you're considering treatment of any patients who have a visceral crisis, you have to be very vigilant of that initial deepening of the curves. It's exactly like the one that we had seen with the CheckMate 227, as that will make a very important role of how you actually choose your patients for the subsequent chemotherapy or immunotherapy. So with the overall survival, again, when it comes to durvalumab versus chemotherapy, for a PD-L1 less than 1%, you can see here that it's about almost the same for a median survival of 10 months, hazard ratio of 1.18, and the curves actually like slide on top of each other, basically without any separation. Well, but PD-L1 more than equal 1%, the hazard ratio is 0.88 with 14.6 months versus 12.3 months, and it was not of a significant p-value as well. So how about the durvalumab plus tremelimumab versus chemotherapy? again, in the PD-L1 more than equal 25%, that initial deepening of the curve, and it's actually lasts longer for about more than 9 months, as we said, and that's quite concerning, with an overall survival of 11.9 versus 12.9, hazard ratio 0.85 with a non-significant p-value of 0.2. Again, when we talk about durva plus tremelimumab versus chemotherapy in the PD-1 subgroups of less than 1%, you can see here basically that durvalumab plus tremelimumab was 11.9 versus 10.3 with a hazard ratio of 0.73, initial deepening of the curve, and when it comes to the PD-1 more than equal 1%, hazard ratio is 1.01 when it was compared to chemotherapy. When we talk about the progression-free survival, durvalumab plus tremi versus chemotherapy in the PD-L1 more than equal 25%. There was 3.9 months progression-free survival with the durva plus tremelimumab versus chemotherapy of 5.4, and the p-value was not significant. And it's exactly the same thing almost when it comes to the opposite arm of durvalumab versus chemotherapy when we talk about the progression-free survival. So they also looked at the subgroup analysis of the tumor potential burden of less than 16 versus more than equal 16. And between both graphs, I'd like to concentrate on the one on the right-hand side because that one of the positive markers that was shown in this trial. When durvalumab plus tremelimumab was compared to the rest of the group, the overall survival was significant of 16.5 when compared to durvalumab alone versus chemotherapy with a hazard ratio of 0.62. And that, keeping in mind, that was basically according to the tumor potential burden of more than equal 16 in that study. So the main conclusion of the MYSTIC trial, unfortunately, did not reach its endpoint, basically of OS or PFS in patients with PD-L1 more than equal 25%. However, durvalumab versus chemotherapy, although that statistical significance was not reached, there was some clinical meaningful improvement in OS as we described. And when we talk about durva plus tremelimumab versus chemotherapy, overall survival was not improved in that setting. And then there was exploratory analysis looking at the high tumor potential burden of more than equal 16 and associated with a better overall survival, as we just mentioned, of durvalumab plus tremelimumab versus chemotherapy with hazard ratio of 0.62. So that's a very important slide, I think. And that's not about any dual immunotherapy. It's about immunotherapy plus chemotherapy, as in the Keynote 189 for adenocarcinoma, Keynote 407 for squamous cell carcinoma, Empower 150, where atezolizumab was given along with beva and carboplatin paclitaxel, and then Empower 130, where the atezolizumab was given along with paclitaxel, carboplatin, or cisplatin. So the most important thing in this slide, I'd like to draw your attention on the adverse events. You can see here on the far right-hand side, where the adverse events is quite high and it's quite significant for any immunotherapy that was added on top of chemotherapy. And the lowest of them was about 70%, as in the Keynote 407. So that's a very important thing to keep in mind for later on argument. The other thing is basically the overall survival here was the best, as we all know, in the Keynote 189 of 27.7 months because it's adenocarcinoma, they respond better than squamous cell carcinomas. And as well as basically in the Empower 150, where you can see here that the PD-L1 high gained 25.2 months, and it's almost about the same with the Empower 130, but it was like for the intermediate group for the Empower 130 rather than the high PD-L1s. So that slide, basically, I just tried to summarize and try to make an argument of how the dual immunotherapy actually exerts a significant effect upon the overall survival. And you can see here with the Checkmate 227, the overall survival is 17.1 months. When they added chemo, it was 15.6, but we have to await the further results basically before we jump into the last or the updated overall survival. But when it comes to pembrolizumab plus chemo, and I only chose the Keynote 189, the intention to treat population was 20 months basically, as opposed to the Empower 150, which is about almost the same. So when it comes to response rates, the dual immunotherapy exerted 32% response rate versus 38% for dual immuno plus chemo when the chemo was added. And then pembro plus chemo was 48.3, is about approaching 50, and it's the same for atezo plus chemo, basically. However, I think that's going to be a very important point is the adverse event. So the adverse events about 33% for dual IO versus dual IO plus chemo, 30%, versus 72.1% and 73%. So I think in terms of the dual immuno plus chemotherapy, that is a very valid option, I think. And the patients who are not going to say fragile, but they have significant comorbidities that might not be ideal for them to receive longer courses of chemotherapy, especially with that kind of figure of adverse events. So this is something to be kept in mind for when we choose immunotherapy along with chemotherapy. So the dual immunotherapy, so the resolution of the initial deepening of the curve when dual IO were used without chemo, that resulted in improving response rate when the chemotherapy was added in the checkmate NLA, and there were only 2 cycles of chemo were given to improve response rate, in addition to the caveats of decreased chemo-related side effects compared to the pembrolizumab with atezolizumab were added because of the 2 cycles only. And it is worth noting that the ipilimumab dose, and that was a big thing basically that the oncology community, especially the lung oncologists, were talking about the ipilimumab dose, and here they use a 1 milligram per kg every 6 weeks, as opposed to the previous melanoma trials and studies with the significant side effects of ipilimumab. So I just want to talk about the approach in metastatic non-small cell lung cancer. It's something that I actually look up quite often and just try to remind myself about. So when we talk about metastatic non-small cell lung cancer, we have to know the histology. Is it adeno versus squam? When we talk about adenocarcinoma, we have to assess the PD-L1 if it was more than equal 50%, or 0 to 49%, and just going to the left-hand side, do we need a rapid response, yes or no? So when it comes to a no, then you have to choose either atezolizumab alone, such as in Power 110, or pembrolizumab alone, which is Keynote 24, as per the Keynote 24/42, basically. And if you want a rapid response, then you have to think about a dual agent, such as chemo plus pembro, or chemo plus atezo, or chemo plus atezo plus beva, as in Power 150, or dual IO plus chemo, as being a suggestive and quite interesting study, but I have to await the full study before I decide upon that. However, how about if it was a PD-L1 of 0 to 49%? Then definitely it has to be chemo plus immuno, either like single agent immuno plus chemo or dual IO plus chemo. And I have to mention that the semipilimab, basically, it's a new drug. It's a new anti-PD-1 drug that was presented in recent ESMO as per the Empowered Lung, and can be used for both squam and non-squam. How about the squamous cell carcinoma? The options in there, it's exactly the same schema, but when it comes to rapid response, you have to choose for chemo plus pembro or dual IO plus chemo, such as checkmate NLA. And if you don't need a rapid response, then it's going to be the same pembro, atezo, or semipilimab. And when it comes to low PD-L1 expressors, it's going to be chemo plus pembro or dual IO plus chemotherapy. So by that, I conclude my presentation. Thank you for listening, and thank you for your attendance.
Thank you very much, Dr. Ahmed, for excellent presentation and overview. We'll keep the questions at the end, please. It's my pleasure. We'll go for the last talk today regarding this session. It's my pleasure to introduce Dr. Ahmed Rifai. Dr. Ahmed Rifai is very known to everybody. He is a medical oncology consultant in IMC Jeddah, and he is associate professor of clinical oncology in Ain Shams University Hospital in Egypt. Dr. Rifai, he will give us a talk about important topic after we have the dual blockade, and also we do have the IO plus chemotherapy. Will give us a talk about febrile neutropenia. Do we need to do better job? Thank you. Dr. Ahmed Rifai, stage is yours. Thank you.
Thank you so much, Dr. Mervat. First of all, I would like to thank the organizing committee, Dr. Abdulaziz Al-Hamad, Dr. Abdurrahman Jazia, and of course, Dr. Mervat Mahrouz for their effort for this very nice scientific gathering. I will start with I hope you can see my slides right now.
Not yet.
Okay, just 1 minute.
Yes. Can you do slideshow, please?
Yeah, sure. Now it's okay?
Yeah, perfect. Thank you.
Okay. Febrile neutropenia, do we need to do a better job? Actually, febrile neutropenia is part of our daily life, and as we heard from our colleagues, just we are using more aggressive chemotherapy protocols to try to achieve the best result. And febrile neutropenia is there. As a background of febrile neutropenia, chemotherapy will induce myelosuppression, decrease neutrophils quantity and quality, and can disrupt the normal barrier in the GIT, which will result in high probability of getting infection, and in the same time will decrease the amount of developing localized symptoms. So there will be subtle or delayed signs of localization and febrile neutropenia. This myelosuppression can last for 7 days in solid tumors, which result in 5 to 30% febrile neutropenia, and it is longer in hematological malignancies, up to 14 days, with probability of febrile neutropenia of 80%. So the more the degree and duration of neutropenia, the more the chance of febrile neutropenia. Of course, all of us, we know the definition of febrile neutropenia, but what is the risk of febrile neutropenia? Febrile neutropenia is an oncological emergency. Prevention and the early detection is very crucial. It is the most common life-threatening situation post-chemotherapy treatment. There are more than 100,000 events per year in the United States, with 5% of the hospitalized patients due to febrile neutropenia. And complication is there in 25 to 30% of patients with febrile neutropenia can result in multi-organ dysfunction, and mortality is about 5%, reach to 11% in hematological malignancies. Why hematological malignancies? Especially because prediction of nadir is difficult, associated thrombocytopenia, inconsistent response to the G-CSF. If there is a proven bacteremia gram-negative, the mortality will reach to 18%. If it is gram-positive, it is about 5%. And as we can see here, the chance of febrile neutropenia, usually in the first cycle, and it reaches up to 50% in breast cancer and other diseases. What is the consequences of febrile neutropenia? Hospitalization. Hospitalization can start from 7 to 10 days, which can cost a lot of money, up to $20,000 in the American hospitals. And also it can jeopardize the delivery of the chemotherapy. With the febrile neutropenia episodes, like 70% of chemotherapy doses to breast cancer patients can be affected, and overall about 60%. And so what if there was some delay or decrease in the doses of chemotherapy? No, actually, this is very risky in impairment of the overall survival. Here we can see if we offer the relative dose intensity less than 85%, it can affect overall survival in patients with breast cancer and those with non-Hodgkin lymphoma. And a relative dose intensity reduction is not only by the dose, but also by the delay duration. And as you can see here in this table, does it happen? Actually, is very frequent in 21% of patients with breast cancer, up to 60% in patients with ovarian cancer. Actually, we now have some tables, and we can know exactly the timing and the depth of the nadir of the neutrophils, and also we can predict the risk of febrile neutropenia with different chemotherapy protocol. As we can see here, protocols were more than 20% in the NCCN guidelines, and those with 10 to 20%. So what is the treatment? How can we do better? As a title of the lecture, first, by the prevention. There is certain factors with which we can predict that there is high risk of febrile neutropenia. The first one is old age. Old age by itself, it can be a surrogate for presence of multiple comorbidity, and also treatment. If we don't offer the proper prophylaxis, the risk of febrile neutropenia will be there. We should also give be meticulous with the laboratory result for the patient. So we'll start with the first part of the prevention by the antibiotic prophylaxis. We can start with the vaccination, the yearly influenza vaccine or the 5-yearly pneumococcal vaccine. antibacterial drugs offering fluoroquinolones can be for patients with intensive chemotherapy and those expected to have prolonged and profound neutropenia. And even we can offer antiviral for those patients also who will receive intensive chemotherapy and expected to have prolonged neutropenia, and those with repeated herbal infections. And also we can offer antifungal treatment, as we can see here in the guidelines of the joint ASCO and the ITSA guidelines. Routine antibiotic is not offered for patients with solid tumors, and because also there is a risk of developing resistance, and we should do good monitoring for these antibiotics. However, in this 2020 exceptional surveillance of the neutropenic sepsis done by the NICE, they just had another opinion. They just found that adding fluoroquinolones for prophylaxis for guarding against neutropenic sepsis is really is worthy. And here they found those patients with acute leukemia stem cell transplant or solid tumor whom significant neutropenia is expected for the chemotherapy. Offering prophylaxis with fluoroquinolones is important, and we should also rate and follow development or eruption of resistance. On the other hand, they don't recommend routinely offering G-CSF for the prevention of neutropenic sepsis in adults receiving chemotherapy unless this G-CSF is an integral part of the protocol. And just the reasoning behind this is just mentioned that they revised 200 randomized controlled trials of primary prophylaxis, and just based on the affection of or reducing the mortality, they found this is really very pragmatic approach and also cost effective. What about using the colony stimulating factors? Using colony stimulating factors is mainly for the prevention, but not for the treatment. We can offer the G-CSF till we have neutrophils less than 10,000, and we can start from 24 hours to 74 hours, 72 hours after the chemotherapy. Of course, we know that we have the Belgrastim or Neobogen or whatsoever other commercial name, or the begilated Belgrastim. We can offer the 5 microgram per kg per day for the short acting and 6 milligram fixed dose for the begilated form. What is the effect of the G-CSF? Actually, G-CSF will decrease the duration of neutropenia and also can decrease the incidence of febrile neutropenia. Nadir will happen even with the begilated form, but usually it will be for short duration. And here in this trial, they just try to compare begilated versus Belgrastim, and they found actually non-inferiority and no difference statistically between begilated Belgrastim and Belgrastim. And they found also that it doesn't matter the number of the cycles or the which cycle. Cycle 1, which is the site of the most common febrile neutropenia, or the subsequent cycles. Here in this trial, they mentioned that begilated Belgrastim just offered reduction in febrile neutropenia by 42%, from 19% to 11%. However, I think just more trials is warranted for just to document this fact. What about bony pain? There is no difference if you offer the patient the daily Belgrastim or you offer the patient the long-acting. It doesn't matter. The bony pain will be the same in about 25% of the patient, and usually it is not really it doesn't bother the patient so much. You can just manage with some sort of simple analgesics. Regarding the begilated Belgrastim, it can cover different weights for the patient up to 132 kilogram effectively. The indication of the G-CSF is really very long list, starting from with chemotherapy and for myeloablative protocols and for mobilization, and for patients with even chronic neutropenia and those with HIV. And still there is no rule for those with patients who receive CDK4 inhibitor, for example. What about biosimilar formulations? Actually, biosimilar formulation of G-CSF and the long-acting formulation, such as levetiracetam, may offer advantage over belgracetam. So, in trial to reduce, the expenses, biosimilars is now a fact. So, what will be our plan for offering the G-CSF prophylaxis? Of course, all of us aware with this chart. Patient with febrile neutropenia risk more than 20%, they will offer prophylactic G-CSF. If the febrile neutropenia risk from 10 to 20, we will check the other risk criteria. If it is there, we will offer prophylactic G-CSF. If it is not there, don't offer. If the febrile neutropenia risk is less than 10%, don't offer a prophylactic G-CSF. And here also, this documented in the NCCN guidelines. We will check also for the risk criteria assessment. If patient is from 1 to 20%, if give G-CSF, if there is a risk criteria more than 1. For the secondary prophylaxis, if the patient developed febrile neutropenia and just want to offer secondary prophylaxis, if he didn't receive G-CSF before, offer him G-CSF. If he was offered, so we are obliged to do dose reduction. If not, we will do the same. What about real life? In this trial, they just assessed 1,400 patients in 140 cancer centers in 12 European countries to check about over and under prophylaxis of the chemotherapy. And just they check, for example, if the patient with risk more than 20% and didn't receive the prophylactic G-CSF, this is under prophylaxis. If patient less than 10% risk and receive, this is over prophylaxis. They found that 26% of the patient 1 quarter receive over prophylaxis and 56 correct prophylaxis, 17% under prophylaxis. And they just checked the difference in the parameters. They found, interestingly, that rates of neutropenia, febrile neutropenia, and chemotherapy-induced neutropenia-related hospitalization are consistently lower in a patient with over prophylaxis. And there is no difference for those who received correct prophylaxis and under prophylaxis, except in chemotherapy-induced neutropenia-related chemotherapy disturbance. So actually, if you are in the choice to offer, over prophylaxis, I will do. And actually, they found the differences is mainly because of the definition of the risk factors and the prophylaxis pattern. What about the management of febrile neutropenia? Febrile neutropenia is an emergency, and we should really inform the patient and educate them very well. Actually, febrile neutropenia is exactly defined as neutrophils infarction. So this is the same like the heart attack or a stroke. And if the patient just went to the ER, we should go for checking a thorough history to know exactly the chemotherapy, if there is a prior antibiotic, steroids, or a surgical procedure, if there is an allergy. And we check in the system if there is an biogram or something there for the patient. And we do thorough a clinical investigation to search for the source and do the required investigation, including the band culture for the patient. Even CT scan can be done if fever persists for more than 3 days. What about the common pathogens? Of course, all of us, we know that there was some sort of changes. We started with a prevalence of the gram-negative, and then with using prophylaxis, now became gram-positive, especially with using the Endwheeler Kester. And now I think the incidence is equal. Anaerobes exist in less than 5%, fungal infection in 10 to 10%. So now the first question after the patient is in the ER, we will keep the patient as an inpatient or we'll discharge the patient. And we have this risk criteria, the MASCC scoring system. And if the patient is exceeding 21 score and the ANC is more than 500 and no coexistent medical condition. And we anticipate that the neutropenia will improve within 7 days. The patient can receive the treatment as an outpatient. Mostly, we will offer this patient fluoroquinolones or together with augmentin or amoxicillin clavulanic acid. Or we can use the clindamycin if there is allergy to penicillin. But this is really, we should select our patient. Not every patient, we can just send him home. The patient should be aware of the risk, and just he can come to the hospital if there is something wrong just took place again. For the inpatient, actually the treatment will based on hydration antimicrobial therapy, and GCSF is not routinely used. And we should emphasize that patients should receive the first dose of antibiotic before moving from the ER to the ward. For example, better to be within 30 minutes of dropping to the emergency. The antibiotic which used, all of us, of course, we know that we use piperacillin and tazobactam, and sometimes the meropenem or cefepime. We just recommend to not use ceftazidime because it can develop resistance later on. And the combination therapy by adding aminoglycoside to the piperacillin also can be used. However, it is not recommended to use combination treatment because it is with more side effect and there is no clinical benefit. If the patient had penicillin allergy, still we can use cephalosporin, except if this allergy was severe and the patient had bronchospasm, for example, we should just go for something else like ciprofloxacin with clindamycin or aztreonam with vancomycin. What about gram-positive? We shouldn't offer also vancomycin as a routine, except if we have culture with MRSA, or if we are suspecting infection in the endometrial cluster, or we find skin or soft tissue infection, and also patient with pneumonia or hemodynamical instability. And this is the practice guidelines show all of this recommendation. Antifungal can be used if the effect of the fever lasts for more than 4 to 7 days, and antifungal also if we find the oral ulceration. What is the duration of therapy? Duration of therapy will differ with different scenario according to the organism and according to the recovery of the absolute neutrophil count. However, we offer the antibiotic till the absolute neutrophil count exceeds the 500. If the patient improved clinically but still neutropenic, we can de-escalate the treatment to oral fluoroquinolone for this patient. And here, and this is also a survey in 2020 to check what is the physician offering in their practice. They found that there is overuse of carbapenems and the combination therapy and unjustified addition of glycopeptides. Actually, they call this imipenem, for example, the big guns, and sometimes it is only allowed by the infectious disease consultant. As I mentioned, GCSF is not offered as a routinely for the treatment of the patient, and mainly for treatment for patient with in the prophylaxis. So what is the home taking message? Neutropenia risk should be thoroughly and wisely assessed before each cycle. Proper prophylaxis is worthy. We should be a little bit more generous in offering a prophylaxis, also following the guidelines. Febrile neutropenia is an oncological emergency. We should educate our junior staff. We should also discuss this with the emergency room team. It is common and can be fatal. Yearly reporting is crucial. Rapid and proper intervention is life-saving. And finally, I would like to thank you for your listening.
Excellent talk. Thank you very much, Dr. Rifai, for excellent presentation and the important topic. We'll keep the questions after polling. So we'll go now for polling. Can we ask all the speakers to just to be to put their video on, please? And in the meantime, Dr. Jose will start the polling. So the first one. Did you attend the ESMO ASCO BIOS Precision Oncology virtual this meeting. Can you please vote? We'll give 15 seconds. Okay. So 42% of the 42% of the attendees they attend the meetings, and only 60% did not. So we'll go for the next question. Next question. This year has unprecedented data for non-small cell lung cancer management. Do you agree? Disagree? Not sure? Can you please vote? All the panel and the speakers, you have the right to comment or give your thoughts as well, please. So the results, 54% agree that it was unprecedented data, and 7% disagree, and 40% not sure.
Yeah, as we saw from the presentation, there were multiple practice-changing findings this year. I'm concerned about the answer for the first question, that 60% did not attend. I don't know if they misunderstood the question that they attend all the meetings. I hope, you know, the virtual meeting will give access to all our colleagues to attend these important meetings. So I hope that those who said no, that means they said no to all of them, that they did not attend all of them, but they attended at least the big meetings.
Right. Do you agree to do EGFR test for all non-small cell lung cancer patients, either early or metastatic patients? Yes, no, only metastatic. Can you please vote? So 83% agreed. I think Dr. Turki, he convinced everybody. And no, only 6%, only metastatic people, just only 11%. Thank you, Dr. Turki. Okay. Osimertinib as adjuvant therapy in early stage non-small cell lung cancer, ADORA is practice-changing study. Do you agree? Disagree? I prefer to wait.
Now we know that he convinced them or not.
He convinced them so much. 83, they agree, and 3% only disagree, and I prefer to wait 14%. I think he very convincing. What is your barrier against ADORA applicability? I prefer to wait OS data. I'm not sure about the benefit. Study bias to the investigator. Experiment. Study bias to investigator. Experimental arm. Okay, so I prefer to wait OS data about 65%, and I'm not sure about the benefit 19%, and study bias about 17%. Pacific study in a stage 3 non-small cell lung cancer is positive study with OS benefit data. We have the 4 years actually. So please vote. Hassan is taking the lead. Okay. So agree 94%, disagree 2%, and the nivolumab is not available about 4%. The nivolumab in stage 3 irresectable non-small cell lung cancer has benefit in all patients. Agree. Only PD-L1 positive patient I have concern regarding post-irradiation. Can you please vote? So the people who is finding that for all patients benefits about 70%, and only for PD-L1 positive, it's only 14%, and people, they have concern about the post-irradiation manifestation, about 16%. Lorlatinib in Crown study has proven efficacy and intracranial involvement as well. Do you think we need to use it upfront in ALK positive patients? Can you please vote? Agree, disagree? I will use it only in second line. People agree to use it in first line, 76%, and disagree about 5%, and only in second line, 20%. We have concern. Last one. Nivo-Ipi plus 2 cycles of chemotherapy for stage 4 non-small cell lung cancer as upfront therapy is good option and less chemotherapy. Yes, no, I prefer to wait. So 84% they found that yes, and no, 5%, I prefer to wait, about 11%. Thank you very much for voting. And we can go for questions. Dr. Professor Jazia, can you please lead?
Yeah, thank you. Thank you very much, Dr. Mervat. We'll cover some of these points now in the discussion, starting with Dr. Turki. There are some questions that we can basically address some of the concern, but I would like to thank Dr. Mohammed Mahmoud, who put many questions. And Dr. Mohammed, we may not be able to answer all of them because the speaker clearly answered some of them. Dr. Turki, if a patient with stage 1B, what is the role of chemotherapy of stage 1B? He said, what is the role of chemotherapy in stage 1B with EGFR positive? Can we skip the chemotherapy?
So stage 1B, we know the data for the chemotherapy. It's a very controversial, and benefit is not really clear. Probably some patients with a bigger tumor more than 4 centimeters, or those with a poor differentiation, or those with a high uptake on PET scan can have a discussion regarding the role of adjuvant chemotherapy. And if we are going to offer, then probably the best evidence we have is for the carbopaclitaxel. So it is not a routine to offer them, but it's a discussion to give chemotherapy. Now for the EGFR positive, myself, I will offer, I will probably lean toward EGFR TKI for those patients, knowing that the curve for the stage 1B was also positive. The magnitude of benefit is less than stage 2 and 3, but still significant.
Still 50% the hazard ratio, still very significant. Okay, so I just want to make this point clear to everybody. The ADAURA study did not address the question of chemotherapy, adjuvant chemotherapy. Adjuvant chemotherapy remains the standard because for those who are obsessed about overall survival, rightly so, adjuvant chemotherapy showed improvement in overall survival. So we stick with that one. Whenever a patient is candidate for chemotherapy, you give him chemotherapy. So, adjuvant chemotherapy. So that's the adjuvant chemotherapy as a standard of care did not change generally. Okay, and the subgroup that in 1B, as Dr. Turki said, if it was large tumor more than 4 centimeters, or if there is high risk features and so on, but the others you try to give chemotherapy, by the standard of care. Now, Dr. Turki too, they're saying, how do we treat EGFR on exon 19 in the adjuvant setting? Exon 20, I'm sorry, exon 20. Yeah, so the resistant mutation.
So yeah, resistant mutation seems they are very resistant to TKIs and even chemotherapy. So we don't really, and for the ADAURA trial and also all other previous trials using adjuvant TKIs, they did not include exon 20, all just exon 19 and 21. So we do not really have data for TKIs in the adjuvant setting, and we know it is a resistant disease. So I will still offer them chemotherapy. This is the best we have.
Fair enough. This is the last question about
if they develop recurrence, then we do have some data from the ASCO and ESMO this year about the mobocertinib. Yeah,
great. So this the last question will be for you about the ADAURA, and then we'll be moving to the other topics. So, and that this question is jointly for you and Dr. Hassan Jafar. In stage 3, that has EGFR mutation, but resectable. They got chemo radiotherapy. Do you do it with Durva or Ozi? Dr. Turki, then I'll move to Dr. Hassan.
I think Dr. Hassan clearly answered this in his presentation. The solid data we have is for the chemoradiation followed by maintenance durvalumab, where we have a survival benefit. For the osimertinib, as the only exception I can use it in stage 3B is if I have a patient who is not fit for chemoradiation or for immunotherapy, then yes, I will offer them and I will treat it as a palliative. And when we have to keep in our mind that usage of TKIs after osimertinib, if we say we will use it as a maintenance after durvalumab, there is this data of increased pneumonitis, so we have to be careful about this approach. So my answer is chemoradiation, durvalumab is the best we have for those patients.
Okay, so Dr. Jafar?
I totally agree with Dr. Turki. We don't have data for stage 3 and resectable. We have it for adjuvant, we have it for metastatic, but specifically for this only immunotherapy, we have it unless we cannot give the treatment, then this is an extrapolation if this can be done. But with the current standard of care, immunotherapy is the only drug approved in this setting.
Yeah, before we move from this ADAURA study, I just want to say for those who are waiting for overall survival, it's theoretically okay to wait for that, but really practically, guys, you have a drug that we have hazard ratio that we never saw. The curves, you can drive truck between them. And number one. Number two, I see people will wait, the curve may merge. By the way, if you brought healthy people and you watch their curves, we are all our curves is going to go down, and one time it will meet. You cannot, so we just wait, probably for the maturation of the survival for the osimertinib, and I am expecting that will be difference. However, if you are extrapolating from gefitinib study, osimertinib is not gefitinib. It's better drug, number one. The one thing that may affect the overall survival, that many patients will be getting osimertinib after the result came out, and that may change the overall survival. So I think comfortably this is the standard of care. I would not hesitate a bit to give somebody who has a resection of stage 1B to 3 to give them osimertinib. Okay, Dr. Hassan.
Dr. Jazee, if you let me rephrase it.
Go ahead. Go ahead, Dr.
I think we are all waiting for overall survival, but this does not mean that we stop using this till we get the overall survival. We like to see the overall survival, but seeing that big improvement in progression-free survival, delaying brain metastasis significantly in all those patients with a very symptomatic improvement, I think this is an enough reason to start the standard of care. Overall survival, there are a lot of players where it goes there, but we don't have a stop managing patient with this very significant differences, just waiting for overall survival.
Yes, thank you.
Can I make a quick comment, Prof?
Yes,
about the survival curve. We may not actually see a survival benefit, simply because I heard that the study will be unblinded soon, and many patients on the placebo, when they progress quickly, or even if they don't progress, they may have osimertinib. So this will not give you an answer. So I agree that clinical benefit is a very important endpoint to use at this point of time.
Okay, great. So thank you, Dr. Turki. So now continue with Dr. Hassan. what is the role of PD-L1 in the decision about durvalumab? Because somebody said, Dr. Mahmoud is asking that, you know, the EMA approved only for positive PD-L1 patients.
I know the PD-L1 is a very critical issue. We saw it with pembrolizumab in the metastatic setting. The correlation is strong. With other drugs, is not that strong. Here, this is a post hoc exploratory. So the pre-planned was more than 25 and less than 25, and both were positive, both were significant. Post hoc analysis, exploratory analysis, showing that the magnitude of benefit is much less, but still there is some benefit from there. So if it is a cost issues, probably limiting for those who may benefit more, I can understand this, but to limit this, saying that there is no benefit on this category of patient, we don't have data and we don't have the evidence for that.
So we give the treatment regardless
Yes.
for those who have disease control after concurrent chemoradiotherapy, regardless of the PD-L1, and you don't have even to check the PD-L1.
And this is the FDA approval.
Yes. So now a question to you, and will be transitioned to Dr. Abdulaziz Al-Hamid. How do you differentiate between IO pneumonitis versus radiation-induced pneumonitis? Difficult question, but you know, it was asked, and the clinical dilemma we face.
For myself, I don't think there is a clear-cut differentiation between both. We have to take it in concern, but probably if it is very minimal, then re-challenging patient with immunotherapy is possible, because this can be related to radiotherapy. But any tools to differentiate, I don't think we have the tools to differentiate between them.
I think
Dr. Abdulaziz?
Radiotherapy usually it is local, and usually it's related to the field of radiation, and usually started about 6 months to 18 months post-radiation. With good treatment and the patient healthy, usually it is resolved within 2 years to 2.5 years. I believe the immunotherapy-induced pneumonitis might be bilateral, not related to the radiation field. I don't know exactly about the prognosis after the intensive intervention, but it's important. I believe important factor for both of them is the patient health status and not active smoking. Because what we notice, patient who's continuous smoker, usually they are poor responses for pneumonitis. They don't respond at all for any treatment, or the response would be usually poor. So we usually emphasize on asking the patient to quit smoking.
Yeah. So basically, practically, what we do, if the pneumonitis limited to the area of radiation field, you can see demarcation almost line and so on, and the radiation therapy still, oh yeah, this is my doing, then you can probably attribute it to radiation. But I just want to make sure that people know that immune therapy induced pneumonitis could come in any shape and form. It could be lobar, by the way. The typical thing, we think of it as you know, as drug-induced pneumonitis, bilateral and so on, but it could be patchy, it could be all kind of thing. So we should not assume that if we saw patchy pneumonia, that is, you know, we assume that this is just bacterial and not be aggressive, because unlike other complications, this could be fatal. So we don't kid around with pneumonitis. We don't fool around with pneumonitis, you know. So, and the bottom line for my colleagues there, whenever you are in doubt, please hold off your horses. You don't know what it is, hold on, slow down, think about it, talk to your radiation oncologist, meet as a team, meet with the radiologist, look for things, culture the patient, and so on. If the patient is hypoxemic, please give steroids. Do not hesitate. Do not wait till the patient get intubated and start running, okay? So then now, to build on this, so Dr. Abdulaziz, somebody got concurrent chemoradiotherapy, stage 3B to start with. Got concurrent chemo, that's the question from the audience. Got concurrent chemoradiotherapy and has marvelous response. Would you recommend that the surgeon do surgery?
This is it's not going to ever end at all, because what we have, the data is, in the general, the outcome tend to be improved after with the 3 modality of treatment. The surgery improve the local control, improve the progression-free survival, has no impact on overall survival. However, pneumonectomy was associated with mortality. The other question, really, I'd like to ask this question to the surgeon, because as you know, surgeons, they don't like to touch patient after radiotherapy, and they don't feel comfortable. So sometimes might end up with the bigger area resected than they planned. It's different than patients who receive only chemotherapy, because usually the tissue is healthy, so they can manage it. When they come to radiation, yes, I asked one of my mentors all the time why the surgeon tend to do pneumonectomy, because they said they cannot get healthy tissue to stop with. Sometimes they end up because all the lung for them look affected. They didn't know what was the disease and what was the normal area. So if you deal, I agree with you, Dr. Jazia, if we have tumor board and the surgeon were there from day zero and he know exactly what's the area he planned to, and you used to work with him, with a healthy patient, I would push for patient for surgery. If I deal with fragile patient, active smoker, or surgeon I don't really work with often, I would ask the patient not to go for surgery, for facility. But this is what we have the data.
Fair enough. The key point here for everybody, multidisciplinary team discussion. If pneumonectomy is on the table, don't proceed, and you individualize the treatment. Whenever you can resect the patient safely, my feeling, and actually from large data with 3,000 patients that we look at it real life, whenever patient could have surgery, they usually have a good outcome. So, but multidisciplinary team, individualize. If pneumonectomy is an option, if the way to go, don't do it. So now I have two questions. One will be for Dr. Mervat about the first line for ALK, and then one for Dr. Lehebi about what are the profile of patients that you will get a combination upfront. So Dr. Mervat, now we have this data of lorlatinib on a CROWN study, but Dr. Muhammad is saying that we know that lorlatinib has high toxicity profile in terms of neurological and cognitive and other things, and then we know about the data of alectinib. There's no head-to-head comparison. So which one you would use as a first line in the clinic?
Well, I agree with you, Professor Jazia. Of course, the CROWN study, which is launched a few weeks in last month in the ISMO study, ISMO meeting, and it was phenomenal that we have this hazard ratio and with the intracranial involvement as well. The patient either with CNS involvement or patient without. But the main point that it was comparable with crizotinib, and it's always comparable with the crizotinib as a standard of care. But we now have the standard of care is alectinib, not the crizotinib. And so we know that alectinib has CNS, it can cross the blood-brain barrier and has a CNS effect as well. So if I use lorlatinib, and it's always the same scenario. What is difference now that lorlatinib is covering most of the mutations, it's more powerful drug, but however, the toxicity profile is higher regarding the hypercholesterolemia, the weight gain, and this is totally not an issue. But I think the most critical one is the cognitive and neurological manifestations. I will be in hold. I will not put it as an upfront. We know that it's the first one now as a second line. We can use it after alectinib. So until we do have mature data, maybe will it change if we do have the next step? Because now in our paradigm, when you have another medications after lorlatinib, we may consider to use it as an upfront. But so far, I will go for the standard of care, which is alectinib, and I will keep lorlatinib for the patient because we know this patient, they develop mutation and they will need another medication as well.
Fair enough. That's great. So let me take the take-home message about ALK. So please, the standard of care till now is alectinib. It is actually one of the almost ideal drug when they was compared with crizotinib. It beat it in all domains. The safety, which is very important too. So it was better, safer medication, better in all aspects. So now, please, when the patient progress on alectinib, try to do biopsy. And even liquid biopsy to subtype the ALK, because there'll be you may find a mutation that may respond to crizotinib. So if you can subtype the ALK, subtype it. If you cannot, you can go to lorlatinib, blindly, because you're likely to cover most of the. Although we start seeing some resistance, by the way, to lorlatinib, but if you cannot, you can go blindly to lorlatinib. And then if you are going to get out, you run out of all the TKIs. Please do not switch to chemotherapy till you run out of the TKIs. If you run out of this, then you make sure that your chemo regimen has pemetrexed, because this is extremely sensitive to pemetrexed, and you may take mileage for months and months on pemetrexed. So keep this in mind. Okay, Dr. Ahmed, what do you think? What is the patient's profile that you'll be using the dual immune therapy in your clinic?
Okay, so thank you for the question, Dr. Jazzy, and thanks to Dr. Mohammed Mahmoud as well for the question. I think it's so basically, whenever we treat those patients, they definitely have to be metastatic disease, we all know. And then, as I said, I have to look at the response rates. Basically, should I need the rapid response rate or not? When it comes to dual immunotherapy per se, we know that on their own, they don't carry a good response rate, and that was manifested by an initial deepening of the curve about 6 months. And that's why in the Checkmate 9LA, they added in the chemotherapy to resolve that. On the important caveats that when they added chemotherapy, the side effect profile was almost the same as in the Nivo plus Epi combination initially. However, the Nivo plus Epi, I don't think it's going to be the best option on their own in any upfront patients on their own. Unless if you have significant side effect profile or contraindications to chemotherapy, meaning a patient who has chronic kidney disease, like a stage 3 chronic kidney disease with a poor creatinine clearance, and you're quite worried about giving cisplatin and pemetrexed, then that would be a valid option, especially if they had a good ECOG performance status, just to go ahead with Nivo plus Epi if you don't need a rapid response.
No, go the 9LA. Sorry, so which one you use the 9LA? Which patients you'll be using the combination with the 2 cycles of chemo?
Okay, so until the full study comes out and we actually see it, compared to the previous studies like the Keynote 189 and the Keynote 407, I think it is a very valid option in patients, anyone basically upfront, especially if they have contraindications to longer periods of chemotherapy, such as chronic diseases or what have you, basically. So it is a very valid option to anyone who has like significant contraindications to prolonged durations of chemotherapy. Keeping in mind the good adverse event profile and the tolerability of the regimen, basically when compared to the Keynote 189 or Keynote 407. So it is a very valid option, but we have to await the full study. I still have to emphasize.
Thank you. Before we conclude, actually, we have one question to Dr. Ahmed Rifai, which is, I enjoyed thoroughly your presentation, Dr. Ahmed.
Thank you, bro.
It was beautiful, really. You put everything in a good way. So, but now we have this COVID-19 business, and during COVID-19, did applying prophylactic GCSF plus antibiotic to decrease hospitalization. What do you think about that? Are there any data from the registries or from what you look at the literature? Should we increase the use of GCSF? Should we be more lenient on that use, or you should be more careful because of the complication of the lung and so on, or whatever? What do you think about it?
Actually, Prof, I will tell you what we are really doing for the time being. Since a very long time, also we are a little bit generous in the prophylaxis because of something been practical and pragmatic. The waiting time in the emergency is really long, and the patient really suffers so much when they come to the emergency with a febrile neutropenia. And usually, as I mentioned, we should offer the treatment very fast before the patient move from the emergency. And this will not happen, and this can jeopardize the patient's life. So what I'm really just inclined for, offering more aggressive prophylaxis in the form of antibiotic, although many don't agree for offering, for example, fluoroquinolone. It is cheap, it is easy for a short period, and GCSF we offer it also for the patient with a risk criteria. And in our community, definitely you will find some sort of risk criteria in our patient. From the 10 to 20, you will find something. So I'm going aggressive with the treatment, and especially as you mentioned in the COVID area, we don't like the patient to step to the hospital except if there is really something mandatory to come to the hospital.
Well, thank you. Great. I'll just make one concluding remark about this febrile neutropenia business. I do not try to treat my patient as an outpatient yet at all. I know there's low risk, but our patients, I take them seriously because where they live and so on. So febrile neutropenia to me is automatic admission for now. I don't treat the low risk as an outpatient yet. You know, although you may individually find selective, educated patient who live close to the hospital, like whatever. That's one. The second thing, we give our patients a card, yellow card, that they are chemotherapy, so they get priority in the ER. So this may be a good idea that, you know, every patient who get chemotherapy, they get this yellow card, and you have an agreement with your emergency department that they should be getting priority treatment. So by this, I will conclude my session. It was terrific, really, presentation from all the speakers and the panelists. And thank you for sharing your knowledge and experience. I would like to thank the audience. I'd like to thank Dr. Abdulaziz and Dr. Mirvat. And now we'll be moving to the satellite symposia immediately. And Dr. Abdulaziz will be introducing the satellite symposia. Thank you very much, everybody.
Thank you.
Thank you.
Jazia, Dr. Mirvat, Dr. Hassan, all the other speakers. It's my pleasure to present my colleague and my old friend, Dr. Ahmed Rifa'i. He's a attending consultant at International Medical Center in Jeddah. He will give us talk satellite symposium for BMS about the IO immunotherapy-based therapy and as frontline for non-small cell lung cancer. Dr. Ahmed.
Thank you, Dr. Abdulaziz, so much, and really just happy to see you. And I will just start my lecture, and I would like to thank Dr. El-Lahabi also. Just he will make my task is really easier. Okay, I will start to speak about immunotherapy-based therapy in the front line. Of course, we know lung cancer is the first killer, and with 1.6 million per year, equivalent to those died from colorectal, breast, and prostate together. And we know now that we are in the era of the molecular pathology, and this is now can control our choices for the treatment. Let us just see what we achieved before. Patients with stage 4, they have a 2-year survival of 10% only, and the 5-year survival is 0%. And with the presence of the immunotherapy, now we have a paradigm shift. About 23% of the patients, they have long survival up to 5 years. But the question, who are those patients who will just be long survival? Still, we are up till now, we are counting mainly on the PD-L1. And as we can see here, in patient who received the pembrolizumab, patient with TPS more than 50%, they achieve up to 30% 5-year survival, and those from 1 to 49 only 15%. And even for the second line, still patient who received the immunotherapy in second line can achieve 5-year survival up to 25%. This is what we have for the time being, in practice. So what is the factors which control our choosing of the first line treatment? What is the parameters? We have the evidence-based data. We have the certain parameters using for personalization, like biomarker, TMB, the driver mutation. And we have the clinical data, the comorbidity, the subgroups, and the treatment preferences with the patient. And we have to think about the sequencing, how we will do our sequencing of treatment. This is the data which we have. We have a very long list of trials. Some of them are outstanding and successful. And we should see how we will use such data. I will start to speak about the immunotherapy as a therapy. Of course, we know the checkmate trial, it was a negative trial, didn't meet the endpoint of overall survival. However, there was an improvement in the progression-free survival in patients with high TMB. And we have the iconic Keynote 24. Of course, all of us, we are aware with this trial, it achieved a median overall survival, updated one in the 5 years, to 26.3 months, with a difference of almost 1 year. And the 5-year survival, again, about 30%. So we consider this 30% as a benchmark for the 5-year survival with using immunotherapy. And here we can see the chemotherapy also did very well with a 15% 5-year survival in comparison to the 0% I just mentioned, because of the effective crossover for more than 66% of the patient. And we can see also a good objective response rate of about 45%, and the duration of response for about 29 months. And the toxicity rate with this single modality is reasonable, with 31% they have grade 3 to 5, and discontinuation about 14%, and they will find that the IO side effect is about 13%. So almost most of the patient who has immunotherapy related, grade 3, 5 adverse effect, they are the one who discontinued the treatment. And then we have the patient with more than 1% in the Keynote 42. And as we can see, patient with more than 1%, they achieved an improvement in the overall survival, and improvement, modest improvement in the progression-free survival. Still, there is 70% of the patient will have rapid progression within 10 months. So this is really also a problem in patient with non-high expressor with only monotherapy. In patient with more than 50%, this is a little bit less. Regarding the survival, we have a 16.4 months median survival versus 12.1 months. Overall response rate is 27% in comparison to 45 with Keynote 24. Duration of response is 20 versus 29 months. And we have the patient with more than 50%. And we believe that those patients are the category which drives all the benefit in this trial, with 20 months versus 12 months in the median overall survival. And the response rate is about 40%, a little bit less than the Keynote 24. And in the post hoc analysis, to check those from 1 to 49, they found actually they didn't do well with monotherapy. And for those category of patients, still we recommend the combination, and we can use only monotherapy as an option for those who cannot tolerate the treatment. And in this pool data of the all pembrolizumab single agent trials, we can find the patient with PD-L1 achieved the 19.4 months. And we can consider this 20 months as a median survival as a benchmark also for the single agent. And for those with without with 1%, they achieve 14 months versus 11 months. So for this pool data, still we can consider this 20 months as a benchmark. So let us see the other competitor, the atezolizumab. Did it hit also this 20 months? Here we can see an improvement in the overall survival for 20.2 months versus 13.1 months, and the hazard ratio of 0.59. So we have almost a treatment with the same efficacy as the pembrolizumab. And if we look at why it's a little bit less than the 26 months, because usually the plateau took place just below the 50%, while in the Keynote 24, the plateau showed up at the 50%. But we use the SB142, and there is sometimes discordance between patients using the antibodies SB142 versus 22C3. As you can see, only concordance in 28%. But there was further analysis for using another assay, the 2-C3, and it achieved the same median overall survival of 20 months, and also using the SB263, also 19.5 months. So if you have high expressor using the SB142 in the tumor cells or the immune cells, or using the 2-C3 or SB263, still this patient will get benefit from the atezolizumab. And you have here the list of all the front lines, and we have lastly the MYSTIC trial, as showed also by Dr. Ahmed El-Lahibi. For those with more than 50%, they achieve 18.3 versus 12.7 months. And for those patients who received durvalumab versus chemotherapy, although they achieved about 4 months difference, but still the hazard ratio was 0.76, as Dr. Ahmed mentioned, and it is a little bit higher than the 0.74 to achieve statistical significance. But as we can see, that using the monotherapy is almost identical for such pembrolizumab and atezolizumab. What about adding chemotherapy? We have also the iconic Keynote 189. In this trial, it achieved an improvement in the overall survival from 10 months to 22 months and hazard ratio of 0.556. And it doesn't matter the percentage of the PD-L1 more than 1, less than 1, more than 50, you will still achieve a benefit with the combination. And in the progression-free survival, the merit of this study is that there is no crossing of the curve and there is no such rapid progression. However, we can find the toxicity is reaching up to 70% in patients who received the chemotherapy together with the immunotherapy, and the rate of discontinuation about 36%. One of the other merit of this trial also is the response rate. It is for all the patients about 50%, and for the high expressor about 62%. So this combination can be helpful if you had the symptoms you want to control in a short time. So if we compare using a single agent versus a combination for the high expressor group, we can find actually both are almost equivalent in the 1 year progression-free survival, almost similar, 48% versus 47%. Hazard ratio for the progression-free survival, almost similar. Response rate is higher, of course, in the combination, but toxicity rate is less. So really, if there is no distressing symptoms, a patient is high expressor, and you are not in a hurry for a response, you can use the monotherapy in an effective way. Coming to the other combination, we have the Empower 150 with using the quadrate, and this achieved a median overall survival of 19.2 months. So we get ourselves also another winner. The same with the Empower 130. It showed an improvement in the median overall survival reaching 18.6 months. And in this trial, when they tried for patients with ALK and EGFR, didn't show a positive outcome. Denote that the response we had it in the Empower 150 is mainly due to using the bevacizumab together with the atezolizumab and the chemotherapy. The Empower 132 was not a successful trial. Coming for the squamous cell carcinoma, we have the successful Keynote 407, and they achieved improvement in the median overall survival from 11 months to 17 months. Of course, is less than we achieve in the adenocarcinoma. And again, it doesn't matter the PD-L1. When this trial was, resimulated again using atezolizumab, it showed a negative result. What about the IO? This is the question which have been just asked by Dr. Gazaya about using this combination. What do we have? We have the MYSTIC trial, and the MYSTIC trial, it was a negative trial. It didn't show an improvement in the median overall survival using the checkpoint inhibitor, the PD-L1 inhibitor together with CTLA4 inhibitor, and just we should skip it and just going for the NEPI Nivo-Epi. And we have some sort of, distinct, both of them are checkpoint inhibitor, but both of them, they have distinct on-off mechanism. The ipilimumab can induce the de novo anti-tumor T cell response and increasing and promoting the memory cells, where and the nivolumab will restore the actually existing T cell function and enhancing the pre-existing T cell response. We have the checkmate 227. Of course, this is with somehow complicated design, and they divide the patient into two groups: patient with PD-L1 more than 1 and less than 1. For both groups, they offer the Nivo-Epi versus chemotherapy, but in patient with more than 1, they have Nivo single agent, and less than 1, they have the Nivo with chemotherapy. The primary endpoint with overall survival in patient with PD-L1 more than 1%. Coming to the efficacy, again, I will go for those with high expressor to see this combination achieved overall response of 44%. And here we have some patients with deep response, complete response is about 9%. With this is outstanding for patients with lung cancer. In the progression-free survival, still we have the problem of this crossing. Coming to the overall survival for such patients, the median overall survival, again, it hit the 20 months. We have 21.2 months and hazard ratio of 0.7. And for those patients, still we can find the 2 years up about 50%. So half of the patient was alive after 2 years. Coming to the overall survival for the patient, we have the 3 years result. Here we can find the median overall survival 17.1 versus 14.9 in the chemotherapy, and the 3-year landmark overall survival about 33%. So almost 1/3 of the patient was alive after receiving this combination in 3 years. And if we know that usually the maximum number of cycles is up to 2 years, so still this disease is showing some sort of taking over, and patient is still showing a good result after 3 years. And it doesn't matter if it is PD-L1 positive or negative, the same result is there in the patient with PD-L1 negative. Even I can just see the difference is more obvious, more distinct in patient with PD-L1 negative, 34% versus 15% 3-year survival. And again, the same point, this area of crossing of the curve existing in the initial part of the curve, maybe this will be the reason of going for the 9LA trial. What about the overall response rate? Overall response rate is reasonable with 39% for patients with more than 1% and 27% for patients with less than 1%. And here is the point of strength of this trial, the duration of response. After 36 months, still we can find that 38% still enjoying their response after, as I mentioned, we stop the medication after 2 years. And even for those with less than 1%, we have long lasting responders. So the response with this combination usually is deep and long lasting. And here, this is a post landmark overall survival in patients who respond at 6 months. So if they respond within 6 months and they just checked, they found still 70% of the responder, they are still enjoying the response after at 42 months. And even for those with PD-L1 less than 1, still 82% enjoying the response at 42 months, or 3 years after the initial 6 months of response, as we can see. What about toxicity? Many physicians will be a little bit worried against the toxicity, and here we can find the adverse effect 3-4 is only 33%. If we can remember, with the combination chemotherapy, it goes up to 70%, but maybe, of course, the different type of side effect. And let me just tell you that the median duration of therapy is 4.2 months. So because if somebody is just worried about the cost or the financial toxicity, still the median number of cycle is not so much, so still it is affordable. What about going for the IO on the chemotherapy or the 9LA? We can see they just try to add a brief cycles of chemotherapy to try to overcome the area of rapid progression in the beginning of the curve. And here the primary endpoint was achieved in this trial with improvement in the overall survival from 10.9 months to 15.6 months with hazard ratio 0.66. And the progression-free survival also, as we can see here, we don't see this crossing in the curve, and the hazard ratio is 0.68. So here, I mean, this trial just achieved exactly what was designed for, to just have a good overall survival and to avoid the rapid progression. And then we can see the overall survival existing in all types of subgroup, except those more than 75 years old, regardless histology, if there is liver metastasis or not, bone metastasis, or even CNS metastasis. And here, this is the overall survival by the histology, and the overall survival with a different PD-L1 percentage. It doesn't matter. This is an agnostic protocol for the histology and for the PD-L1. And the overall response rate is also, very reasonable, about 38%. And as we can see, again, the merit of the combination achieving a good duration of response. But this is still at 12 months. Maybe we'll have a mature result which showed the full picture. Coming to the side effect, which is also worrisome for many of the physicians, we can find that the nivo-ipi is not more than the chemotherapy for 4 cycles, and with the presence of also maintenance, still anemia and neutropenia or hematological is less than the chemotherapy. And again, the immune-related side effect is not abnormal. Coming to another question about the quality of life, here we can find time to definitive deterioration is less using the nivo-ipi versus the chemotherapy, improving 6 items: anorexia, fatigue, cough, dyspnea, hemoptysis, and pain. So what about the special group? Now we just got an information about the available option. What about the subgroups? What about the driver mutation and the TMB? Here, for example, in TMB, actually, we don't know how to use the TMB very well, but for patient with Keynote 42 patient high expressor, when they have TMB low, still they didn't show a response. So pembrolizumab may not benefit patient with high PD-L1 if TMB was low. But using the combination will abolish the effect of the TMB. Doesn't matter in patient with Keynote 189, doesn't matter if TMB high or low, and patient with Keynote 407 doesn't matter also. Patient with EGFR shouldn't receive chemotherapy, immunotherapy upfront because it's not showing a very good response. Patient with other driver mutation except the KRAS also, they will not show a very good response. Patient with STK11 and KIAB also, they will not show good response to the immunotherapy. Maybe patient with L858R, maybe they will show some response to immunotherapy in comparison to deletion in exon 19. What about, those patients? Actually, we know that the protocol, if the Empower 150 is the protocol of choice for those patients, and we should offer the 2 drugs, the bevacizumab together and the atezolizumab. What about autoimmune disease? This is also very a strong factor to be considered before offering immunotherapy. However, still now we are less restrictive to patients with autoimmune disease. We can find that the risk of those patients is not so high, and we should choose our patient if the disease is not very active. Still, we can use immunotherapy. Patient with brain metastasis still will respond to the immunotherapy with pembrolizumab, and again also with the nivo-ipi, we can see those patients showed a good response if there is a brain metastasis or no brain metastasis. Liver metastasis is a poor prognostic factor, and still it showed a good response with the combination of the Empower 150, and even in the combination with immuno with chemotherapy in the 189, it showed also good response in the liver metastasis. So in conclusion, checkpoint inhibitor as a monotherapy in high expressor using the pembro or atezo is a standard option. However, in selected population, combination with chemotherapy still may be required, especially for those with less than 50%. Nivo-Epi in the first line dual combination demonstrate long-term 3 years survival benefit with durable responses in patients with metastatic non-small cell lung cancer whose tumor is showing PD-L1 more than 1%, because this is a primary analysis, and even those with PD-L1 less than 1%. Nivo-Epi with limited chemotherapy offers a unique treatment options across histology subtypes and across PD-L1 expression levels, and with a potential for both rapid disease control and long-term overall survival benefit observed within the first line. However, close monitoring for the patient with applying the appropriate management of adverse event. As Dr. Ghazia mentioned, you should really keep an eye, and you should offer the corticosteroid before the patient will go to the emergency. We should select the right patient based on the criteria which I mentioned for the right regimen, and to try to maximize the benefit. And finally, thank you for your being there and for your listening. Thank you.
Thank you very much, Dr. Ahmed Al-Rifai, for this interesting talk. Just before moving to the second session, I'd like to ask you one question, as actually it's fit for you more than anybody else here. Since you work now in private institute,
yes,
your decision about to use monotherapy, immunotherapy versus combination, is it medically only decision, or is it biased to the insurance level the patient has and the coverage?
Actually, yeah, this is really very valid point in the private sector. But for me personally, in our hospital, we have, let me say, a VIP patient and with a good insurance covering. So for the time being, is actually it is the medical issue. However, also sometimes the patient will start the treatment at the end of his insurance budget. Also financial toxicity is really very important, and we should do some sort of, modification of our treatment, which is called nursing-based evidence rather than medicine-based evidence. So sometimes we do some modification based on the financial availability for the patient.
I decide to go for monotherapy. How do you between pembro or atezo? Is it up like this special indication for each, or again it is up to you on the insurance cover?
Actually, I will tell you what I will just tell you. The habit that we are using pembrolizumab because it was a little bit earlier and it has mature result 5 years now. However, I think there is some sort of, maybe atezo a little bit cheaper than the pembrolizumab. So this be also a factor. And as you just mentioned, just a few minutes about the financial toxicity. So this may be one of the reasons that I can use atezolizumab because of the less price. However, regarding the efficacy, I think both of them are effective and both of them are doing great, but pembro has 5 years survival.
Okay, I think that's it. We reached to the end of this satellite symposium. Again, I'd like to thank Dr. Ahmed Al-Rifai, our
thank you so much,
valuable colleague and friend from International Medical Center in Jeddah. And now we move to the second session. It's my pleasure to introduce the other moderators, or the chairman, Dr. Fahad bin Shamsa, Senior of Oncology and Consultant in Medical Oncology, King Fahad Specialized Hospital, Dammam, Dr. Senior Medical Oncology, Consultant in Medical City. I didn't see Dr. Abdullah Shams, I think he's here. Dr. Abdullah Shams is the head of oncology in King Fahad Medical City, and Dr. Mohammed Al-Ghamdi, who just would like to congratulate him, recently became the head of section of medical oncology in King Khalid University Medical City. I think Dr. Islam and Dr. Fahad, at least I can see them, so I will leave the podium for them.
Thank you very much, Abdulaziz, for the invitation, for inviting us to participate in this great event. It's really a great pleasure to co-chair this session with dear respected colleagues and brothers, Dr. Abdullah Sham, Dr. Assam Murshid, and Dr. Muhammad Al-Ghamdi. I will go ahead and introduce the first speaker, who's Dr. Imad Hamada. He's a professor of clinical oncology and chairman of Al-Qasr Al-Aini Center of Clinical Oncology and Nuclear Medicine, Faculty of Medicine, Cairo University. Dr. Hamada will present about immune therapy in bladder cancer, how to select treatment for patients. Dr. Hamada, it's a great pleasure to have you with us here. Mic is yours.
Bismillah ar-Rahman ar-Rahim. Good afternoon, everybody. It's my pleasure to be with you in the Best of Oncology Cancer Care as a GU session. And I would also like to thank all the members of the organizing committee who give me the opportunity to be present among you in this meeting. In the next few minutes, we will discuss the role of immunotherapy in bladder cancer and how to select. This is my disclosure. And definitely we have nowadays 5 immune checkpoint inhibitors that have been licensed in the metastatic urothelial cancer. We have some that target the PD-1, other target the PD-L1, and also we have a lot of studies have been performed ranging from phase 1 to 2 to 3, and also the PD-L1 status is very important. However, the cell cycle scores have been varied between the immune cell and the tumor cell, and also the FDA and the EMA have been licensed, some of them to platinum refractory and platinum ineligible if the PD-L1 is positive, for example, for the Atezo and Pembro, while for the platinum refractory, Nivo and Durva act also on this license. However, also we have the avelumab that have been licensed as maintenance after first-line chemotherapy. And also the pitfalls here of the PD-L1 that the prevalence is not the same for all the drugs. And it ranges between 30 to 54%. And also they depend upon the company diagnostic test, and even the cutoff levels is not well understood. So the algorithm for the first-line chemotherapy for metastatic urothelial cancer from July 2018 till now, that definitely if you have a patient that is eligible for cisplatin-based therapy, you should go for GEM-CIS combination. However, if you have ineligible for cisplatin-based therapy, you should go for the PD-L1 testing. And if it is positive, you can go for immunotherapy or GEM-carbo. And if it is negative, it is only GEM-carbo. And by this, we have definitely the 2 mono immunotherapies, Atezo and the pembrolizumab. And if you say that the response in the PD-L1 positive was 47% for the pembro versus 28% for the Atezo, and also the overall survival in the PD-L1 positive patient is increased with pembro 18.5 versus 12.3 months. So why to combine immuno and chemotherapy for first-line patients with platinum eligible, whether you use platinum or carbo? And here came the phase 3 IMvigor 130, where they have patients with locally advanced or metastatic urothelial carcinoma with no prior systemic therapy, with good echo performance status should be less than 2, and they are stratifying approximately 1,200 patients by PD-L1 status, immune cell 0 versus 1 versus 2 and 3, the Badger risk factor score 0 versus 1 versus 2, or patient with liver mets, and definitely the investigator choice for the use of chemotherapy, whether cis or carbo with GEM. And they randomized the patients into 3 arms: Arm A, Atezo platinum GEM, and Arm B, Atezo monotherapy, and Arm C is only platinum GEM plus placebo. And they have a co-primary endpoint. The investigator assessed PFS and overall survival, mainly between Arm A versus C. Then they go for the overall survival between arm B and C in a hierarchical approach. The key secondary endpoint is the response rate, duration of response, PFS, and overall survival, especially in arm B versus C, according to the PD-L1 subgroup, and lastly, the safety. And if you look here to the final PFS in the intent to treat population, definitely the primary endpoint has been met in favor of the atezo-platinum gem versus platinum gem, with a very good hazard ratio of 0.82 and statistically significant p-value, 8.2 months for the atezo-platinum gem versus 6.3 for the platinum gem. However, the interim overall survival for the intent to treat population is not statistically significant. It was not met because of the border of the alpha, and they stated, although numerically it is much better, 16 months versus 13.4, and have a hazard ratio of 0.83, but look to the p-value, one-sided, it was 0.027. So the co-primary endpoint of PFS was met. However, the co-primary endpoint of the overall survival was not met with the addition of atezo-2 platinum gem. But when you go for the interim overall survival and combining the arm of monotherapy atezo versus platinum chemotherapy by the PD-L1 status, again, if you have a PD-L1 of immune cell 0 to 1, definitely you didn't have any advantage for arm over the other. And as you see, 13.5 months versus 12.9 months for the platinum gem, which has a ratio of 1.07. But if you go to the PD-L1 immune cell 2 and 3, definitely the curves start to separate as early as the 3 months, and you can get a hazard ratio of 0.68 in favor of the atezo monotherapy versus the platinum gem. Concerning the confirmed overall response rate and duration of response, if you add atezo to the platinum gem, you have an overall response rate of 47%. However, for the platinum gem, it is 44%. However, for the monotherapy, it was less, 23%. Also, the median duration of response is 8.5 for atezo platinum gem versus 7.6 for the platinum gem placebo, and not estimable for the atezo. Also, we have the Keynote 361, which is the first-line pembro chemotherapy or both in advanced urothelial carcinoma. It is open-label phase 3 trials recruiting 1,010 patients with advanced unresectable or metastatic urothelial cancer. And here we can include the renal pelvis, the ureter, and the bladder and urethra with no prior systemic treatment for advanced disease and ECOG performance status between 0 to 2. And they randomize the patient according to the PD-L1 combined positive score more than 10 or less than 10, and the choice of platinum, whether cis or carbo. And they randomize the patient into 3 arms, pembro plus gem-cis, pembro alone, and gem-cis or gem-carbo alone for at least 4 to 6 cycles. And here they maintain those who attain a stable disease or partial response to pembro at 200 milligrams every 3 weeks to approximately 29 cycles. The primary endpoint definitely is the PFS and overall survival. However, the PFS is dependent by the blind and independent committee review, and this has been published at the ESMO 2020. And unfortunately, this results is a negative study. Concerning the PFS by the blind independent committee review and overall survival, and as you see, pembro added to chemotherapy had a PFS of 8.3 versus chemo 7.1. Hazard ratio 0.78, p-value 0.0033. However, the boundary for significance should be less than 0.0019. Also, the overall survival, the two curves are overlapping each other, although numerically you have a better overall survival, pembro plus chemo 17 months versus chemotherapy at 14.3. with a hazard ratio of 0.86, but the p-value also is insignificant, 0.0407, while the boundary for significance at the final analysis should be less than 0.0142. But if you go for the median PFS by investigator assessed, definitely it was in favor of pembro plus chemo, 8.3 versus 6.5, and the hazard ratio moved from 0.78 to 0.69. Also, we have the Danube, which is the first line durvalumab plus or minus tremelimumab versus chemotherapy for advanced urothelial carcinoma. And it was a randomized open-label multi-center phase 3 study. They recruited also a very good number of patients, 1,032 patients. Again, with a creatinine clearance more than 30 mL per minute, very good echo performance status, locally advanced or metastatic urothelial cancer, and the tumor tissue is available for PD-L1 assessment. And they randomize the patient again according to the cisplatin eligibility, PD-L1 status high or low, and liver and lung metastasis present or absent, to durva plus tremelimumab, and the standard of care chemotherapy for 6 cycles. The primary endpoint was overall survival with durva versus chemotherapy in the PD-L1 high patients, and the overall survival with the combination of durva, tremi versus chemotherapy in the intent to treat population. And then came the secondary endpoint, which is overall survival of durvalumab versus chemotherapy in the intent to treat population, and also for the combination versus chemotherapy in PD-L1 high patients. Look to what we have. Definitely, it's also a negative study where the overall survival in the PD-L1 high patients, durva versus chemotherapy, the two curves are overlapping for the first 1 year. However, it reaches 14.4 months for durva versus 12.1 for the chemo, with a hazard ratio of 0.89 and the statistical non-significant p-value of 0.3. Also, for the overall survival in the intent to treat population, durva plus tremelimumab, although it have a 15.1 month overall survival versus 12.1 chemotherapy with a hazard ratio of 0.85. However, it is not statistically significant with a p-value of 0.075. If the secondary endpoint, definitely for the median overall survival with durva tremelimumab versus chemotherapy in the PD-L1 high patient, it is statistically significant, 17.9 versus 12.1, with a hazard ratio of 0.74, but the median overall survival with durva as monotherapy versus chemotherapy in the intent to treat population was not statistically significant, 13.2 versus 12.1, with a hazard ratio of 0.99. So what we have from the Keynote 361 and the Danube trial, that they found no overall survival benefit to either the combination of anti-PD-1 plus chemotherapy or the anti-PD-L1 plus the CTLA-4 tremelimumab versus chemotherapy alone. Also, we have a higher overall response rate with chemotherapy alone than durva, even in the PD-L1 high population. And in the context of the Javelin 100, they reinforced the use of platinum-based chemotherapy as preferred first-line option, and to reserve the checkpoint inhibitors for subsequent therapy as either maintenance after platinum-based or salvage as second line or beyond treatment. And now we came to the Javelin Bladder 100, which is an open-label randomized phase 3 trial where they go for patients with unresectable locally metastatic or advanced urothelial carcinoma who attain CR, PR, or stable disease with 4 to 6 cycles of the standard first-line chemotherapy, cisplatin gem or carbo-gem. They recruit 700 patients, and they go for a treatment-free interval between the chemo 4 to 10 weeks to stratify the patients according to the best response to first chemotherapy, the metastatic site, whether visceral or non-visceral, to AVI 10 milligram per kg every 3 weeks plus best supportive care versus best supportive care. And here the best supportive care could be either antibiotic, nutritional support, hydration, pain management, or even palliative local radiotherapy for some isolated lesions, but no other systemic treatment. They treat the patients until progression of disease, unacceptable adverse events, or withdrawal. And the primary endpoint was overall survival for all comers and PD-L1 also positive population. Secondary endpoint, PFS, overall response rate, safety and tolerabilities, and patient-reported outcomes. This also, Javelin Bladder 100 has been published at ASCO 2020 by Paul. And as you see here, that the avelumab improves overall survival in the overall study population from 14.3 for the best supportive care alone to 21.4 for the avelumab plus best supportive care, with a hazard ratio of 0.69 and statistically significant p-value. And as you see, the curves start to separate after the first 2 months and continue to separate to the tail of the curve. Not only that, but concerning the subgroup analysis of the overall survival, definitely all patients have a trend for overall survival favoring the AVI plus the best supportive care. However, it is more with the ECOG performance status 0, also for those attaining CR or PR, much better than those with stable disease. Also for non-visceral metastasis, much better than the visceral metastasis. However, concerning the creatinine clearance, whether you have more than 60 or less than 60, it is the same. And for the PD-L1 status, definitely it is positive for the PD-L1 negative also. It shows some positivity, and the unknown also, but the highest is for the PD-L1 positive. Also, avelumab improved the PFS in the overall study population. It will be unique to have immunotherapy that causes an improvement in the PFS. But here, because it is instead of the best supportive care, we have 3.7 for the avelumab best supportive care versus 2 months for the best supportive care. And again, the hazard ratio of 0.62 with statistically significant p-value. And due to the 1 year PFS, it is 30% versus 13% for the best supportive care, which means that we can double the PFS by 1 year maintenance avelumab. Also, concerning the subsequent anti-cancer therapy, we have more discontinued and more patients receiving subsequent drug therapy in 62% for the best supportive care versus 42.3% for the avelumab plus best supportive care. And also, those patients who are still ongoing on the study treatment are more in the avelumab plus best supportive care, 24 versus 7% for the best supportive care alone. So the first take-home message is that according to the ESMO clinical practice guidelines, which have been updated at July 16, 2020, that cisplatinum eligible patients still cisplatin-based chemotherapy is of level 1A evidence to be followed by maintenance avelumab for tumors which have not progressed on chemotherapy, also designed as level 1A. For cisplatinum ineligible and PD-L1 unknown or negative, GEM-carbo designed as 2B, followed by maintenance avelumab for tumors who have not progressed on chemotherapy, designed as 1A. However, for cisplatinum ineligible and PD-L1 positive, GEM-carbo followed by maintenance avelumab, which have not been progressed on chemotherapy or monotherapy, atezo or pembro, with a level 3B evidence. What about the second or subsequent lines of therapy in metastatic urothelial cancer? Definitely, we have accelerated approval for the atezo, niva, durva, and the avi. However, the only one that have received the level 1 evidence was the pembro through the keynote 045. And at this, the dose regimen have been 400 milligrams every 6 weeks is approved under accelerated approval. These are the overall response to immunotherapy in bladder cancer after platinum therapy. We all know that chemotherapy only give an overall response of 10%. However, this has been doubled by the pembro and nivo and reached approximately 13.4 for the atezo in the IMvigor 211, 16.5 for the avelumab, and 17.8 for the durva. Also, the 1 year overall survival in the bladder cancer after platinum therapy, chemotherapy give only approximately 26% 1 year overall survival. However, we can reach a double also with the pembro, 44, 40 with the nivo, 46.6 with the durva, and 39 with the atezo, and 35.9 with the avelumab. We have also the keynote 045, which proves that we have an advantage for the overall survival with pembrolizumab in recurrent urothelial carcinoma, where they improved the median overall survival from 7.3 to 10.1, with a very good, again, hazard ratio of 0.70, which means that we have 30% reduction in the death rate of those patients receiving in recurrent urothelial carcinoma with pembro. Also, we have the IMVigor 211, where we have the overall survival with atezo versus chemotherapy for PD-L1 positive. It was numerically 11 for the atezo versus 10.6 with hazard ratio of 0.87. However, it was not statistically significant, but it starts after 10 months to show differentiation between atezo and chemotherapy in favor of the atezo. Concerning the objective response rate for the all-comers, pembro did better than chemotherapy, 21.1 versus 11, and also for the population of with PD-L1 positive with combined positive score more than 10, again, it is 20.3 versus 6.7 in favor of the pembro. What about the correlation between the tumor mutation burden and overall response with PD-1, PD-L1 target therapy? This had been published 3 years ago at the New England Journal of Medicine 2017 by Arokan. The tumor types with higher mutation burden have a higher response rate with PD-1, PD-L1 blockade, as you all know, especially the non-small cell lung cancer and the urothelial cancer also. And from the phase 2 Checkmate 275, where they go for nivolumab, they show definitely that bladder cancer with higher tumor mutation burden have a higher response rate and even higher median survival. So if you see that the overall response can reach 32% versus 11% with low tumor mutation burden, and also the survival increase from 5.7 months to 11.6 months if you have a tumor mutation burden high. So now we also have another very well understood treatments that make some difference in the management of urothelial bladder cancer, as the enfortumab vedotin, which is an antibody drug conjugate targeting the Nectin-4. The Nectin-4 is a transmembrane cell adhesion molecule that is highly expressed in approximately 97% of the metastatic urothelial carcinoma patients. And the enfortumab vedotin is a fully humanized monoclonal antibody against the Nectin-4 conjugated with microtubule disrupting agent, the monomethyl aristatin, by a protease cleaver linker. And through this EV201 cohort 1, which is a phase 2 trial of the enfortumab vedotin 1.25 milligram per kg after platinum-based chemotherapy and the immune checkpoint inhibitor, we have a very amazing overall response rate, which reaches approximately 44%. And also we have a tumor shrinkage in approximately 84% of the patient. Also, the PFS is approximately 6 months, and you have approximately 1 year overall survival through this phase 2 trial, which are definitely encouraging results. But definitely you have some treatment-related adverse events, mainly peripheral neuropathy, rash, and hyperglycemia. Also, we have another drug, which is erdafitinib, which is an anti-fibroblast growth factor receptor, and definitely it was used after 1 line of platinum-based chemotherapy. It is an oral pen fibroblast growth factor inhibitor, and through this phase 2 pivotal trial, we can have an overall response rate that reach 40% and the median overall survival of approximately 1 year plus. And this have been the updated PFS and overall survival. Again, it is quite comparable to the enfortumab, 5.5 months as median PFS and 11 months as the median overall survival. But definitely the treatment-related adverse events are of importance of grade 1 and 2, and they have the central retinopathy. This is an established class effect of the MAPK pathway inhibitors, and definitely you have some skin events, hyperphosphatemia, which is approximately of 2% of grade 3, and some nail events and ocular events. So the second take-home message that PD-1, PD-L1 inhibitors are approved also in the post-platinum setting with level 1 evidence for pembrolizumab only, and the first-line maintenance immune checkpoint inhibitor, Javelin Bladder 100, will impact the role and the use of immune checkpoint inhibitor therapy in the second-line setting. Also, we have the enfortumab vedotin could be an option. Still, we are waiting more phase 3 trials and molecular testing. Also, the fibroblast growth factor receptor 2 or 3 genetic alteration should be taken into consideration, and definitely the erdafitinib can be used in those patients. Concerning what is new, that definitely we have at the GCO published by Carlo at the 2020 that we have some germline variants in urothelial cancer. And how about the frequency and the penetrance? Definitely 86.6 have no germline mutation. However, they pick up approximately 13.7 that they can have some of these germline variants, especially 5.8 for the BRCA1 and BRCA2 in 2.9%, the MSH2, 6, and MLH1, 2%, and others. And because of this, we have the BOCC trial, which is a durvalumab-based biomarker-directed randomized trial in the metastatic urothelial cancer. It is a multi-arm phase 1b trial. Based on the biomarker, you can choose your treatment, and these have been for patients receiving more than 1 line of platinum-based chemotherapy or progression for less than 1 year of perioperative platinum-based chemotherapy, definitely with good performance status and the archive tissue for biomarker assessment. As it is phase 1b, they recruit only 108 patients. The biomarker is fibroblast growth factor receptor 1, 2, 3, either mutation or fusion, the ATM, BRCA1 and 2, or the homologous recombination repair gene as in prostate cancer, and the rector with the tuberous sclerosis 1 or 2, and lastly, no biomarker selection. And according to this, they go to either the erdafitinib plus durvalumab or olaparib plus durvalumab, the vistiristinib plus durvalumab and durvalumab only, as also it is a phase 1b, the primary endpoint was safety and tolerability. This usually definitely the biomarker through the DNA analysis. And as you see, the response rate is the highest, reaching 35.7 for the olaparib durvalumab for those who have ATM or BRCA1 or BRCA2 or the homologous recombination repair gene alterations. And definitely the PD-L1 positivity have been 50%, and the tumor mutation burden more than 10% was reached in approximately 54%. What about the ongoing research? Definitely we have the CheckMate 032, Nivo versus Nivo plus Ipi in locally advanced. It is phase 1/2 trial, and they recruit 274 patients with a primary endpoint response rate and duration of response to Nivo at 3 milligram every 2 weeks, Nivo at 3 milligram, Ipi 1 milligram every 3 weeks for 4 cycles, and Nivo 1 milligram plus Ipi 3 milligram every 3 weeks for 4 cycles. And they maintain those patients who have good response and tolerability to Nivo as maintenance 3 milligram per kg every 2 weeks. What we have, that definitely the response rate is much higher, 38% with Nivo 1 milligram plus Ipi 3 milligram, and also the median PFS reached approximately 5 months with the Nivo 1 milligram, Ipi 3 milligram, and Nivo 1 milligram, also Ipi milligram, we have a median overall survival of 15.3. These are the response to the AVI, and as you see, for PD-L1 more than 1%, it reaches approximately 54.8%, which is the highest. So the conclusion, after the emergence of cisplatin in the late 70s, there was a paucity of new therapies until the year 2008, when the efficacy of GEM has been demonstrated. And definitely since 2016, we have multiple new therapies that have been approved, including the immune checkpoints, ERDA and enfortumab vedotin, and also the cisplatin, although this remains the first-line standard of care for patients who can tolerate and can result in durable response for a small subset of patients with advanced disease. The Javelin Bladder 100 trial confirms that to date, platinum-based chemotherapy remains the most effective first-line therapy. However, the paradigm shift that switch maintenance with avelumab is preferred for those patients who did not progress on the initial chemotherapy, because this maintenance therapy have been associated with improved survival and delayed disease progression. Not only that, PD-L1 and PD-1 are approved in the post-platinum setting with level 1 evidence for pembro. Enfortumab could be one of the options for those who had received platinum-containing or PD-1, PD-L1 inhibitors, and also the erdafitinib for those with fibroblast growth factor receptor 2 or 3 genetic alterations. And still biomarker-directed therapy could be a step towards better personalized medicine, and we should wait more and more trials in order to have this precision medicine. And thank you very much for your kind attention.
Thank you very much, Dr. Ahmad Hamada, for this elegant and comprehensive presentation. We will have a Q&A time after completing the presentations of this session. And it's time now to hand the mic to my dear colleague and brother, Dr. Abdullah Shorm, the Director of the Cancer Center in King Fahd Medical City, to introduce the next speaker, Dr. Abdullah.
Thank you so much, Dr. Fahad. It's my pleasure to be with you. Special thanks for my colleague in Prince Sultan Military Hospital for their kind invitation and a very excellent meeting. So it's my pleasure to introduce Prof. Mark Totel. He's a consultant medical oncologist in Manor Hospital and Maggie Cancer Center in Oxford. His special interest in GU and breast cancer, and he's going to enlighten us today about best treatment sequence in metastatic renal cell carcinoma. And we are also very proud that we are going to have another lecture from him about how to treat hormonal sensitive prostate cancer in 2020. So Dr. Mark, the mic is for you, please.
Brilliant. Thank you very much for the introduction. Can I just confirm you can see my slides?
Yes, sir.
Brilliant. Well, thank you very much for the introduction. It's a great pleasure to be invited to this meeting. I have to say I've greatly enjoyed the talks thus far. I'm going to talk to you about the best treatment sequence for metastatic kidney cancer. So the first thing I'll say is this is my view on it, and I think the key things for the learning for this is really that we can all think about how we might do things differently, particularly in the first line setting, which has seen a tremendous change in how we treat advanced kidney cancer over the last few years. So this is where I work. This is Oxford in England, and this is the cancer centre here at the Churchill Hospital, and this is where my research is based at the Jenner Institute here. This is also where they have invented the Oxford COVID vaccine as well, just in this sort of section of rooms up here. So these are my consultancy and disclosures. So the overview of my talk is about the current treatments for advanced kidney cancer, and I'm really going to talk about the optimum sequence of drugs or combinations of drugs for the first line treatment of advanced kidney cancer. And the reason for focusing on this is really principally because this is the area which has changed the most over the last few years. And then I'm also going to touch briefly at the end about the treatments for advanced kidney cancer and second line and beyond. So what do we mean by kidney cancer? Well, we mean a number of different things. The first thing is the commonest type of kidney cancer is clear cell renal cell carcinoma. This is the WHO classification. The second commonest type, at least in the UK, is papillary renal cell carcinoma. And then there are other groups as well. There are chromophobe and sort of unclassified kidney cancers. And then the other group over here, a few of these metabolically deficient kidney cancers, these really make up the kind of small print, if you like, of advanced kidney cancer. But nevertheless, all of us will have some of these patients who treat kidney cancer in our clinics. And so what are the aims of treatment for metastatic kidney cancer? Well, the first aim is to control the cancer. And what do we mean by that? Well, we mean giving the treatment and the cancer stops growing. There's improvement of symptoms or delaying the onset of symptoms from metastatic disease. And these are all really encompassed with control. And then over the last sort of 15 years or so, we've seen therapies which clearly improve overall survival. And then really this is one of the key areas that we're questioning now is, do immunotherapy treatments cure the patients that we treat in the clinic? And this is something which I think is going to become increasingly important as we think about which treatments do we start with and what's the sequence that we should follow. So what are the validated therapeutic targets in advanced kidney cancer? Well, there's VEGF and VEGF-related signaling, and we've got many drugs, so cabozantinib, sunitinib, and these are all the sort of TKI-based treatments which target this. We've got PD-1, and these treatments include nivolumab, pembrolizumab, and avelumab. We've got CTLA-4, and the treatments for that include ipilimumab, mTOR, and everolimus, and then there's combinations approaches, and then there's HIF signaling, and there's a molecule which targets HIF signaling, MK6482, and I think this has been partially validated in early phase clinical trials. So how do we treat kidney cancer? Well, the treatments that we use that target kidney cancer include drugs which block the degradation of, the treatment of kidney cancer involves targeting HIF, and HIF-1 is a transcription factor which is constitutively active. The transcription factor HIF, once it's produced, it's unusual and it requires hydroxylation by VHL to be degraded. And if you lose VHL, and the VHL loss is seen in about 80% of clear cell kidney cancers, then that HIF transcription factor becomes constitutively active, and that leads to downstream gene activation changes. There are other changes which are involved in that as well. Now, how do we target kidney cancer and treat that? Well, over the last sort of 10 years, there's been a tremendous progress in that. The first thing to say is that the kidney cancer cells don't exist on their own. They exist in a relationship with endothelial cells, for example, here, and these provide the support structure or the vascular tissue. You can target this by blocking VEGF and VEGF-related signaling, and here in the cartoon here, you've got axitinib. You can also block the interactions between immune cells and the tumor cells, so that's blocking PD-L1 by drugs such as avelumab, and blocking PD-1 by drugs such as nivolumab and pembrolizumab. You can also look at therapies which block the interactions between T cells and dendritic cells, for example, and CTLA-4 can be blocked by ipilimumab, and that really takes the brakes off the immune system in a very non-specific way. And some of these therapies are synergistic together, so we see therapies which work very well, for example, together. So ipilimumab, that works between the sort of T cell interaction, and then there is nivolumab, which works really between the tumor cell and T cells. But of course, I think one of the things that we know is that though the targets are specific, nobody really can give you a clear indication about how the drugs work, because each individual patient will have a different combination of immune cells within their tumor. Now, how do we sort of stratify patients within the clinic when we're thinking about the sequence? And this stratification can work on the first or the second line. And there's the IMDC criteria here, which are listed. These make up actually a very handy set of clinical parameters we can use. So performance status, hemoglobin, time from diagnosis, and calcium. And the great thing is it doesn't require a fancy assay. We can actually just do this in the clinic and use straightforward calculators to work out what to do. Now, when we're thinking about sequences of treatment, I think the first thing to work out is what risk group somebody's in. And the reason for that is that gives you an indication of how right you have to get your first treatment. So if somebody's got an unfavorable tumor, then you may want to start them with your most important, most well-tolerated combination of active drugs. Whereas if somebody's got a favorable tumor, you may wish to think about, could they go on to a single agent TKI? So what are the first line treatment options? Well, the first line treatment options includes watch and wait, and that would be for good prognosis, selected intermediate prognosis patients. This would include single agent TKI treatment, for example. Although I think you'll see from the data I'm going to present, I think this approach is probably in the past now. For intermediate and poor prognosis disease, we've got IO, and we've got IO TKI combinations for all prognostic groups. Now, over the last sort of 10 years, there's really been an explosion in treatment options for advanced kidney cancer. Anyone looking into the field would think, oh my goodness me, there's a lot of drugs to take in. And I think you'd be right. I think one of the key things is to remember is that we can only use a certain number of treatments. And the most important drugs in combinations, in my view, were the initial TKIs, so sunitinib and pazopanib, Axitinib made a modest impact in terms of second-line treatment, and then things really started to move with the introduction of nivolumab as a single-agent immunotherapy treatment, cabozantinib as a highly effective second-line treatment and beyond, and of course a first-line treatment. We've got tivozanib, a new TKI, and then we've got the most important developments recently, which is nivolumab and ipilimumab, and axitinib, pembrolizumab, or avelumab. So what about first-line treatment for advanced kidney cancer? Well, these are the current ESMO guidelines, and I think one of the things to bear in mind is that when we stratify our sequence, we really think about intermediate, poor, and good prognosis treatments. This would include, for most patients, for the good risk, either pembrolizumab or axitinib, and you can see how fast things are changing as these guidelines have already been updated, and we could also consider avelumab and axitinib in this situation. For intermediate risk patients, they get a prospect of a number of different choices, including pembrolizumab and axitinib, and ipilimumab and nivolumab. And poor risk patients get a slightly different choice of treatments, but again, very similar. I'm going to go on to next talk about the choices for first-line treatment. So the CheckMate 214 study, which was first presented a number of years ago, is looking at the combination of ipilimumab and nivolumab in patients with advanced kidney cancer. Nivolumab was given slightly differently in this study, and the ipilimumab was given slightly different in the study relative to the melanoma schedule. And the key thing to note is the ipilimumab is at a dose of 1 milligram per kilo, unlike in the melanoma dose of 3 milligram per kilo. And you get a kind of induction phase of combination therapy followed by maintenance nivolumab. And they compared this to Sutent, 50 milligrams once a day, for 4 weeks on, 2 weeks off, which is a standard schedule. I think the key thing here in this data is there was a clear prolongation of overall survival in this group. What we can see here is the curves actually stay the same initially. And I think this is important to remember. In some IO studies, we see an inferior outcome for patients who start with IO versus chemotherapy, as we heard in the long talks this morning. But really, there's no difference here initially. So actually, in somebody who's got bad or intermediate risk disease, and this is the main patient population, there isn't a detriment for them going ahead with ipilimumab and nivolumab treatment. What you can see here is as time goes on, and that's the interesting thing about IO therapies, the curve appears to be flattening, but there are of course less patients on this part of the curve. Nevertheless, there's a significant reduction in the risk of death, and you can see that overall survival is significantly prolonged, with 52% of patients at this analysis, which was presented at ESMO, being alive at the 42-month point. What about adverse events? Well, one of the things we were all worried about with combination immunotherapy was that the adverse events would be very severe. And that's one of the things we've learned from the melanoma team. And I think we're fortunate in kidney cancer that we went 10 years after they introduced sort of ipilimumab into their clinic. And one of the key things that we saw was that the adverse events actually were pretty similar between the two arms. I have to say this is a slightly misleading slide because it does highlight all the TKI adverse events, which are sort of to the right of the panel. Nevertheless, what it does show is that, in fact, ipilimumab and nivolumab causes far less diarrhea, for example, than Sutent treatment. Although I must add that the diarrhea that you can get from combination immunotherapy has to be managed quite differently from Sutent diarrhea. Now, what about the response rates? And I think that's really important when we're thinking about initial treatment. How good is it exactly? And one of the key things we see is the response rates with IO treatment for patients are actually very, very high. And in fact, they look higher overall than patients who have a TKI-based treatment. Again, that's slightly misleading because quite a lot of patients won't meet a RECIST response with Sutent, but will still have a response. But one of the things which is really interesting is we see about 10% of patients will have a complete response, in other words, a disappearance of their tumor. And this group is of particular interest. What about the side effects? Well, I think the key thing is, well, when you start the treatment, there is a risk of side effects. So they could be pulmonary, pneumonitis, gastrointestinal, so that's inflammatory, hepatic, so renal dysfunction, liver dysfunction, renal dysfunction, and endocrine side effects. And quite a lot of these came on during the induction phase, and then most of them resolved very successfully. Now, what about quality of life during the treatment? And I think that's really, really important. What we saw here with quality of life is unlike with Sutent treatment, where you get an initial sort of decrease in quality of life, and whilst you get the dosing sorted out, that seems to stabilize. With immunotherapy, it gets better. In other words, the longer you stay on the treatment, patient's quality of life goes up. Now, of course, there's a selection in this. If you're doing well, you get on with the treatment, you stay on there. But nevertheless, this is the first time I've ever given a treatment in my clinic where actually patients feel better along with they've been on the treatment. And I think that's really, really good. What about avelumab and axitinib versus Sutent for advanced kidney cancer? So this is an important new treatment first presented by Robert Motzer, only last year, in fact. And they took a very similar population to the Keynote 214 study, but this included all-comers rather than the Keynote 214, which was intermediate and poor prognosis and the primary analysis. This was patients who had all subgroups of kidney cancer. Now, who went into it? Now, it's a bit difficult to see on this slide, but you can see here the majority of patients were in the intermediate group, and there were a few patients in the favorable and a few patients within the poor. Was there any difference in outcome in patients who are PD-L1 positive versus negative? And what we could see here is that the progression-free survival was considerably improved, and it didn't really make any difference whether you're a PD-L1 or PD-L1 positive or PD-L1 negative. And I think the key thing to bear in mind here, from a practical point of view, is that there isn't any, PD-L1 and PD-1 isn't really a biomarker in advanced renal cell carcinoma, at least within the context of checkpoint inhibitors. Now, what about a subgroup analysis? Well, it's difficult to read too much into this, but I think what we can see is the bars are clearly to the left favoring the axitinib combination. What about the response rates? You can see here the response rates are deeper with avelumab versus axitinib. The anti-tumor activity was very, very similar. We saw good rates of partial response and stable disease, and this was clearly superior to Sutent treatment. Adverse events were very, very similar, not much dissimilar from giving Sutent treatment on its own, but with the added complications, of course, IO side effects. And I think in practice, when we're using these drugs, I think that's one of the things we have to do. It's very straightforward. When you've just got an IO combination, it's easy to manage the adverse events because you can say it's all IO. With TKI combinations, it's a little bit more complex, but it's definitely practically doable. Now, there's another study, which is pembrolizumab plus axitinib, and again, compared to Sutent in advanced kidney cancer. This was again published very, very recently. And again, who went into the study? Well, a very similar group. You could have a look, and it made up there were more favorable patients in this study versus the previous two I presented. And what you can see here is, again, you saw a very, very good response, and the overall survival was clearly better. What you can see down below is all of the subgroups had a favorable outcome, and the one group that was of interest is that the poor prognosis group clearly did better if they had Sutent. I must add, this is a small cohort of patients. What about progression-free survival? Again, very, very similar to the previous IO checkpoint inhibitor study, the avelumab data. And again, what you can see here is if you add the two together in immunotherapy and you add it in a TKI together, in this case axitinib and pembrolizumab, you see an improvement in activity. And again, response rates are very good. I think it's noticeable from both the avelumab and pembrolizumab data that their complete response rates are not as high as with Sutent versus as with ipilimumab versus nivolumab together. What about adverse events? Again, adverse events that causes treatment discontinuation. Again, about 10 people, 1 in 10 people will have to stop due to adverse events, which is an acceptable ratio in my view. Now, what about second-line treatments? Well, I think the first thing to say is I think for all patients that start now treatments for advanced kidney cancer, I think the most important thing is they start a really effective first-line treatment. So for patients who've got intermediate prognosis disease or poor, we either start with an IO-TKI or we start with a IO-IO combination. Second line things are more complicated, and I haven't got time within the context of talk to go over all the different rationales. However, there is very good evidence that cabozantinib works well after initial IO treatments, and certainly the response rates to cabozantinib are very high. However, what we've done in the UK is the UK has taken quite a pragmatic view, and essentially once you've gone through your IO-TKI combination, we then move on to a single agent approach, which is usually, say, for example, cabozantinib, but axitinib, or tivozanib, pazopanib, Sutent would all be reasonable combinations. And what we tend to do is to then reset things and go back to the original sequence that we're working on. There are studies addressing this area. There was the TiVo3 data, which was presented at GUASCO last year, which showed that tivozanib was active post-IO. In terms of third-line treatment for advanced kidney cancer, again, I think this very much depends on what you've had before. I'm sorry about the noise in the background, by the way. I think a car alarm is just going off. Once you've got to the third-line treatment of advanced kidney cancer, you're down to sort of what are the standard options. So if you haven't had cabozantinib yet, and this is definitely when I get it out, if you've only had one line of TKI so far in a previous IO, then nivolumab and everolimus is also a good option. And again, we do occasionally use everolimus or other related treatments. So what's my summary? Well, I think first of all, we've got three new combinations as first-line treatments for advanced kidney cancer. There are more coming, so levantinib and pembrolizumab data was positive. You've got cabozantinib and nivolumab. And essentially, I think the take-home messages from that is if you add a TKI and single-agent checkpoint inhibitor, you get a good response, which is better than TKI on its own. And essentially, we're still looking at optimum treatments for the second-line treatment post-IO and IO-TKI treatment. So I'm now going to stop there, and I think I'll move on to my next presentation after just a short break.
Yeah, you can proceed, Professor, to the second lecture.
Can I just confirm we've got my slides?
Clear.
Yes. All right, excellent. Thank you very much. So we're now going to sort of switch topic completely, really, and talk about the initial treatment for hormone-sensitive prostate cancer. And again, like the treatments for advanced kidney cancer, this is an area of cancer medicine which has changed hugely over the last sort of 5 years or so, or 6 years. So again, this is where I work, and these are my disclosures. So I'm going to talk about 3 parts of the treatment for hormone-sensitive metastatic prostate cancer. I'm going to talk about the role of radiotherapy, an overview of current treatments for advanced hormone-sensitive prostate cancer, the optimum choice of drugs for the first-line treatment of advanced hormone-sensitive prostate cancer, and I'm going to talk about the role of chemotherapy, particularly with respect to docetaxel in 2020. And all of these areas are, in fact, highly topical. So first-line treatment, what do we mean by that? So what we mean with first-line treatment is we mean patients who've been newly diagnosed, and most of the men that I see in my clinic have got de novo metastatic prostate cancer. In other words, their first presentation with the disease has been with prostate cancer, which has spread mostly to bone, but occasionally we see patients with just lymph node positive disease that we treat in combination with, usually with our radiotherapy colleagues or clinical oncology colleagues. And these patients have all been started on hormonal treatment with either an LHRH agonist or degarelix when they first get diagnosed. So what are our aims of treatment of metastatic prostate cancer? We've got control of the cancer, which we're aiming to achieve, and that's usually achieved very satisfactorily with the initial hormone treatment that we use. We're aiming to improve symptoms or delay the onset of symptoms. Again, hormone treatment does this very well on its own. And I think the key thing that we've seen over the last few years is a multitude of treatments which improve overall survival in the first-line setting. And these are all, I think, some of the most important transformations in the treatment of advanced prostate cancer we've ever seen. And I think increasingly for some patients, we're looking at long-term disease control. In other words, we've got this cohort of patients we've always had. They've always done well with just hormonal treatment. But increasingly, we're starting to take patients with more adverse features, put them on highly effective medical therapies, and then that leads to long-term disease control. So how do we sort of split up our patients with metastatic prostate cancer? Well, one of the ways of looking at it, and this is something which first really appeared in the CHARTED study, which was presented by Chris Sweeney and ASCO in 2014. And when you take somebody who's got hormone naive disease. In other words, they've just presented. You can divide them into low burden disease based around the number of metastases, for example, what they've got, how many areas of the skeletal spine they're involved, how well they are. And then you've got high burden disease, which has got lots of metastases, say more than 4, affecting different areas. And there's a number of different versions of this. There's a Stampede version, and there's a charted version, there's a latitude version. And I don't think there's really much to sort of choose between them. And I'll explain why that a little bit later. Now, what are our treatment options for newly diagnosed men with advanced hormone-sensitive prostate cancer? But if you've got low burden of disease, you can give patients docetaxel or abiraterone. If they've got low burden disease, you can also have enzalutamide or apalutamide, and they can have prostate radiotherapy. High burden disease, they can have either hormones, docetaxel, abiraterone, or enzalutamide or apalutamide. Docetaxel at the moment in the UK isn't being used very much because of the coronavirus pandemic, and I'm going to talk to you about several reasons why we should perhaps put docetaxel to one side, other than for reasons of cost and short-term side effects later in the talk. So I think we're very lucky in the UK to have the Stampede study, which has been organised by Professor Nick James, who's now based in Birmingham. And this is a huge multi-cohort randomised phase 3 platform study looking at many different types of treatments for advanced prostate cancer. We've recruited a lot of men in Oxford to Stampede. And the really good thing about Stampede is a fairly pragmatic design. In other words, it takes men that we would all see in our clinic generally, and we put them into Stampede study, and Stampede's done in the UK, it's also done in Switzerland, and we get some results out, and we know that these will affect, these results are very similar to what you would get in other studies around the world, and also it's given the UK tremendous insights into how we can best improve our management of prostate cancer. Now, the thing about Stampede, which is pretty amazing, is the scale of it, and it's also got quite a lot of complexity in there, because you've got different arms here. And the analysis I'm going to talk to you a little bit about for the docetaxel analysis, which was presented after the charted analysis, it had 2 different groups, and it had patients who were given zoledronic acid or bisphosphonate, and it had patients who were given docetaxel as well. And what you could see here is that the failure-free survival for patients who were given the docetaxel was better than the patients who were given docetaxel plus zoledronic acid. And there was no difference in outcome for patients who were given zoledronic acid. So we showed that zoledronic acid didn't have an advantage, but we also showed that failure-free survival was better and overall survival was better by around about 9-10 months if you had docetaxel overall. Now, what about different groups of patients? And I'm afraid this is a very busy slide, but essentially there wasn't really a group of patients who didn't seem to get benefit from the treatment. The only group which was a bit more uncertain is patients who just had lymph node metastasis and they had a slightly improved failure-free survival with docetaxel. Nevertheless, there isn't really a group that you wouldn't offer docetaxel based around this analysis, and at the time this was practice changing. And again, this is looking at time to further life-prolonging treatment. And again, it was very similar between the 2 groups. So in other words, if you went onto the docetaxel, there was an increase in the time before you had your next life-prolonging treatment, whether that was docetaxel or abiraterone or another treatment, which could be given later. Now, what about the role of radiotherapy in patients who've got metastatic prostate cancer? Well, I think this is something which is still quite important, and the reason for that is we know there's a group of men who present with a limited amount of metastatic disease. When the Stampede study was initiated, we didn't know how much prostate cancer, whether your outcome would be influenced by having a local treatment. And there's plenty of evidence from studies. So in breast cancer, for example, it doesn't matter if you have your primary treatment and you've got metastatic breast cancer, you still doesn't have any difference in outcome. So it wasn't really sure whether if you had some radiotherapy to your prostate, it made a difference in outcome. And again, you can look at the scale of the Stampede, which is huge. And you can see here they had patients there were 4,696 patients who were randomized into the platform. And again, they split these patients up. So some of them had standard of care control, some had radiotherapy, and they pre-stratified their patients into low and intermediate, low and high burden of metastatic prostate cancer. So what did we see? So if you look at control versus radiotherapy, there was no difference if you looked at the whole population in terms of outcomes. But if you looked at failure-free survival, it was slightly better. And again, they've done this is a pre-planned analysis, and you can look at patients who've got a low metastatic burden, and these are patients who've got 4 bone metastasis or less, and they clearly do better if they have radiotherapy. And if they've got high burden, maybe they do slightly worse. And again, looking at different subgroups, I think the only key thing within the low metastatic burden is the patients who had the patients who just had the numbers of bone metastasis. So in other words, if you've got 4 bone metastasis or less, there is something that matters. And again, what you can see here is that in the low metastatic burden, you can see that there's an improvement in overall survival, and what you can see here is failure-free survival is also improved. And I think this is really, really important, because what it means is that you've got fewer patients who essentially progress and relapse after their initial treatment. And again, now, I think so for the UK, for example, we're offering men who've got low metastatic disease burden radiotherapy based around STAMPEDE. And in the other thing to say is in the high metastatic burden, there doesn't appear to be an advantage, but you can see here this curve does appear to be separating here. Now, it's got much less reliable as there are lower numbers of men on it, but it'd be interesting to see how this progresses over time. Now, what about other treatments for advanced prostate cancer? So the first thing to say is that this was presented by Karim Fazazi a few years ago. This is the latitude data looking at abiraterone plus prednisolone in patients with metastatic prostate cancer. Now, the one thing I'd say about this is there is also the STAMPEDE study, which I'm not going to talk about today, except in a few key details, which also study the same drug, abiraterone, in newly diagnosed men, but it also took all comers. Now, what they were looking at is whether or not patients who had sort of high-risk metastatic prostate cancer, and that was defined as numbers of bone metastasis greater than 3, Gleason score, and visceral disease, whether there was an advantage for men having abiraterone in this situation. And what you can clearly see here is that overall survival was improved if you started men on abiraterone, a treatment for castrate-resistant prostate cancer earlier in the disease course. And I think one of these things that this showed is that the earlier you use your most effective drugs in metastatic prostate cancer, the better the outcome. So in other words, the harder you hit the disease with your most effective drug treatments, the outcome is improved. And what you can clearly see here is there is a significant overall survival advantage. And again, the radiographic progression-free survival advantage is also improved. So really an absolutely groundbreaking discovery that you can improve overall survival using abiraterone earlier in the disease course. And again, this is looking at secondary endpoints, proportions of patients with PSA progression, with symptomatic skeletal-related events, and proportions of patients with pain on progression. So in other words, patients did much, much better if they had abiraterone when they were newly diagnosed. And again, all of these endpoints are improved, and again, time to progression to chemotherapy, all the other things you'd expect to be delivered were improved. What about adverse events? Well, again, obviously you've got the abiraterone acetate adverse events, which are there, but overall quality of life was excellent in this, and there was an analysis of that updated on that. So in other words, very, very good. You get the standard abiraterone related side effects that everyone who treats prostate cancer will be familiar with. So what Latitude showed was that the addition of abiraterone with prednisolone to standard hormone deprivation therapy improved outcomes. So we've now had 2 new therapies which were shown to improve outcomes. There was an analysis of STAMPEDE in which they took the 2 different cohorts together, or they weren't together, but they were given in sequence of men who received docetaxel versus men who received abiraterone, and didn't appear to be much difference in their outcomes. But I'm going to show you some data from STAMPEDE in a few minutes about how to choose between an AR targeting agent and docetaxel. Now, Kim Chi has presented the data on apalutamide versus Titan versus standard hormonal treatment, and apalutamide is an AR targeting inhibitor. It's a bit like enzalutamide, similar, slightly distinct side effect profile. I think slightly more diarrhea with apalutamide, although in clinical practice you wouldn't notice that, so rash rather, but in clinical practice you wouldn't really notice it. And overall, they showed it was an improvement in placebo, and I'm going to go through the data for you. So again, in terms of progression-free survival for all of the patients who went on to their study, significantly improved in those patients who received apalutamide versus placebo. So very, very similar to the abiraterone data. Again, hazard rate, all these sort of all the hazard ratios on the forest plot, much better going towards apalutamide. And again, overall survival is very, very good. You can see here that the very few patients within the study are relapsing, and it's overall it's better than taking placebo. And again, who was in the study? Well, these are all patients that we would recognise. Quite a lot of these patients had high volume disease, and some of them had previous chemotherapy with docetaxel before. So unlike in Latitude, where the patients hadn't had chemotherapy, if you'd had previous chemotherapy, you could then go on to have apalutamide later. And again, all of the main secondary endpoints were reached. Adverse events were similar between the two groups, slightly higher for the apalutamide group, but nothing clinically significant. I think from a practical point of view, what are the adverse events of special interest really? Slightly higher increased risk of rash, perhaps a slightly higher increased risk of rash relative to placebo, but everything else was the same. Again, seizure rates are very, very similar between the two studies. So overall, it's a well-tolerated drug. And I'll tell you, when we had quite a lot of patients on Titan in Oxford, and we had one person who did have an adverse event who had to stop, and everybody else, I was convinced they were on placebo because they had nothing, no side effects at all that we had noted. And it turned out that the only person who wasn't on active drug was somebody who had hypertension. And then again, they've started the drug. So in practice, it's very well tolerated. So how do we choose between chemotherapy or an AR targeting agent? Well, I think there's a few things to say. Well, I think the choice has been made very easy in the UK because of COVID-19. So we're choosing not to give men chemotherapy at the moment, and the government have very generously made enzalutamide and abiraterone available as alternative treatments, which we didn't have before. And one of the reasons for that is the UK's got a particular cost effectiveness model where we essentially, if we get a treatment like docetaxel, the government then compares new treatments to docetaxel and says, well, if your new treatment is as effective, how does it compare on a cost basis? And of course, docetaxel is a cheap generic drug now, which has been off patent for some time, whereas these new drugs are patented. And obviously, recently developed. We've got cost effectiveness problems in the UK, which are being addressed by the government at the moment. So this is some results of Stampede, which was, and these are the long-term results from the abiraterone cohort of Stampede. And this was presented by Nick James at ESMO this year. And what do they show? Well, first of all, they split up the Stampede cohort into the Latitude criteria of 3 bone metastasis, visceral metastasis, or Gleason score of 8+, and you had to have 2 of these 3s. And they asked, if you had low or high volume disease by this, should you have abiraterone versus standard of care? And there was no difference in outcomes. So essentially, it doesn't matter what your burden of disease, they showed there was an advantage for having abiraterone. Now, obviously, there's a license for abiraterone in hormone-sensitive prostate cancer that you should obviously follow, but it didn't show there was a group that didn't benefit from the most effective treatment to start with. So if you have somebody who's got low volume disease, either docetaxel could be an option, or it could also be apalutamide, so show that patients will do well. And I think this is also really important. The same group also showed that the patients with low volume disease got benefit from docetaxel as well. So there isn't really a group you can say, well, you've only got 1 or 2 bone metastasis, you shouldn't have treatment because we don't think it's going to do very much. You should treat everybody the same way who's got metastatic prostate cancer, obviously taking into account their comorbidities. What about overall survival? And I think this is an amazing overall survival graph. What you can see here is there's a clear benefit in overall survival if the patient's got standard of care or SOC versus abiraterone acetate or prednisolone. And the overall survival advantage is 3.8, is almost 3 years. That's a huge overall survival advantage in a metastatic trial. And unlike in the docetaxel arm, it didn't drop off. So in other words, there's a group of patients who are having their overall survival maintained. And again, they showed that failure-free survival was much better, skeletal-related events were improvement, and it didn't matter whether you had low or high volume, you still got a good outcome. So essentially, I think one of the things this study has shown is it doesn't matter what your volume of disease, if you start somebody on an AR targeting therapy, whether that's abiraterone in this analysis or apalutamide, they're still going to do very well. So you don't need to go in with chemotherapy in this group. So I think what I've talked to you about is chemotherapy and AR targeted therapies are effective treatments for hormone-sensitive prostate cancers. All therapies have a significant overall survival advantage. It's noticeable in STAMPEDE, and in the longer run, that 3-year advantage for abiraterone appears to be higher than that we've seen for CHARTED and for CHARTED and for the STAMPEDE data with docetaxel. So I think really we should be starting somebody on AR targeting therapies first, as I think they'll do better than if they go on to chemotherapy. And now I'm going to stop, and I think questions will be within the panel a little bit later. Thank you for listening.
Thank you so much, Prof. Mark. So we will go with the third speaker, and then we'll let Dr. Assam Mershad lead the discussion at the end of the sessions.
Thank you very much, Dr. Abdullah, and thanks, Dr. Mark Tuttle for the great presentation. Now we proceed for our next presentation, which will be presented by my dear colleague and brother, Dr. Amin At-Tijani. Dr. Amin is a consultant medical oncologist in King Abdulaziz Medical City of National Guard in Riyadh. Dr. Amin has a great interest and experience in GU cancer and CNS oncology. He will be presented and discuss the landscape of therapy for castrate-resistant prostate cancer. Dr. Amin, tafadhal.
Thank you very much, Dr. Fahad, for your kind introduction. Also, I would like to thank the organizing committee for inviting me to participate in this annual meeting. My task will be to talk about the update in landscape of therapy of castrate-resistant prostate cancer. So I will start with the metastatic castrate-resistant prostate cancer. And first of all, we need to define castrate resistance, and this usually progression of disease by PSA or radiographic progression despite androgen deprivation therapy with adequately suppressed testosterone level. We need to confirm the PSA rising. We need to do consecutive rises, and testosterone levels need to be measured, and also imaging, including CT scans and bone scan, are important. When we are talking about the landscape, and we will go back to 2004, when docetaxel was approved, when docetaxel compared with mitoxantrone at that time, which was the standard of care, it showed overall survival benefit of 19 months versus 16 months for mitoxantrone. And 6 years later, in the second-line setting, cabazitaxel was approved and also tested against mitoxantrone, and it shows significant overall survival benefit, 15 months versus 12.7 months. Then later came the novel hormonal agents, abiraterone and enzalutamide. Abiraterone first in 2011, and it showed overall survival of around 16 months versus 11 months compared to placebo. And enzalutamide also showed better overall survival benefit, 18.4 versus 13.6. These agents also tested in the pre-docetaxel setting for the abiraterone, also versus placebo. Overall survival was significantly better, favoring abiraterone, 34.7 versus 30.3. And for enzalutamide, also versus placebo, was 32.4, the overall survival versus 30.2 months. One of the important agents is the radium-223, which also compared versus best standard of care. And this was in 2013. It showed overall survival of about 15 months versus 11 months. And in this study, about 50% of patients were given treatment after docetaxel, and about 50% they are unfit for docetaxel or they refuse to take docetaxel. And in the last year, we have cabazitaxel versus abiraterone or enzalutamide in the CAR trial, which showed 13.6 months overall survival benefit versus 11 months. And recently, in this year, olaparib, for those with BRCA1 and 2 and ATM mutation, showed better overall survival benefit when compared to abiraterone or enzalutamide, 19 months versus 14.7 months, and this is in the second line or beyond. So there is several agents approved for metastatic castrate-resistant prostate cancer, but the optimal sequence is unclear. And actually, none of these metastatic castrate-resistant prostate cancer trials compare the new agent with the standard of care. Most of these compared versus placebo. And most of the trials have not included patients with ADT plus docetaxel or ADT plus the novel endocrine agent in the castrate-sensitive setting. So the first line therapy, the options according to phase 3 trials, we have abiraterone prednisone in COA 302 trial for those with asymptomatic or mildly symptomatic with no visceral metastasis. Other options include docetaxel and prednisone in TAX 327, enzalutamide in PREVAIL trial, and this is also for asymptomatic and mildly symptomatic patient, and also radium-223 in symptomatic with those with no lymph node or no visceral metastasis. So factors that help in the treatment decision in sequencing those agents, history, clinical history is important, those symptomatic versus non-symptomatic, co-medications, and also comorbidity. And what the treatment in castration sensitive was received, because most of this trial tested in those who receive is only ADT alone. But now we have ADT plus chemotherapy, docetaxel, or the novel hormonal agent. Duration of response to the therapy also is very important in decision-making, staging, including blood counts, renal function and liver function, PSA value, and PSA doubling time, and also imaging study. Patient preference is very important in selecting the treatment. In the first line, for those who receive the treatment after ADT alone, these are the options as I mentioned. And there is in the panel consensus of experts in Europe, they vote according to patients who are asymptomatic or symptomatic after ADT alone. And about 86% voted for abiraterone or enzalutamide to be given after ADT. And for symptomatic patients, about 52% voted for abiraterone or enzalutamide. For chemotherapy, for docetaxel, only 6% voted for asymptomatic, and 46% voted for docetaxel in symptomatic patients. What about those who receive docetaxel in the hormone-sensitive setting? And we have the options here, including re-challenge with docetaxel, cabazitaxel, and the novel hormonal therapy or radium-223. The same panel here For the asymptomatic patient who received ADT and docetaxel, voted for 90% for abiraterone or enzalutamide, and 2% for cabazitaxel and 2% for docetaxel. For symptomatic patients, 73% voted for abiraterone or enzalutamide, 19% for cabazitaxel, and 6% for docetaxel. So, first line after ADT and abiraterone or the other novel hormonal agents for castrate-resistant sensitive disease, actually, we have no prospective randomized data about activity of substances after ADT plus abiraterone or other novel androgen receptor antagonists in metastatic castrate-sensitive prostate cancer setting. But we know that activity of enzalutamide after abiraterone or vice versa likely to be low. But the activity of taxanes, chemotherapy, is likely to be maintained in those patients who receive abiraterone or enzalutamide or apalutamide in the hormone-sensitive setting. There is one important question: could olaparib be an option for patients with alteration in DNA repair genes? And this question needs to be answered. What about giving abiraterone after enzalutamide? And this was tested in Plato trial, which include about more than 500 patients who receive enzalutamide and have PSA progression after initial response. Patients randomized either to receive enzalutamide plus abiraterone or abiraterone alone. The PSA response is only 0.8% for those who continue on enzalutamide and receive abiraterone, and 2.5% for those who receive abiraterone. And there is prospective data in selected patients that PSA responders to enzalutamide is better. Also, there is confirmed of retrospective data that showed only minimal activity of abiraterone after enzalutamide. So what about the second line, metastatic castrate-resistant prostate cancer after docetaxel for first line in the castrate setting? And according to phase 3 trials, we have these options: abiraterone and prednisone, and we know this tested in Quad 3.0 trial, cabazitaxel in TROPIC and Proselica, enzalutamide in a FERN trial, and radium-223 for those, as I mentioned before, symptomatic with no lymph node or no visceral metastasis. And so what about the third line? So actually, we should try our best during the course of disease that fit patients should receive docetaxel and at least one of the novel agents. So the best treatment option after docetaxel and one of these novel agents was unknown. And should we switch to novel agents or should we give cytotoxic? And this leads us to discuss the CAR trial, which is the third line trial. And in this trial for metastatic castrate-resistant prostate cancer, those who receive one of these two novel agents, enzalutamide or abiraterone, followed by docetaxel, or they receive docetaxel first, and then after that, enzalutamide and abiraterone, patients randomized either to receive cabazitaxel or to receive the novel hormonal agents, which he did not receive it in the previous lines. Eligibility here include progression of disease less than 12 months and no prior alternative novel hormonal agents. And in this trial, the primary endpoint, the median radiographic progression-free survival, was in favor of cabazitaxel, which about 8 months compared to the novel hormonal agents, 3.7 months, with a hazard ratio of 0.54 and a significant p-value. The overall survival also in this trial, the CAR trial, is significantly favor cabazitaxel over the novel hormonal agent, 13.6 versus 11 months with a hazard ratio of 0.64 and significant p-value. Regarding the PSA response, is better for cabazitaxel, 35.7%, compared to novel hormonal agent, 13.5%, and also tumor objective response is better for cabazitaxel compared to novel agents. Pain response also is in favor of cabazitaxel, 45% versus 19.3%. So cabazitaxel, now we can consider it a new standard of care for the third line for fit patient who progressed on prior novel hormonal agent within the 12 months with manageable toxicity. One of the important agents, this is novel agents, lutetium PSMA, also tested versus cabazitaxel, and the primary endpoint of this trial is PSA 50% or more response. And clearly here we see that lutetium PSMA have PSA response of 66% compared to 37% for cabazitaxel. There is about 30% absolute difference in PSA response compared to cabazitaxel. Prostate cancer and DNA repair genes is very important to discuss. Germline DNA repair mutations also occur in about 12% in men with metastatic with M1 prostate cancer, 5% in those with localized disease, and 3% in general population. For the somatic DNA repair mutation, it is about in 10% in men with metastatic castrate-resistant prostate cancer. Profound trial, this is a study which tested olaparib in this setting, and the key eligibility criteria with those with metastatic castrate-resistant prostate cancer who progress on prior novel hormonal agents, abiraterone or enzalutamide, and one of the eligibility criteria also, they should be alteration in at least one or more of any qualifying gene with a direct or indirect role in homologous recombination repair gene. Stratification by previous taxane and measurable disease. There is 2 cohorts in this trial. The first cohort is for BRCA1, BRCA2, and ATM mutation, and the other for other alteration. Randomization 2-to-1. Patient receive in cohort 1 olaparib versus the control, or here also olaparib versus the control, and crossover is allowed. The primary endpoint was radiographic progression-free survival in cohort A, and these are the key secondary endpoint, which include objective response rate, radiographic progression-free survival in cohort A plus B, time to pain progression, and overall survival in cohort A in interim and in the final analysis. This is the primary endpoint, which was met in favor of olaparib versus the physician choice of treatment, which I mentioned here, it is abiraterone or enzalutamide. And the median progression, radiographic progression-free survival was 7.39 versus 3.5. And this is the 6 months, and this is the 12 months. So there is significant difference. So olaparib for patient with DNA repair alteration showed this is overall survival in cohort A, which is significantly better in favor of olaparib versus the physician choice, which are like 19 months versus 14.7 months, had a ratio of 0.69 and a significant p-value. This is in the whole overall population, and there is no significant difference. And here on the cohort A plus B with adjustment for crossover, which show there is a better, or at least this is significant. This is the most common adverse events in these trials, which include anemia, nausea, fatigue, asthenia, and at the final this is at the final overall survival cut point. So olaparib improve overall survival in a molecularly defined subset of patients with metastatic castrate-resistant prostate cancer. Therefore, genomic testing need to become clinical practice. Other combination therapies, all of this failed in phase 3 trials. We will not go in details on that. Another combination therapies include radium-223 plus abiraterone versus abiraterone alone, and this is failed. There is more fracture in this study and more deaths. One of the trials also abiraterone plus enzalutamide versus enzalutamide. There is no significant difference in overall survival. And we have abiraterone plus epitacicept versus abiraterone. There is statistical improvement in radiographic progression-free survival in previously untreated metastatic castrate-resistant prostate cancer in those with PTEN loss tumor. So the take-home messages for metastatic castrate-resistant prostate cancer, we have several agents, but optimal sequence is unclear. Majority of patients who are fit for chemotherapy should be offered docetaxel and also one of the novel endocrine agent at some stage of their disease. The third-line treatment in patients who receive docetaxel plus and also a novel endocrine agent and who progress within 1 year and who are fit, cabazitaxel should be the standard. Best use for radium-223 unclear only symptomatic patient without lymph node bulk or visceral metastasis. Abiraterone after enzalutamide show low activity. Enzalutamide after abiraterone, modest activity in selected patient. Combination therapy not very successful until now. We have now treatment for molecularly selected subgroups, olaparib, but optimal sequence unclear. We need more predictive marker. I will go quickly for the non-metastatic castrate-resistant prostate cancer.
I mean,
and yes,
actually, I've exceeded your time. So can we just stop?
It is 2 minutes. 2 minutes. I will finish in 2 minutes.
You have taken 7 minutes more. So and you will let us very much behind schedule.
2 minutes. I will finish. Okay, 2 minutes. So this man with the prostate cancer with a rising PSA while on ADT, no detectable metastasis on conventional imaging and testosterone at castrate level, usually relapse from local treatment is the most frequent scenario of M0. There is 3 scenarios to develop CRPC: M0, salvage ADT after local treatment, or PSA rise during radiotherapy and ADT, or ADT alone for localized disease, which should not be used. We know that it's high risk non-metastatic, is a deadly disease with time to bone metastasis and overall survival. We have 3 agents here, enzalutamide, apalutamide, and dolutamide. The studies are similar. PSA doubling time of less than 10 with good performance status. And all of these, this is showed the metastatic free survival in Spartan and Prosper for apalutamide and enzalutamide, and this is for dolutamide. And this is overall survival, which is significant for the 3 trials. This is the safety. And my conclusion here, it is actually quite rare situation with unmet need. And even rarer is next generation imaging is used. We have 3 agents, and there is clear and meaningful improvement in metastatic-free survival, remarkable safety, and clinical endpoints are improved in progression and overall survival. Thank you.
Thank you. I mean, I owe you an apology, actually. My watch was wrong. I thought it was 3:05. So I owe you a deep apology, please. A sincere apology.
So I can go back, or what? I can go back.
No, sorry. Really, I'm sorry.
We can never be bored from hearing from you. I mean, so if you allow me, Issam, we just heard in this session very great presentation from all the speakers, And it seems, Dr. Issam, the landscape get complicated. If you remember the landscape before for kidney cancer, bladder, prostate, it was so simple that you have like 1 or 2 options that you choose from, and we always go discuss lots of things, how to differentiate between sunitinib, pazopanib, or like docetaxel to prove survival. We're so happy. And now we have very several options that we have the luxury to try and look at, dissect trials, look at evidence, use patient factors, tumor factors, and talk about biomarkers to select. So this is a luxury that we should be all happy about. Thank you for all the speakers who really enlightened us about that. Dr. Issam.
Thank you very much, Fahad. Really, it's so complicated. If you are as old as I am, when I joined oncology in 1994, we had only one option, or 2 options actually. Interferon, which was the one we widely use, and interleukin, which nobody liked to use because of the toxicity. Things remained the same until 2005, and then again we have one other king who was on the throne for a few years alone, undisputed. And after that, loads of things, waterfall of medications came out, to the moment that even in the questions actually here, I feel that some of the people who put questions, they are a little bit confused, especially between the favorable risk, the intermediate risk, and the poor risk. Now you have different agents effective. So I would take this opportunity to address the first question, which was posted to Dr. Total. It was that why they didn't include favorable risk, and I do believe he's referring to the Pembro and the nivolumab.
So to the 214 study. So they did include the favorable risk patients, and they actually didn't appear to get, in the primary analysis, they didn't appear to get a benefit from the combination immunotherapy. So I didn't discuss that today. So they didn't appear to get a benefit. In fact, the response rate was higher with TKIs, so with Sutent, than it was with a combination immunotherapy. With regards to that group, I think this is a watch this space, because I think the consensus is, certainly at GU ASCO, is that it may be that that group will still get a benefit, but it's because that group is playing out over a 10-year period. The other groups have read out first. So I think wait and see, but certainly that ipilimumab and nivolumab isn't licensed in this group, so there wasn't a benefit in the primary analysis.
May I extend the question, Issam? Yeah, yes, thank you.
Yes, please.
So, and I'll extend the question again for more discussion with Mark. It seems that favorable risk, they do well regardless of what type of therapy you give them. In the most recent update in the last ASCO about the keynote study, Pembro-Axi, it seems that there was no survival benefit from Pembro-Axi. Despite that, it still shows in the guidelines for the favorable risk. And this is my question. What do you think about Pembro-Axi? Would you recommend it for favorable risk, or maybe according to the available evidence from the keynote study, they do as well as sunitinib?
Well, I think it's really, really difficult, because they do very well with Sutent on its own. And I think there are 2 bits. There's the VEGF signaling, which is obviously dominant, and then there's the immunotherapy aspect of it. So, I mean, we haven't got any access in UK NHS oncology at the moment for axitinib. So we haven't pembrolizumab. So it hasn't come up particularly. But for all of the patients who've got good risk disease, I'm putting them on the double combo, an IO, avelumab, axitinib, because I actually think they do better in the longer run on it. So I think the Axi Pembro data is also less mature than avelumab data. So there's 2 aspects of it. But I have to say, one of the things about the data is that we know that immunotherapy together is better than having a TKI. And what we haven't seen so far really, really clearly is whether there's a really good synergy between IOs and TKIs. So I think it is still reasonable to start with a TKI treatment, and then you could add in an IO agent later. So I appreciate that's not a very clear answer, but there's a lot of things which have been made unclear by the sort of avalanche of data which has descended on the kidney cancer world in the last few years.
Yeah. Okay. If you allow me to continue, Issam?
Yes, please.
Thank you very much. So that's really good, great argument and great point, Dr. Mark Tuttle. It seems despite no survival benefit, there was very good response, and CR rate, even favorable risk, are higher in the IO-IO or IO-VEGF arm. But this risk grouping and scoring was in the TKI era. Maybe, do you think we should maybe do more research to make better predictors for treatments and biomarker? Yeah.
So the IMDC group are looking at whether these prognostic tools still hold in the IO era. I think in terms of sort of prognosticating patients, if you like, the IMDC criteria were used to prognosticate the patients who, which were developed in the TKI era. They were used to stratify the patients in the 214 study, for example. They do seem to hold up in that the different groups, you can split them out by outcome. One of the problems in kidney cancer is a lack of biomarkers. So, you know, the only way you can really distinguish between patients who are going to do less or badly is based around the IMDC criteria, or perhaps a sarcomatoid element as well within it. But at the moment, I think the IMDC are the best criteria we can use, and PD-L1 expression hasn't turned out to be as useful, say, as it has been in melanoma or lung cancer, for example.
Dr. Abdullah, if you have a question.
So thank you, Fahad. Dr. Mark, let me ask you about sunitinib. Do you think sunitinib is in best option at the meantime, based on the data that we have in first or favorable risk group?
I mean, I haven't, I was having a think about this, but I haven't prescribed any Sutent now for probably a year and a half. So, I mean, we've still got patients on it because they're on it, but I haven't personally prescribed any Sutent. So I think if you haven't got access to IO TKI therapy, or you do have somebody who's got, say, a pre-existing autoimmune condition, you think, well, look, they've got psoriasis, maybe I don't want to be jiggling that up for 2 years. I don't want to be upsetting them for 2 years. And it's reasonable to start with a TKI on its own. But I think for the most part, I think we are giving IO TKI patients for the favorable risk ones. The one thing I would say about the favorable risk patients is when you start them on treatment, you've often started them because of clinical progression or they're about to get ill. So although they are classed as favorable, they're still going to have a disease which is going to cause problems if it's not treated effectively within the next 3 or 4 years anyway. So I think going in with an effective treatment, most effective treatment at the beginning, I think is the best way of getting a good long-term outcome.
This is for the whole panel. If we can have just a brief answer for that. Which is better? I believe that was partially answered, but we have to put it. Which is better, TKI-IO or IO-IO? And why do you take side effects into consideration? So let's start with Abdullah.
Yeah, thank you so much, Dr. Assam Mirshid. I mean, if you look for the data, all of them showed an overall survival benefit in intermediate and poor risk. And definitely for IO and favorable risk, it does not show any survival benefits, like exactly in IO and TKI. It showed only progression-free survival. I agree with Dr. Mark, it's only premature data, but the data is there. Doesn't show any overall survival in long follow-up, which was published in last ASCO. So, I mean, all the option is there in intermediate and poor risk. I will consider the patient. I will consider the patient status and the performance status and the toxicity profile. And the most important thing, I think, it's at the level of the economy at the meantime. I mean, if you look for the IO, you'll get 4 cycles of combination, then you will continue with monotherapy. While IO plus TKI, it is, you need to give the 2 medication together for some quite long times. So it's an option, definitely, and the data is very clean and very clear. It's a phase 3 trial showed survival benefit in those patients with intermediate and poor risk. I cannot say this one is better than the other in the absence of phase 3 clinical trial comparing between the two regimen, which I doubt that will be any clinical trial to address this issue at the meantime.
Okay. Amin?
Actually, I totally agree with Dr. Sham. Both options are valid. It depends on availability of the medications. If both are available, both are valid for intermediate and poor risk. Toxicity also is very important. As you know, this is ipilimumab we are giving only for 4 cycles, and axitinib are continuing actually continuous treatment. So toxicity is very important also to look on. But to me, I am using both actually.
Okay. So if you are really stuck and by your pharmaceutical and therapeutic committee, and you have to choose one combination, which is almost the scenario. I don't know about the scenario in the UK, but in our country, the scenario with the BNT committee is that you have to choose one as long as they're equally effective.
This is a difficult question, Isam.
Yeah, which one you will go for? This is the real life scenario we're dealing with. So I know we can play with it. We can put favorable risk and then add another combination, use this here and that here. But if you are really stuck, okay, with them, will you go for IO-IO or TKI-IO? Myself, I will go for IO-IO.
Can I have an answer?
أهلا دكتور عماد ما شفناك sorry معلش I missed your presentation في الأول. I had some technical problems in connecting. فرصة سعيدة شفناك يا باشا. Yes, I didn't notice you. اتفضل.
No problem. And I do believe that I will go for IO-TKI if I want to have a rapid response, because definitely the response rate with the IO-TKI is much higher than the IO-IO. And also, if I have a patient with an autoimmune disease, I can go also for the IO-TKI. Then I go for the IO-IO because of the toxicities. So we can choose, although we can have the favorable and the intermediate and poor, but also if you have a patient that you need a rapid response because of the bulk of the disease, definitely I will go for the IO-TKI.
Okay, now we will go to your bladder cancer field. Okay, there was a question asking about what is the role of immunotherapy with squamous cell carcinoma? Was it right?
With the squamous cell carcinoma, there is underlying the phase 2 trials, but still we didn't have any approved IO for the squamous cell carcinoma. But definitely it is only for the urothelial carcinoma, whether we have the renal pelvis of the ureter or the bladder.
So if you are stuck with a patient who is chemotherapy ineligible, let's say he is platinum ineligible and carboplatin ineligible and squamous cell carcinoma, would you use immunotherapy, pembrolizumab, for example, in this patient?
I will use Pembro if it is a PD-L1 positive patients. I will go for monotherapy. It has a designation of the level 3A in the ESMO guidelines. So
I mean, Ahmad, I mean the patient is squamous cell carcinoma.
No, squamous cell carcinoma I didn't have till now.
Okay. So, and the other question is that why do you think that some immune therapy trials were negative? I do believe maybe he's referring to Invigor or
yes,
Invigor 10.
The Danube and the Keynote-46 when added to the chemotherapy did not have an overall survival benefit. I don't know, because addition of immuno to chemo is not stratified by even the PD-L1 status. This is unlike the lung cancer, where we have if you have a PD-L1 less than 50, you can go for immuno plus chemo. But in the bladder cancer, until now, the addition of immuno to the conventional chemotherapy did not add for the overall survival, unless we have some improvement in the PFS when we add atezo to the cisplatinum gem or carbogem.
Yeah, and the last thing in the bladder cancer, which is to remind to everybody, what about the FDA warning of using immunotherapy with bladder cancer, and how can you relate that later to using immunotherapy to end bladder cancer? We know the answer, but of course, please go ahead and just elaborate for the gentleman who put the question. The FDA, anybody, or Ahmad will answer? Okay, Ahmad, it's yours.
Excuse me, I want the question again, I saw.
The FDA, you remember 3 years back when first the immunotherapy was first introduced, and there was an FDA warning of not using it in PD-L1 negative patient because it gave inferior survival. And we know that now we are using it despite, in some cases, despite the PD-L1 positivity. So how can you, what can you comment on
I think because we see that according to the diagnostic content for the either the pembro or the atezo, for the PD-L1 positive, we can obtain a very good objective response and overall survival. But this was not in the PD-L1 negative or even in the PD-L1 unknown. But because we didn't have enough drugs to use in the metastatic setting or the local advanced bladder cancer, we started using the PD-L1 positive, not in the PD-L1 negative, definitely.
Okay.
This is in the first line, I think. This is in the first line.
Yes,
in the post-platinum second line, we didn't have the pembro is only the level 1 evidence in the PD-L1 positive also.
Now we have only, I think, 2 or 3 questions on prostate cancer. First of all, this is by a urologist, definitely, this question. What is the role of prostatectomy in metastatic patient? So, Dr. Tuthill?
So I think this is a controversial area. So I think the trombone study, which was led by Mr. Suranakiyam in the UK, showed that it was feasible to do a prostatectomy in men who've got metastatic prostate cancer. Surgeons often make an argument that it improves local control, so it stops men from getting problems within their prostate. But in my experience, we have relatively few problems with local control in metastatic prostate cancer. So I think this is an area of study. My personal view on it is that there is an advantage for radiotherapy. So there may well be an advantage in low volume disease, although that would have to be shown with a trial. And then the other comment I'd have is that although robotic surgery has made a radical prostatectomy seem like a relatively minor operation, it's still associated with quite a lot of potential adverse outcomes. So I think this is an area which is for research at the moment, rather than for clinical practice, but one which is developing, and there are certainly ongoing trials which are going to explore it.
Okay. And another question to the panel and to Dr. Tuthill. Do you think that routine use of bone agents, I do believe he means the bisphosphonates, would help in reducing the incidence of fractures that we see with the hormonal treatment, which is more than the placebo?
So I think from an overall survival point of view, we didn't see any benefit in terms of on systemic disease with having a bisphosphonation in STAMPEDE, but certainly maintaining bone health has been shown to reduce skeletal related events. So although we wouldn't give, say, zoledronic acid every 4 weeks IV, we do put patients on alendronic acid and other sort of oral bisphosphonates to help maintain bone health. So I think there's a role for it. Again, it depends a little bit on your local population and their pre-existing health before you start.
Okay. So, and the last, I do believe this is the last question. I just have to ask this political thing. Which is better? Is it Enzo or Epinephrine? If you really want to choose one, what do you use?
Is this for the newly diagnosed patients?
Yeah.
I mean, I think the truth of the matter is that I think if you look at the metastatic setting, enzalutamide, abiraterone have got very similar activities, and it's same for newly diagnosed patients. I think they've got different toxicity profiles. So slightly more perhaps cognitive side effects with enzalutamide. But again, I think they're both, all of the drugs, enzalutamide, abiraterone, apalutamide, they're all in fact very well tolerated. In the UK, because of the coronavirus pandemic, we haven't been using very much abiraterone in the pandemic because of the steroids. So I think you just have to bear that in mind. But they're all three of them are good drugs, and I think it will come down to what you have available in your country and what you have experience with using. And certainly, as I use all three, I haven't noticed any difference in terms of side effect profile management issues in real clinical practice. But obviously, if you look at things from a high level, you can perhaps tease things out. But for the everyday clinician, I don't notice a difference. And Dr. Amin, what do you think?
Yes, and what I want to ask you actually, I totally agree with you. But are you using both of them on the same? If the patient progress on one, and you use the other, because sometimes we are doing this
sequencing.
So the sequencing, I think I mean, in most of my practices within the NHS, and in the NHS, the NHS is aware that if you've progressed on abiraterone, you're unlikely to respond to enzalutamide and vice versa. So we're not going, abiraterone followed by enzalutamide. The only times we do that are in clinical trials where that's permitted, because the response rates are not terribly high second time around. So from a practical point of view, we're not doing two AR targeting agents in sequence, because there is cross resistance. But of course, if you've got somebody who's got side effects, then and you switch them, even if it's later on in the disease course, they will still maintain a response.
Okay, I think we have to close, but before we close, may we have a final thought from all the panelists in just less than 10 seconds? Final thought, please. Let's start with Fahd. Say your comment and then your thought.
Thank you very much. I really, I'm really impressed by the presentations and for the huge transformation of the landscape for all GU cancer. I'm really happy now that I need to think and have the luxury to choose for my patients. And thank you for all.
Thank you.
Thank you very much.
Prof. Hamada Ahmad, you are on board? Okay. Abdullah?
Yeah, thank you, Dr. Assam Marshad. I mean, we have an excellent session today with excellent leader and excellent discussions. A matter of fact, GU gets very complicated. We have plenty of medication now in the first and second line. The main problem, we are still lacking clearly the sequencing, the best sequencing therapy, and definitely we are still lacking the biomarker to guide us in our treatment for the lovely patient with the GU cancer.
Amin?
Thank you, Dr. Murshid, for the session is great. Actually, my thought about we need biomarkers are actually for all these cancer, whatever bladder or renal or prostate, to select therapy. So this is one of the important things I think we should look for.
Dr. Total?
Well, first of all, thank you very much for the opportunity to present today and to have this very interesting discussion. I think one of the things I would reflect on is that we've got lots of drugs. And I think one of the things we can all be reassured about is if somebody is newly diagnosed prostate cancer or newly diagnosed kidney cancer, they've now got really good drug treatments now. And whichever one you choose out of the available options, the patients will do really well. And I think that's my take-home message is we've now got really effective new treatment options for these groups of patients, which has really just transformed outcomes and how we look after our patients in the short and the longer term as well.
Thank you very much, guys. From my practice, actually, I do GU and breast, so I don't think so many people do GU and breast together.
Oh, I do that, yeah.
Oh, okay.
I do that also.
So we are a majority today. I can see that urological cancers are almost following the pathway of breast cancer, of being so complicated in the term of choices that you have and the need for markers and the need for more personalized way to decide which patient to treat. And I do believe the old way of thinking of, if you have 2-3 equally effective choices, you have to choose one. I do believe that all the 3 choices should be available, because sometimes you don't choose it based on efficacy or based on the outcome. Sometimes you choose it based on the patient comorbidities. You choose it on the patient toxicity profile, which is different from one patient to the other. Thank you very much for all of you on the behalf of the organizing committee. And now I'll just give the floor to Dr. Al-Hamad for the Satellite Symposium. Please be with us. Very interesting topics in the Satellite Symposiums, which will start after the break of around 5 minutes or so. Thank you very much.
Thank you.
Because we are running late, we're going to start right away, Dr. Issam.
Okay. Sorry.
So I would like to thank, first of all the speakers and all the moderators, Dr. Issam, Dr. Fahad, Dr. Abdullah, Dr. Imad, with all respected titles. Also the speakers, that they give us really rich, full talk and comprehensive about the GU. It's my pleasure to introduce my colleague, Dr. Issam Murshid, who's going to give us talk for Astella of castrate prostate cancer. Dr. Issam Murshid is very well known and nationwide, as he said, in breast and GU. He's one of the senior medical oncology consultants in Sultan Medical City. Thank
you very much, Dr. Abdulaziz, and thank you for all of you who are still with us during the weekend and a very nice weather in Riyadh today, especially, and those who are staying indoor. Really appreciate your attendance, and I'm very honored by your attendance. This satellite symposium is going to be about castration-resistant prostate cancer, and it is sponsored by Astellas. And these are my disclosures, and I have also disclosed that they gave me an honor for delivering this speech to you today. The natural history of breast cancer is either you have a localized cancer from the start, or a de novo metastatic disease. De novo metastatic disease, usually they can go into being first hormone sensitive, and then they can be hormone sensitive or castration resistance. And after that, at one stage or the other, patient will go into being castration resistance. The same for the non-metastatic. Some of them, they do recur and metastasize, and the same thing applied. And we have so many different choices nowadays, whether to those who are non-metastatic but M0 with the raise of PSA, and those who had actual or frank metastasis. In most men, castration-resistant prostate cancer is...
Or there is no presentation because you didn't share.
I didn't share. Sorry. I don't know what's happened to me today. I'm getting old. Can you see it now?
Yes, it's very clear.
Okay, we'll start from the start. As I said, I will talk about castration-resistant prostate cancer, and with the only focus will be on the non-metastatic castration-resistant prostate cancer. And as I said, this is a satellite symposium for Astellas, and they have paid an honorarium for that. Okay, and this is the natural history of prostate cancer. We started usually either localized, whether a small volume disease, or locally advanced, or de novo metastatic, and at one stage or the other, the patient will actually transform from one stage to the other of either being hormone sensitive, then to hormone castration, hormone sensitive to hormone insensitive, or castration resistant cancers. In most men, the following castration resistance actually ongoing the androgen receptor signaling in a minor driver. Okay, which actually the AR receptor activity is the major driver of the disease itself. A biological mechanism of castration resistance include increased in the expression of the androgen receptor co-regulators, androgen receptor amplification, androgen receptor activating mutation, and increase in the stereogenesis, otherwise due to crosstalk through alternative pathways. And remember that, as we always say, cancer cell, they can develop their own alternative pathway to avoid the death, or to avoid death by any other medications. And so many agents have been introduced in the market, as it was really beautifully explained by Dr. Amin and Dr. Tothill. The treatment consideration, what we should consider when we treat non-metastatic castration-resistant prostate cancer. We should take into account the age of the patient, the life expectancy, the comorbidities, if existing comorbidity, and the effect of those comorbidities on the patient, stage and grade of the cancer, potential benefit of each treatment option, cure versus palliation, patient concern about side effects of treatment options. What counts for the decision? The quality of life, either of the disease or of the intervention, symptomatic control, whether pain or urinary symptoms, PSA and related anxiety. For example, patient with increasing PSA and there is no evidence of metastasis. Is it worth actually to treat him if he's very anxious of developing metastasis, or will be more anxious if you offered him treatment? Survival as usual. There are 3+1 Ps in the decision making, which is a shared decision, of course, between the patient and oncologist and the involved specialties, if any. The treatment goal would include the prolongation of survival, preservation of quality of life, prevention of treatment-related complications, and at the end, the patient baseline and symptoms. For example, the PSA doubling time, performance status of the patient, concomitant medications the patient is receiving, comorbidities, for example, diabetes, and the choice of adding a drug with steroids, which may affect his diabetes, and the treatment impact on the patient. First of all, we have to try to identify who's low risk and who's high risk and what is the percentage. In fact, when you go through different trials and different studies and different populations in the world, there was a great variation in defining or finding the low risk versus high risk. But the gold standard is that when you treat a patient, is it worth actually to introduce a treatment which may cause toxicity to that patient? You have to think about this a lot. Now we'll go into defining the non-metastatic castration-resistant prostate cancer, which is defined as a serial rising of PSA despite the castrate level of testosterone. No evidence of metastatic disease by conventional imaging, that is CT scan, bone scan, and sometimes you may use PET scan, but I know that the PET scan, there are so many limitations of using it in prostate cancer. Inclusion criteria of these trials, actually look into the intervention. They have included patients with PSA doubling time of less than or equal to 10 months, or PSA greater than 2. And it's important actually to notice, as it was, I think, mentioned by Amin, that the FDA labeling prescription label did not limit the prescribing these agents to only high risk. So, why do you need to interfere early when the patient is having a biochemical relapse, as we called it before, or now with the new definition of non-metastatic castration-resistant prostate cancer? There were some studies that have looked into the relationship between the PSA doubling time and the incidence of developing more metastasis, and even though the incidence of dying of the disease. And all these trials actually have concluded that the shorter the duration of the PSA doubling time, the higher likely that the patient will develop bone metastasis and the higher chance of death. We have 3 agents in this field, the enzalutamide and the apalutamide, which are second-generation anti-androgen target the androgen receptors at 3 key points, or 3 targets within the, or 3 way of targeting the androgen receptor, prevent the binding of androgen to the AR, competitive inhibition, inhibit the translocation of androgen receptors into the nucleus, and interfere with binding of the androgen receptor to the DNA. Darolutamide is structurally distinct from apalutamide and enzalutamide, characterized by a low blood-brain barrier penetration, and this may save the patient from CNS toxicity, which can accompany the 2 previous agents, and improve the tolerability of this patient. This is the mechanism of action of enzalutamide. As I said, it's competitive inhibition with the androgen on the receptor level, and then it blocks the activation of the receptor, which means that the transcription is not there, or loss of transcription, and then also it inhibits the activity of the DNA, or binding of the receptor to the DNA. This is the structure and mechanism of action of apalutamide, which is almost similar to enzalutamide, and this is the darolutamide. Okay, The three trials which actually led to the approval of these drugs in this indication were the Bruscar, the Spartan, the Aramis trial, and all of them, as I said, they have included patients with PSA doubling time 10 months and less, or PSA level of 3 and more. Oh, sorry, 2 and more. And these three agents actually have shown efficacy in terms of median metastasis-free survival, and it was reasonably well tolerated by the patient with a reasonable quality of life. These are the original publications, and as this is a comparative between the three endpoint, the endpoint of the three trials, as you can see, the MFS, or the median metastasis-free survival, was very much superior in favor of these agents versus placebo, 40.5, 36.6, and 40.4. This benefit was very substantially significant, and substantial and significant, and the magnitude of benefit was very high, but you have to take into account toxicity in certain patients whom you over-treat them, and also the financial toxicity of using these medications. The Prosper trial, actually, this is this trial design. As you can see, centrally reviewed non-metastatic castration-resistant prostate cancer with a rising PSA despite castrate level of testosterone, and baseline PSA of 2 and more, and PSA doubling time of 10 months and less. Patients were randomized 2-to-1 into receiving enzalutamide plus ADT versus placebo plus ADT. And after the trial, actually, patients were allowed to change the label either to crossover or to continue on enzalutamide. Primary endpoint, as I said, was the metastasis-free survival, and secondary endpoint includes overall survival, time to PSA progression, safety, PSA response, and quality of life. This was the first interim analysis which was published in the ASCO GU of 2018, and there was a clear difference in terms of metastasis-free survival in favor of ADT plus enzalutamide of 36 months versus 14.7 months. Okay, but there was, in that analysis, there was no effect on the overall survival, but there was a trend of improvement of overall survival. The same goes for, and this is the updated analysis in the ASCO GU on the ASCO virtual meeting of 2020, and there was an improvement in survival with 27% reduction in the risk of death, with a superior median overall survival of 67 versus 56.3. The patient subgroup analysis, most if not all the groups actually benefit from the medication or from adding the combination. And remember, this was used in patients with which can be defined as high risk. The secondary endpoint, there was significant improvement in PSA progression time with 33 months longer in favor of enzo combination, and at the same time there was an improvement. There was the time for the subsequent therapy was improved by 22 months in favor of the enzalutamide arm. Subsequent therapies definitely be most patients will have received chemotherapy in the enzalutamide arm. In the placebo, they have received abiraterone acetate, and there are other agents, including actually continuing in enzalutamide after progression. This is the time for the antineoplastic therapy, which was longer by 22 months compared to the placebo arm. And there was, of course, the toxicity of the treatment was a little bit higher, but it was very much tolerable and within the profile that we know about the medication. Fatigue being the most common one, followed by musculoskeletal events and fracture. And you remember when we talked in the previous presentation about the bone health in these patients and how to maintain bone health. The toxicity of interest would include, of course, the hypertension and followed by the cardiac toxicity. So enzalutamide did improve the overall metastatic-free survival in these patients, and it decreases the risk of death by 27%. The adverse events were within the toxicity profile that we know about the medication. There was no alarm, no signals, and it was very much well tolerated. The second trial is the Spartan, almost of a similar design, but they have used the medication of flutamide with the same randomization of 2:1, and their first analysis was the metastatic-free survival, and they added, after progression and use of second-line therapy, the second progression-free survival figure. And again, and you have seen this, it's 40.5 months versus 16.2 months in favor of the flutamide arm, and this was published in the ASCO GU of 2018. This was the original, of course, slide shown by the author at that meeting, and there was an improvement, as I said, in the metastatic-free survival, but there was no much improvement in the median survival, which is not reached. Actually, it is still premature to analyze. The same thing, there was improvement in the local progression, distant progression, or death in favor of the combination, and the time to PSA progression was longer for patient on the combination. There was no added toxicity than what we know about the toxicity profile of this medication, fatigue being the most common, followed by rash. So in conclusion, it was effective in the reduction of metastatic in improving the metastatic pre-survival. This was published in the ASCO GU 2018 with no effect on the immature effect on the overall survival. But in the 2019 publication, as you know, there was a reduction in the risk of death, as well as the same the same point of the metastatic free survival was maintained. The last trial is the ARAMIS trial, which included patients with actually for the medication of darolutamide, and it's almost of a different. Sorry, I have to say something about the Spartan. The Spartan, they have included lymph nodes in the stratification, but it wasn't included in the other two trials. The ARAMIS trial also they have recruited patients with the same. Almost with the same characteristics, and they were randomized 2:1. And the primary endpoint was the metastasis-free survival. Secondary endpoint includes overall survival, time to pain progression, time to first cytotoxic chemotherapy, time to first side effects, and safety, with exploratory endpoints, multiple exploratory endpoints actually. Again, there was significant improvement in the risk of distant metastasis or death in these patients in favor of the darolutamide arm, with no alarms or red flags in toxicity than we know about it. Fatigue being the most common actually side effect of these agents in these men. In conclusion, the darolutamide actually significantly improved the metastasis-free survival in men with non-metastatic castration-resistant prostate cancer, and it was associated with a 29% reduction in the risk of death in the first interim meta-analysis, and the toxicity profile was actually very well tolerable. Okay, these are the combinations between the trials. It can show you that the definition of the endpoint was there was slight differences between patients in terms of defining the metastatic free survival, but more or less it is actually similar in a way. The same thing with the inclusion criteria. There were differences. All of them actually, all the three trials, they recruited patients with the PSA of 2 or more and PSA doubling time of 10 and less. But there were some minor differences in terms of the recruiting patients with lymph node, either N1 disease, and the which was not included actually in the Prosper trial, and it was in the ARAMIS and the Spartan trial. Okay, this is a comparative slides between the endpoints of the trial, but of course we are not here to compare between which is better based on this, because we cannot compare clinical trials together unless we do head-to-head comparison. And also these are the comparison of the key endpoints As you can see that there was improvement in all variables or all endpoints in favor of the combination of these medications. The adverse event, as I said, fatigue was the most common side effects of all these agents, and bone-related events were the second. So, what are the concerns? The concern is that, as I said, there is no head-to-head comparison of these data, so you cannot say that which is better. The 3 trials have shown strong positivity in terms of the effect of these agents in patients with non-metastatic castration-resistant prostate cancer. Long-term effect on natural history of the metastatic prostate cancer is unknown, and will the more aggressive disease phenotype develop earlier metastatic castration-resistant disease due to longer exposure to androgen receptor targeted during the non-metastatic castration-resistant prostate cancer. Regarding toxicity and tolerance, we have to actually weigh the effect versus the quality of life, and I think we have to be very selective in offering it to patients with good performance status. So, we need a better way actually to understand the post-marketing setting and the more follow-up on the toxicity of these agents in these elderly population. As safe choice and monitoring of toxicity is mandatory. There can be significant financial toxicity, especially if the patient is paying out of pocket, or if the patient is in a system where the drug cannot be provided free for him and he's going to pay for it. And this should be taken into consideration. Underlying toxicities such as cardiovascular disease, hypertension, history of falls or seizures, virility, and the impact on osteoporosis or osteopenia and fractures. We need biomarkers definitely to identify patients who are in need of this, as it was mentioned before. And maybe conventional therapy is not enough to decide on the fate of these patients. You may need to base the PSMA PET scan in these patients. In conclusion, for men with non-metastatic castration-resistant prostate cancer, the treatment options are very effective in reducing the risk of death and in improving the metastatic free interval, as well as the PSA progression time and the need for second-line therapy. As I said, there is no head-to-head comparison between these 3 agents, so we cannot decide which is better. And all these 3 agents are FDA approved, and for therapy decision, we should take into consideration the disease risk, the PSA doubling time, the comorbidities, the life expectancy, and the potential for physical and morbidity toxicities. So we balance the risk versus the benefits. Thank you very much.
Thank you, Dr. Assam, for this comprehensive talk. I just have one question. I think we kept asking this similar question since yesterday. Since there is no head-to-head trial between these 3 medication or 3 agents, is it the time for political decision on nationwide, since most of the health providers are governmental sectors? Is it based on the price? Is it based on the first approved? What do you think?
I think if you have the 3 options together, okay, approved, then the price is a matter, of course. You have to think about the price, taking it about the price. This is what the classical way of thinking, okay? I'm not saying this is how I will do it, but of course, they will think about the price if you have 3 options and you tell them that the 3 options are equal, and nobody will look at the toxicity profile when they choose medication, okay? The decision makers in certain hospitals. And not in our hospital, of course.
Can I have a thought on this?
And another point is that first of all, my option is that we should have the different options. Especially, we have here some differences in toxicity profile for these patients. For example, darolutamide actually is the least toxic, and especially to the CNS toxicity and cognitive function, and you have to take this into account. And it is very safe in patients. It is a little bit considered safer in terms of cardiovascular or heart condition in relation to the other two, especially enzalutamide, which is the worst when it comes to, although the risk is not high, but in the three, actually, it is the worst in the effect of the heart and in the CNS. So I'm not going to say what I will choose, but definitely I will go with the safest and the cheapest one.
So Fahad, before you talk, I have one condition. Because the special relationship between you and Dr. Mohammed Al-Ghamdi, I will ask you to present him for the second satellite symposium for BMS. Is that okay with you?
It will be a great privilege to me.
Thank you.
Thank you very much. So I will not ask you, Isam, which one you would prefer if you will be asked for the BNT committee. But for you, Abdulaziz, I think we should not go towards exclusive politics. I mean, you want to choose only one or nationwide. These agents are relatively new, and evidence is coming. Our insight is improving with time. These are, we just heard from Dr. Isam, very elegant presentation about landmark trials, very well designed trial, but we will have more papers coming out and subgroup analysis from these things. Maybe will add to our insight, and maybe the decision that we will take today to take only one of them, maybe will not be our decision next year. So I would love to have them all. Yes, Abdulaziz.
I will just answer you. This is true, but the current era or the coming era is kind of totally an opposite. Now we are dealing with one company called NIPCO, and they're going to have universal price, and you have to justify why you take the other non-sugar medication. So this will be like a rough battle between the hospitals and the companies, and we have like special offer, special arrangement. Now it's not anymore the case. That's the reason I asked this question. I totally agree with you. I think we have to have the three. This is support even the research, and they have feedback in our society. But the current situation, I think you also face it, King Fahad. Now they are trying to enforce you to take only one medication. The other options will be hard for you to adapt.
Of course, it will be decided by the company, the NIPCO or something. But I mean, from our community, I think we should be clear that we would like to have all options, especially that I think prices are very close. The cost is very close to each other, and the competition even will help your pricing as well. So, but that was really a good argument.
I think Fahad and the group, if we want to sail through politics in adding medications, we should think like a con artist. Okay, we should think like a con artist. You have certain pitfalls in certain medications that you may getting it in an indication, and then after that you can use it at any indication. And if we just take an advice from the mafia or from those guys, the mobsters, they will give us a very nice advice in how to get these medications. Thank you very much. Let's go to jail now. Thank you. Okay, I think I'm done with this.
You can introduce
Dr. Fahad.
Your friend, and I delegate it to you if you don't mind.
Oh, no problem. It is my pleasure. So we'll move now to the next presentation. That was really a great presentation and discussion from you, Isam. And now we move to the next presentation. It's a satellite actually symposium sponsored by BMS. And it's about the real-life experience of dual IO blockade and first-line treatment for RCC. This will be presented by dear brother Dr. Mohammed Al-Ghamdi. Mohammed Al-Ghamdi is a medical oncologist and leading the medical oncology practice group in King Saud University. He has a special interest and experience in GI and GU cancers and unknown primary. So he treats very similar specialty that I do, and that's only one of the things that we have in common with Mohammed. Mohammed, it's a great privilege to have you with us, and we will enjoy hearing from you. Tfaddal, Dr. Mohammed.
Thank you so much, Fahad, and thank you, Dr. Abdulaziz, and thanks to the organizing committee. And I really appreciate the nice introduction, my friend Fahad. So today I'll be talking about real life experience with the first line IO combination. And also I'm going to give an update about the Checkmate 214, the 48 months.
Nice and clear.
These are my disclosures. So if we look at the burden of the metastatic RCC, we know that, and these data is actually from the year 2009. We know that from the time of diagnosis, about 30% of patients will present actually with metastatic disease as a de novo. And the 1 year survival is about 36%. The 2 year survival is even less, 22%. If you look at the 5 year survival, it's only 12%. So approximately about 40% of renal cell carcinoma will die of their metastasis in the first 3 years. So we need to do more for these patients in terms of giving them the best options and treating them with the best available evidence. We know that worldwide, this is probably not the commonest disease. However, it's a common as there are about 300,000 people diagnosed with RCC, and about 80% of those they have either intermediate or poor risk, and about half of these patients will not go to the second line therapy. So improving the survival and the having them to have a great durable response remain an ultimate goal to treat these patients. Looking at the data for Saudi Arabia, and this is the from the GloboCan, we know that the kidney cancer, it's the 10th most common cancer, and that based on the report presented in 2018. The newly diagnosed cases in the kingdom, around 830. Unfortunately, 249 patients will die of this, and the 5 years prevalence for all ages, 2,311, and again, the male to female ratio is 2:1. So when we talk about treating patients with metastatic RCC, we need to talk about the models that we're going to use for prognostications. We know that the Memorial Sloan Kettering, this is in the era of the cytokines in 2002. We know the international, the IMDC, or what we call HENG criteria in 2009, again in the targeted therapy. How about immunotherapy? Actually, we don't have a specific prognostic models used for patients who treated with immunotherapy in first line. However, we still use the MSK-CC and IMDC. Looking at the Memorial Sloan Kettering criteria, we know that it's based on the performance status of less than 80%, the time from diagnosis to the treatment with the interferon alpha less than 12 months, hemoglobin less than lower normal, LDH more than 1.5, and corrected serum calcium more than 10. And the risk group is by number of these categories. So favorable with 0, intermediate 1 or 2, poor more than 2. How about the IMDC? So similar, however, some differences in neutrophils count and platelets were added to IMDC, and also taking out the LDH level. And it has also the favorable, intermediate, and poor risk factors. These are the differences between the two. And as I mentioned, LDH is available in the Memorial Sloan, but not in IMDC. Neutrophil count and platelets available in IMDC, but not in the MSK. Looking at those patients in each group, and we're concentrating now on IMDC, and this was the work by the group at Tom Baker Cancer Center, Calgary, Heng, Ko, and Yep. They looked at the incidence or the distribution of patients among the subgroup categories. So favorable is about 22%, poor about the same, 23%, while the majority of patients have a 54%. So why is this is important? So if we look at the data of the cytokines or the interferon alpha and looking at the risk stratifications, we know there are a huge difference between the three groups. Zero risk or favorable risk, we're talking about 30 months median survival. With 1 or 2 risk, which is the intermediate, we're talking about 13.8, and only 5 months with the 3 or more risk factors. For the VGF or the IMDC, again, the first or favorable, we're talking about 43 months, 22.5 months with the intermediate, and only 8 months with the poor risk. Not only that, but also looking at the intermediate risk. Does it really make a difference if you have only 1 or 2? Actually, it does. If you look at here, you can see that those with the intermediate with only 1 risk factor, the median progression-free survival was 11.2, and the overall response, 43%. While those with the 2 risk factors, progression-free survival was 8.5, and with overall survival of 40%. So even in intermediate risk, we're probably dealing with a 2 different expected outcome of group of patients. So what are the rationales, or why do we use the immunotherapy in renal cell carcinoma? We know that cases that had the spontaneous remissions seen with RCC, and that probably related to the immune system that's been activated and controlled the RCC. We know that the RCC actually exhibits immune cells, infiltrates, and a several immune escape mechanism. And if we look at the history, what did we use to treat with for RCC? Interferon alpha. And Dr. Issam Marshad, I wasn't there actually when they treated the interferon, but you were. So basically, immunotherapy is really not new for RCC. However, with a smarter way and a different probably mechanism of action might have a good results. So ipilimumab and nivolumab, the anti-CTLA-4 and anti-PD-1, the combination of the two, which is having a synergistic effect on the tumor by doing 2 different mechanisms, have a benefit for these for our patients. So Checkmate 214, these are patients who got a treatment-naive clear cell RCC with a measurable disease, good performance status, stratified to either favorable risk, intermediate, or poor risk, and randomized to Nivo-Epi every 3 weeks for 4 doses because of the combination, then carry on with the Nivo every 2 weeks versus the standard of care, sunitinib, 50 milligram 4 out of 6 weeks until the progression or unacceptable toxicity. The co-primary endpoints for the intermediate and poor risk with the overall response rate, progression-free survival, and overall survival. Looking at the overall survival for the 2 groups, the intermediate and poor risk, it was significantly better with the combination immunotherapy, 48.1 versus 26.6. That resulted in a significant hazard ratio of 0.65. About subgroup analysis, most of the patients actually got benefit from the Nivo-Epi combination, with some exception of the small number of patients who are above age of 75. How about the progression-free survival? So progression-free survival was also significantly better with the use of the combination of Nivo-Epi, resulted in a progression-free survival of 11.2 versus 8.3, with a hazard ratio of 0.74. Response rate was also better with the combination immunotherapy, and we're talking about total response of 42% versus 26%. Complete response seen in about 10% with the combination versus only 1%. And if we look at the ongoing response, still we've got 65 versus 49%. That was the updated 2020 this year in ESMO. About the duration of the confirmed response. So we know that for the intermediate and the poor, the response or duration of response it's not reached with the combination, but it was 19.7 months. significant hazard ratio of 0.45, and a clear separation of the curves. Side effects. Suitent, it's a classical TKI with the diarrhea, fatigue, hypertension. However, there was an increased lipase level more with the combination immunotherapy. This is an overall survival post-hoc analysis looking at those patients who actually discontinued due to treatment side effects. Again, the combination was even better than the Suitent if you stop the treatment related to side effects. And the 12-month survival was about 87 versus 79, almost 10% or 9% difference. The 24 months, 74 versus 61 months. Again, this is just to show you those patients who discontinued due to treatment-related side effects versus those with intention to treat analysis. So basically, the aim of this is to show you that patients might actually have benefit even if they stop their treatment. Quality of life was better with the use of Nivo and Epi. This is a subgroup of patients when we have a sarcomatoid. So this is an exploratory analysis in these patients. Baseline characteristics between the two groups, no difference. Intermediate was almost more than 70% in both the Nivo and Epi versus the Suitent. Looking at the overall response rate, it's even higher with the combination of Nivo and Epi than the Nivo and Epi in all the group of patients, 56 versus 41. But significantly better when we compare the Nivo Epi versus Sunitinib. It was about 18.3% had a complete response. This is the progression-free survival for the Nivo Epi. It was significantly with a clear separation at the 3 months mark of 8.4 versus 4.9, hazard ratio of 0.61. The overall survival, again, there is also a significant difference between the two, almost more than double, and the combination Nivo and Epi with the 31 months versus only 13.6 with the Suitent, hazard ratio of 0.55. So when you want to treat patients with intermediate or poor risk, probably a combination of Nivo and Epi is one of the best options available if you have it. If you look at the categories, so the poor risk or the intermediate, Epi and Nivo with others, Exitinib, Pembro, and also the other options here. Okay, so I'm gonna go to my case. So this is Mr. F. He's a 74-year-old male with hypertension. He presented in September to emergency room, September 2018, to emergency with a history of left flank pain and hematuria. Classical presentation of RCC. He was seen by a urologist for evaluation. They did CT scan, MRI of abdomen, and it did show a left renal mass with no metastatic disease. Blood work was unremarkable. So patient underwent upper radical left nephrectomy on beginning of November 2019, and it was 13 centimeter in the maximum dimension. It was a clear cell carcinoma T3A NXMX. So no adjuvant therapy, and he kept on regular follow-up with his urologist. He did a follow-up scan on September 2019, and that showed nodularity and thickening of the left nephrectomy bed, about 4 centimeters, with a multiple new small bilateral lung nodules. And the biopsy from the left, from the renal bed, confirmed the recurrence disease of RCC, clear cell type. So Mr. F was referred to me, and I saw him for the first time in my clinic at the end of October. And at that time, we get access to Epi, and Nivo was available by compassionate access by BMS. He was having no symptoms, excellent performance status. He got a mild renal impairment and a low hemoglobin, normal calcium, platelet, and neutrophils. So he was an intermediate risk by IMDC. This is his baseline PET scan. As you can see here, the activity. So this is a normal physiological bowel. This is the other kidney, but here is the lymph nodes, and also here in the abdomen. Lung was PET avid negative because it was small in size. So started him on Ipi and Nivo, and he completed 4 cycles. That was in the beginning of this year, in January. And after 4 cycles, PET scan did show a significant improvement of his disease. Although it's a limited disease, but a significant improvement. So during his course, he developed hypothyroidism. He is on L-thyroxine, and he required one-time admission during the course of treatment with dehydration. So after more cycles of Nivo, so after 4 cycles of combination, I carried on with the Nivo, and PET scan after 6 more cycles showed a complete radiological or activity response, and even a response in his lung. This is just to show you the timeline. So we see the activity here on November 2019, after the 4 cycles, in January, clear improvement, and in last scan was in June. There was a complete resolution of the disease. So he is currently ongoing Nivo every 4 weeks. The reason I put him in 4 weeks because of the pandemic. And I saw him last month, and he is due for PET scan actually this month. These are just some information for healthcare workers from for Nivo and Ipi to minimize the risk and to have better education for patients and healthcare workers. Thank you so much.
شكرا جزيلا دكتور فهد. دكتور فهد, go ahead.
Thank you very much, Dr. Mohammed, for the great presentation. And do we have time for discussions and questions, Dr. Abdulaziz?
Yes, we have like 5 minutes.
Excellent. So the floor is open now if we have comments or questions. So maybe I'll start with this, Dr. Mohammed. Now we have, as we discussed earlier today about kidney cancer, we have more than one option to offer our patients with intermediate and poor risk. So when it comes to the IO-IO combination, who are the patients that you really consider IO-IO instead of other options?
So basically, those with clear cell sarcomatoid features, I would definitely use intermediate and poor risk. Also, if I don't have any contraindication to use of immunotherapy, and more importantly, if I have both agents. So I would definitely consider using the IO-IO in the first line treatment. For the second line, for the IO-TKI as a first line, I'm just worried about second line. What am I gonna use? I know there are some data looked at the adding Ipi in the second line after the use of Pembro and Axitinib, and there was some activities. But also you want to have something new to offer patients for the second line setting.
I think Dr. Mark he want to ask or to comment, because Dr. Mark, do you hear me?
Yes, I mean, I think I think whichever you choose, you'll get a good result. But I think certainly for the poorest patients who are likely to do well with sarcomatoid features, I have a tendency to put them on combination immunotherapy. I think there's a tolerability advantage as well, which is difficult to get from the trials, where you still get the Axitinib has its own particular set of side effects which don't go away with time. So you still get the TKI side effects with the combination approach. I would say something about the toxicities of the combination in patients with pre-existing autoimmune disease is that I've now used the combination therapy in patients with things like inflammatory bowel disease, rheumatoid arthritis, and psoriasis and other symptoms. And I've found paradoxically, I've had patients with inflammatory bowel disease whose symptoms have got better despite the treatment, and I've had patients with psoriasis whose disease has got better despite the treatment. And that may just be a coincidence, but what I'd say is that the absolute contraindications for the treatments in terms of in the studies don't necessarily apply in clinical trial, although you would have to have a risk-benefit discussion with the patients before giving them something which could make a pre-existing condition much, much worse.
Dr. Mark, do you have it? I don't know about the system in the UK. Do you have like what you call non-formulary or named patient? Like you purchase this medication for this particular patient?
So we don't have the UK is we don't have any. The way it works is you basically get your one opportunity for using your immunotherapy treatment per the license. So we can only use the combination first. We can't use it second. And the only time we can do that at the moment is because of COVID, because the government has sort of ripped up the actual licensing. So we have to use the drugs as per the license. So none of our patients second line can get combination IO treatment. They have to have single agent treatment unless it's licensed.
Dr. Fahad, sorry, just because I think the internet wasn't.
Can I just comment?
Faisal, go ahead.
Yes, please. So when I was in UK, we used to give the non-formulary drug through Cancer Drug Fund. I'm not sure. I've left the UK around 6 years ago. So I'm not sure if we still have that fund or not yet.
Yeah, well, it's so the Cancer Drugs Fund was a political thing which the government set up to essentially take away this charge that the government weren't supporting treatments. It's now been replaced. The CDF isn't really what that is a checking system. So if I prescribe combination immunotherapy, I have to check the patients off by all the criteria as is reflected in the clinical trial, so performance status, histology and everything like that. So it really mostly now functions as a check on prescribers, and I think rightly so that I can't just go, well, you can have it. I have to meet criteria. And second time around, so if I prescribe something and a high cost drug is found to be not eligible based around my criteria, then the trust have to pay for it. And of course the costs are quite high for, say, the combination treatment. You know, £100,000 is a lot of money to get for the hospital just to find. So it's an acceptable system, but it does run into problems when you get patients who fall slightly outside of it. Because I mean, no doubt about it. I don't think there's any. If you've had a TKI first and you've got intermediate prognosis, I think you'd still respond very nicely to combination therapy given second.
Thank you, Mark.
I have a question and a comment. I was stressed on Mark's comment about inflammatory bowel disease. I had used it in a patient with inflammatory bowel disease, and as Mark said, according to the gastroenterologist, of course, he said, what have you done to this patient? He had marked improvement of his inflammatory bowel disease. So I do believe, yes, that it should not be an absolute contraindication. The other thing is that, do you see a room for Sutent in the second line after failure of IO if you don't have the other options available?
I mean, we haven't been using Sutent, I have to say. It's not, when patients have progressed, they've either gone on to cabozantinib because it's a clinically significant progression. I've put patients onto Sutent, but onto tivozanib. But I haven't been using much Sutent second line, actually. I don't know what other panel members have been doing themselves.
So I'll take the question to Dr. Mohammed Ramdi. So what is your second line option after nivolumab, ipilimumab immunotherapy?
Thank you, Fahad. So just a comment about the autoimmune disease when we use immunotherapy. So we know it's not really an absolute contraindication. However, when we gonna use any immunotherapy in such patients, we need to be cautious. Patients could actually die and go to ICU with the flare-up of their diseases. I'm not sure about how these patients improve, but probably a good adjustment of their medications prior to start to immunotherapy. It's one of the reasons, because you're gonna actually get the attentions of their primary physicians to their underlying condition. So Fahad, for your
Second
question,
line.
so I think Sutent is still a good option after the combination of IO. I know cabozantinib, axitinib is also a valid option, but we have limited access to these drugs, actually, to be honest with you. So Sutent, it's still one of the active agents, and we see patients who actually respond even in the second line.
And you know, at the end, you want to rotate and you want to expose your patients to the active agents. I think with this transformation of the landscape, we need to think, extend our options. So I totally agree with you, Dr. Mohammed. And with that, we will conclude the sponsor satellite symposium by BMS. Thank you very much, Dr. Mohammed. That was a great presentation and discussion. And should we go ahead, Dr. Abdulaziz? Should I present next speaker as well?
Like it is from your, it is your home.
Because he's also my dear, very dear friend, brother, Dr. Faisal Azzam. So he will be presenting the next MSD sponsor satellite symposium, and will extend our learning and about RCC landscape. Dr. Faisal Azzam will talk about the role of IO in management, again, in the first line metastatic RCC. I promise you, although we heard a lot about RCC, Dr. Faisal is always enjoyable to hear from, and he present in a very special way. Dr. Faisal is a medical oncologist in King Fahd Specialist Hospital, and he has a great experience and leadership in the GU oncology, as well as gynae oncology and sarcoma. Dr. Faisal Azzam, it's a great privilege to hear from you and to have you with us today. The mic is yours.
Thank you very much, Fahad. That was a very nice introduction. And thank you very much for everybody in the panel. So I'll just share my screen.
We see your screen. And we see your presentation.
Right. So Mohammed has explained very well the first line IO combination. So, but I will go through all the available drugs we have in first line treatment. So, just my disclosures. My talk is have two sections. First is a case presentation, and second is the evidence for those treatments. So, first of all, case presentation. I have a patient called Mr. S.A., 56-year-old. He's a fit teacher, but very anxious man with clear cell carcinoma. Apart from diabetes mellitus, for which he's taking metformin and gliclazide, no other comorbidities. So he presented in October 2017 with abdominal pain, and he had a few investigations while the CT scan showed a tumor in the left kidney, for which he underwent left nephrectomy, pathology reported as clear cell carcinoma, PT3A grade 4, lymph nodes were negative. So he remained under the follow-up with the urology team till December 2018. So that is nearly 14 months after nephrectomy, when they found on a follow-up scan that there are 2 sub-centimeter nodules, 0.9 centimeter and 0.5 centimeter. So he was referred to us, the medical oncology. A PET scan was arranged, and a PET scan reported 5 millimeter left lung nodule, but no disease anywhere else. So we had a discussion with him about metastatectomy to confirm the diagnosis, but patient was not very keen. So we opted just to have surveillance and repeat the scan in 3 months' time. This is what we did. In 3 months' time, another PET scan showed more lesions. Now we have 1.5 centimeter new FDG-A lesion, while the other lung lesions are still there. So this time, we have again discussed that he should go for metastatectomy. He initially accepted. He went to thoracic team, but later on, he changed his mind and he refused to have metastatectomy. So after that, he came back to our clinic, medical oncology clinic. So he was told that if he's not accepting, it's better to start this systemic anti-cancer treatment. And because the disease is limited, he might benefit more at this stage. But again, he refused to have any treatment, any biopsy or metastatectomy in March 2019. So we gave him another appointment in 3 months' time with another scan. But before he could have a scan, he came into my clinic with a really short of breath. He couldn't complete sentences. Her performance status was 0 3 months ago, and now it is 3. We did an urgent chest X-ray that showed a large left-sided pleural effusion. So he was admitted for thoracentesis. Pleural cytology was negative. This time because he was symptomatic, so he agreed to have a biopsy. So thoracic team did a pleural biopsy, and that confirmed it to be metastatic clear cell renal carcinoma. After thoracentesis, he's still short of breath, but much better. His performance status has improved. He's feeling a bit tired, and we arranged a PET scan that showed multiple bilateral lung and pleural nodule now. Because of the pleural disease and extent of the disease, thoracic team said that it is not resectable anymore. His labs were normal. So overall, he is in the favorable risk group if you look at it through the IMDC category. This was his PET scan. So the treatment option at that time, now he has agreed to have treatment. The treatment options that could be possible in these patients are metastatectomy, sunitinib, pazopanib, cabozantinib. Ipi plus Nivo is for intermediate or poor risk. Our patient is favorable risk, pembrolizumab, axitinib, and ipilimumab plus axitinib. So we decided to start him on pembrolizumab plus axitinib. In July 2019, 3 months later, his performance status improved. He's asymptomatic. We did a PET scan again, and that showed significant response in pleural and lung metastases with minimal residual disease still there. So why did we decide to give a combination of TKI, axitinib plus IO pembrolizumab in a patient who have a favorable risk disease? That is because of the response rate. And we know from Keynote 426, the response rate was nearly 60%. And if you compare for frontline metastatic clear cell carcinoma, the response rates for all the drugs that are currently available, if you can see here, the best one is axitinib plus pembrolizumab, that is nearly 60%, while for favorable risk, the another recommended is sunitinib, the response rate is 27%. Ipilimumab plus nivolumab, as Muhammad said, 42% is the objective response rate. So we continued with pembrolizumab plus axitinib, started in July 2019. 6 months later, he's very well. Performance rate is 0, asymptomatic. PET scan showed this time complete response, no disease. But unfortunately, he developed liver enzyme derangement. So if you can see here in July when we started, his ALT and AST both were normal. But in December, it has risen to 385, the ALT, while AST was risen to 172. So that means our patient have grade 3 hepatitis. He was asymptomatic, but because of the grade 3 hepatitis, we stopped his treatment. 3 weeks later, he came back with normal LFTs. So we decided to restart the treatment, and he was restarted because his ALT, AST were back to normal. 3 weeks after that, when he came back, his liver enzymes were deranged again. But he was generally very well, asymptomatic. ALT was this time 155 and AST 73. So we decided to stop only axitinib, but continue with pembrolizumab. So we did that. His LFTs normalized again while he was on pembrolizumab. In March 2020, that is nearly 2 to 3 months of stopping axitinib only, he remained very well. LFTs were normal. So we decided to re-challenge him with axitinib again and see if his liver enzymes remain normal. So from the Keynote 426, we know that 2.3% of patients had more than grade 3 hepatitis. And the way we treated the grade 3 hepatitis is to stop the immunotherapy. In some patients, prednisolone is needed. Our patient did not need it because it went back to normal very quickly. Those patients who are on PD-1 or PD-L1 checkpoint inhibitors, those can be restarted once they get the LFTs get back to normal. But if the patient is on CTLA-4 inhibitor and they have grade 3 or more of the hepatitis, it's recommended to stop it permanently. So our patient now on pembrolizumab plus axitinib started in March 2020. He is well, he's on a full dose of axitinib, asymptomatic, LFTs remain normal, PET scan report no disease. September 2020, He is again very well, no disease on PET scan, but he developed a new left upper lobe 4 millimeter lesion, which we decided it could be just the immunotherapy effect, or it could be just something not significant. So we better continue with the treatment. But unfortunately, he had a severe skin reaction, which was urticaria, nodules, erythema, and papules were there. So we stopped all the treatments. He was referred to dermatology department. He was treated with the topical steroids and all the topical treatment. We did not give oral steroids. And within the next 3 weeks, next 4 weeks actually, his skin was back to normal. So he came back to our clinic again very well. So we restarted pembrolizumab plus axitinib. He had 2 more cycles of combination since his skin problems recovered. And the last time I saw him was 2 weeks ago. He remained very well. He's booked for another PET scan, but not yet done. But the last PET scan in September was normal, except a 4 millimeter left upper lobe nodule. So our patient who was started on combination of pembrolizumab plus axitinib for favorable risk metastatic renal cell carcinoma, clear cell renal cell carcinoma in July 2019. Till December, he is very well and disease-free. So this was the case. Now I'll move on to the evidence for first-line treatment in metastatic renal cell carcinoma. This slide was shown by Muhammad. We know that for favorable risk, the recommendations are axitinib plus pembrolizumab, pazopanib, sunitinib, cabozantinib can be given, or other combinations can be given. For poor and intermediate risk, EP plus nivo is plus XE plus pembro, and cabozantinib are all those preferred recommendation in the guidelines. So just going quickly through the old trials of sunitinib, which randomized patient to sunitinib or interferon. The results were positive in favor of sunitinib, with progression-free survival of 11 versus 5 months for interferon, hazard ratio of 0.42. Pazopanib study was also positive for progression-free survival in favor of pazopanib versus placebo, with a hazard ratio of 0.46. Then cabozantinib, a phase 2 study called Cabozan, reported a positive progression-free survival, where they randomized the patient for intermediate and poor risk, either cabozantinib or sunitinib, and the progression-free survival was favoring cabozantinib as compared to sunitinib, with hazard ratio of 0.48. Now that progression-free survival was significantly better in those patients who had MET mutation positive disease, with the hazard ratio of 0.32. Those who had not have a MET mutation, the hazard ratio was 0.67. So those were the old drugs, but now we have combination, and we are now preferring to give combination to all our patients who have metastatic clear cell carcinoma. So checkmate 214 has already been discussed. Ipilimumab plus nivolumab. Keynote 426 led to approval of pembrolizumab plus axitinib. And now, recently in ASCO 2020, they have presented checkmate 9ER, nivolumab plus cabozantinib, and then another trial, Javelin 101, led to approval of avelumab plus axitinib versus sunitinib. So if you look at the comparator arm for all these combinations was sunitinib, as sunitinib has been considered as first-line treatment for these patients. Just briefly going through all these, this has already been discussed, checkmate 214. So the initial approval in 2018 was because of the median overall survival, although not reported, but the hazard ratio was 0.63, but objective response rate of 42% versus 27%, progression-free survival of 11.6 months versus 8.4 months. In this year, ASCO 2020, they have reported their efficacy and safety at 42 months. So this is what I'm going to discuss a bit more. So this was the design where they randomized the patient to either nivolumab plus ipilimumab for 4 cycles, followed by maintenance nivolumab every 2 weeks, or sunitinib single agent. Overall survival in intermediate and poor risk population, initially at 17.5 months, follow-up, the hazard ratio was 0.63, at 30 months it's 0.66, and at 42 months it's 0.66 with a median overall survival of 47 months versus 26.6 months. At 42 months, 52% patients were alive in an arm where they had combination as compared to 39% in sunitinib arm. For ITT population, similar results. Hazard ratio at 42 months were 0.72, which are similar to the previous assessments. And at 42 months, the overall survival in IT2 group was 56% for combination as compared to 47% for sunitinib only. In favorable risk group, this has already been discussed. We do not recommend to give combination of nivolumab plus ipilimumab in a patient with a favorable risk group because at assessment at 17.5 months, then 30 months and 42 months, all of them favored sunitinib rather than combination of nivolumab plus ipilimumab. Then objective response rate in intermediate and poor risk group, it was 42 versus 26% with 10% complete responses. For ITT population, it was 39 versus 33% with 11% complete responses, while for favorable risk, it was 54% favoring sunitinib, not combination, as compared to 29% for combination. But if you look at the complete responses, there were significant complete responses reported. For favorable risk group, 13% complete responses were reported, even in patients who had a favorable risk group, although it's not recommended to give combination for favorable risk group. Then progression-free survival in intermediate or poor risk group, again favoring the combination of ipilimumab plus nivolumab. The hazard ratio at 42 months was 0.76. And one of the interesting bits you can notice here is that at 30 months, the curve has plateaued. So that means those patients who are alive and have controlled disease at 30th months, most probably their disease will remain stable as compared to sunitinib, while the curve is going other way. Progression-free survival in ITT population is behaving similarly at 30 months. The curve has plateaued. The hazard ratio at 17.5 months was 0.98, and at 42 months it was 0.89. Now, progression-free survival in favorable risk. As I mentioned, we do not recommend combination favorable risk group. And you can see here 17.5 months, the hazard ratio was 2.18, while at 42 months, it was 1.62. So not recommended to give combination for this group of patients. Quality of life for these patients who had combination nivolumab plus ipilimumab was not worse than patient who had sunitinib. In fact, it was better than sunitinib. So just to conclude, the CheckMate 214, the long-term follow-up at 42 months was favoring combination in both intermediate and poor risk, plus the ITT patient in the ITT group, with the progression-free survival curves plateauing at 30 months. Patient with favorable risk group, sunitinib is better than this combination. The incidence of the treatment-related adverse effect and the steroid use was decreased over the time, and no new safety signal observed with this combination. Discontinuation of this combination due to treatment-related adverse event did not affect the overall survival. Moving on to Keynote 426 study, which led to approval of exitinib plus pembrolizumab. Initial assessment was at 7 months, and the overall survival hazard ratio was 0.53, progression-free survival hazard ratio was 0.69, and objective response rate was nearly 60% versus 35%. These results led to approval of this combination for first-line metastatic renal cell carcinoma. In ASCO this year, they have presented their results after follow-up of 23 months. This was the study design. The randomization was pembro plus XC versus sunitinib in metastatic renal cell carcinoma who were treatment naive. Overall survival and progression-free survival in IT2 population, both favoring the combination. You can see here the overall survival at 24 months, 74% patients were alive in a patient with combination as compared to 66% in patient with sunitinib. The median overall survival was not reached, but the hazard ratio was 0.68, favoring combination. Progression-free survival in the ITT population was similarly better, favoring combination of pembro plus XC as compared to sunitinib. Median overall progression-free survival was 15.4 versus 11.1 with a hazard ratio of 0.71. Response rate was 60% in ITT population as compared to 39.9% with sunitinib. Complete responses were 38.8% in combination as compared to 3% with sunitinib, with median duration of response of 23.5 months as compared to 15.9 with sunitinib. Now, in favorable risk group, overall survival, no overall survival was seen in patient who had pembro plus XC as compared to sunitinib with hazard ratio of 1.06. Progression-free survival was seen in combination as compared to sunitinib with hazard ratio of 0.76 at 24 months. 45% patient had progression-free survival benefit as compared to 35%. Objective response rate of nearly 70% in those patients who had pembro plus XC with 11% had complete responses as compared to 50% with 6% complete responses. In intermediate and poor risk group, all patient, all overall survival, progression-free survival, and objective response rate, all endpoints were better in patients who had combination. At 24 months, 69% patients were alive with combination as compared to 56% in the sunitinib arm. Although the median overall survival was not reached, but it was favoring combination with a hazard ratio of 0.63. Progression-free survival, again, similar picture with a hazard ratio of 0.69 in the intermediate and poor risk group. The objective response rate was 55% versus 35%. Complete response is 8% versus 2%. Another important point to note here is the depth of response and overall survival. So if you look at these curves, overall survival curves, those patients who had a complete response with either pembrolizumab or plus axitinib or sunitinib, they did very well, and their curves remained plateaued. But those patients who had less than complete response, so partial response, so those patients who had pembrolizumab plus axitinib, they did well, but not similar. But not the similar picture was not seen with sunitinib as compared to combination. So just to conclude, the Keynote 426, we have seen the results initially, and then at 23 months were significantly better with those patients who had combination of pembro plus XC, with the overall survival hazard ratio now 0.68, progression-free survival hazard ratio now 0.71, and objective response rate of 60% versus 40%. Patient with the favorable risk showed no difference in overall survival with pembrolizumab plus axitinib, but progression-free survival and objective response rate were better in favorable risk group with combination. Patient with intermediate and poor risk group, overall survival, progression-free survival, and objective response rate all in favor of combination rather than sunitinib. So these results show that even after 23 months, that pembro plus XC is the standard of care for patients with previously untreated advanced renal cell carcinoma. Just quickly going through the new trials, Javelin 101, which randomized patient to combination of avelumab plus axitinib or sunitinib. The primary endpoint of progression-free survival in PD-L1 positive group was significantly better, 13.8 months versus 7.2 with hazard ratio of 0.61. In overall population, again, the hazard ratio was 0.69, favoring combination as compared to sunitinib. Now, progression-free survival was better in all the groups of patients when they looked into the subgroup analysis, regardless of the PD-L1 status, regardless of the risk factor and prior nephrectomy. Comparing the patient in PD-L1 group and overall population, progression-free survival was noted to be better regardless or similar regardless of the PD-L1 status. So to conclude the Javelin results 101, it demonstrated longer progression-free survival and higher objective response rate for combination as compared to sunitinib. Progression-free survival benefit was seen regardless of the PD-L1 status and regardless of the prognostic risk group. So we need more time for the overall survival. But nivolumab plus axitinib has demonstrated favorable safety risk profile, and that could be one of the combination among the other to be used in the first line treatment. And the more recent trial, which was again presented in ESCO this year, is a phase 3 study called Checkmate 9ER trial, which randomized patient to nivolumab plus cabozantinib versus sunitinib only. The primary endpoint of progression-free survival was significantly better for combination 16.6 versus 8.3 months with a hazard ratio of 0.51. The subgroup analysis favored almost all the groups of patients using nivolumab plus cabozantinib. Overall survival also favoring combination, although it has not reached yet, the median overall survival is not reached yet, with a hazard ratio of 0.60. Subgroup analysis for overall survival, again, all those patients benefited from combination rather than sunitinib, regardless of the performance status, gender, bone metastasis, nephrectomy, and PD-L1 status. Objective response rate was 55% in combination as compared to 27% with sunitinib. Complete response is 8 versus 4.6% were seen. Median duration of response 20 months for combination as compared to 11.5 months with sunitinib. Toxicity profile grade 3 or more toxicity wasn't very common, except the hepatotoxicity was seen in 3%. All others were 1 or 2%. Quality of life, again, similar to other studies, were not worse than those patients who were on sunitinib, in fact, better than sunitinib. So just to conclude the results of the Checkmate 9ER trial, it met all its efficacy endpoints and demonstrated superiority over the sunitinib. The progression-free survival, risk of disease progression or death reduction was 49%. Overall survival, risk of death reduction by 40%, absolute and absolute objective response rate increased by 29%. So nivolumab plus cabozantinib showed consistent progression-free survival, overall survival, objective response rate benefits over sunitinib across the key baseline characteristics, including the risk factors, PD-L1 status, and bone metastases. It was well tolerated, and there were low rate of treatment discontinuation. Patient had significantly better quality of life with combination as compared to sunitinib. So again, this could be in the future another first-line treatment for our patient with metastatic renal cell carcinoma. So we have now mostly have two, most of the institute would have either IPI plus Nivo or XC plus Pembro. How do we decide among those? It's difficult and we cannot compare, but I thought I'd just quickly go through the two different trials and see if we have any differences or similarities. So similarity between these two trials are that they have same comparator arm. And another important point to notice in the overall survival curves, you can see here the early separation was seen in both. In fact, quite early in Keynote 426 for axitinib plus pembrolizumab, but we have longer follow-up for Checkmate 214. We have 42 months follow-up results as compared to 23 months for Keynote 426. About the responses in intermediate and poor risk group, there were 42% objective response rate was seen with IPI plus Nivo, 10% complete responses were seen, while in the Keynote 426 with the combination of Pembro plus XZ, the objective response rate was 55% initially, and now 55.8%. Complete responses were 6.5% initially, and now 8%. Another important point to notice here is progression of disease was seen in 27% of patients in Nivo plus IPI study, while progressive disease was seen only in 14.6% in patients who had axitinib plus pembrolizumab. Then the progression-free survival, as I mentioned previously, if you can see here, the plateauing of the curve at 30 months with Nivo plus IPI is quite encouraging. In same thing, you can see here, although it's too early to say that if you're using Pembro plus X in Keynote 426, it seems that the curve is plateauing, but it's too early to say that it will happen the same like the Checkmate 214. We have to wait for a bit longer to see that. Looking at the toxicity profile, and if you look at the darker bit, these are the severe toxicity. And in both these studies, sunitinib arm had more toxicity, although there are slightly differences in the toxicity arm, but both these trials showed the combination is better as compared to sunitinib only. So we know that now we have multiple systemic therapy options for metastatic renal cell carcinoma. There's no obvious clear choice in these patients. For favorable risk group, any drug you give, including single agent sunitinib, probably they will do very well. I have actually currently have 3 patients with favorable risk lungs only disease, and they had a complete response, and their complete response is theirs for nearly 2 years. They are continuing on sunitinib only. So if you're considering Nivo plus Ipi patient with the intermediate and poor risk group disease, you have to consider those, no significant autoimmune disease, but as we have discussed that it can be given in these patients also. VEGF contraindication, so it's better to give this combination. And if you want to avoid the chronic VEGF adverse event like with exitinib, it's better to give this combination of Nivo plus Ipi. For those patients who are better for Pembro plus Xi, the favorable risk can be given this combination, intermediate or poor risk can be given. But one thing that is noticed is that a rapid response has been seen and a better objective response rate like our patients. So you can consider this combination better in any risk group if you want to have a rapid response. Again, patient, if you want to avoid the immune-related adverse event, then combination of IO treatment is better. We have a few more trials in pipeline, which probably would lead to approval of more combination like lenvatinib plus pembrolizumab and cabozantinib plus nivolumab plus ipilimumab. So this probably will give us more option to treat these patients, but we have to wait for the results of these studies. My last slide, I'm not going to discuss this, but this is just to put side by side all these trials for combination. All these are more or less similar, quite effective. Their toxicity profile is more or less similar. So it is difficult to compare these drugs because we don't have the comparative studies, but we can choose the patient, which will to choose the patient according to their disease, according to the toxicity profile. Thank you very much.
Thank you very much, Faisal. That was really comprehensive and informative. And now it's getting more difficult to discuss RCC landscape in 30 minutes. 30 minutes is not even enough. It's very rich now. And I know, Abdulaziz, we are like almost heading toward the ending time. But only one question to Faisal. We have now a decent CR proportion of patients that will achieve a complete response, either an IO or IO anti-VEGF. So what to do, for how long we treat these patients? And the other question, what does it mean to have a CR to a patient?
Right, so like my patient who had quite an extensive metastatic disease, and now he is completely disease-free on scans. Radiologically, complete response has been achieved. For how long? Now, for EP plus Nivo, I don't think so we have the answer, because maintenance nivolumab has been continued till progression. But for Keynote 426, I think they've used 35 cycles. So we can stop and see if the patient do well, maybe that, or continuing with nivolumab. We have actually a few patients who are continuing nivolumab for quite a long period, and they tolerate very well. So either of those could be okay. I'm not sure if others on the panel agree with the same, but this is how we do not have a clear answer from the trial, especially from EP plus Nivo, when to stop. We just say that till progression of the disease.
Excellent. So if we have any question from the panel, then otherwise, Dr. Abdelaziz, you're muted.
I have comment. First of all, I would like to mention something about Dr. Faisal. I really enjoy listening to him. Every manners, politics, history, medicine. He knows. He tells it like he sounds like novelist. He give you the historical manner, go slowly with this like dark or deep voice. It's really interesting to listen to him. He's like
that is Faisal. Yes.
Very nice. Thank you very much.
I think Dr. Faisal.
I would call him the David Attenborough of oncology.
Well deserved.
I think it is the time in our region is now, which for the non-formality, we should have like a round table, because I think all of you guys face, I'm radiation oncologist, face the problem is to convince the clinical pharmacist. This all mixture, this all things. I think now we need to change even the policy for non-formality, to make it round table, to sit down with your literature and also with the clinical pharmacist, is to convince, because the winner out of this is the patient. It's not the oncologist, it is the winner is the patient. All of us work for the patient with different perspective. I think that's it. The second thing, if you allow me, since we have Isam and Fahad, I think Saudi Arabia, and Dr. Mark, even he can witness this, Saudi Arabia maybe the largest country using the immunotherapy outside North America, West Europe, and Japan. This is really advantage for us. We should ask for sponsorship to give the feedback and to retrospectively show our data, because so far with all this with those all experts, we don't have our data. And I think with that will help us to design our future, like in the guidelines. So I think that I spoke with one of the companies and they're willing to sponsor this project, but they want someone to take lead. I'm a radiation oncologist, I'm out of it.
I totally agree with you. And we were just talking, me and Sam, about this, to have a network group so we can collect our data and exchange our experience. And yeah, we have some plan with Dr. Isam to take it to SOS and to make a formal networking group in geo-oncology. But that's what we were thinking of. Totally agree, Dr. Abdelaziz.
In fact, yesterday after my presentation about the real-world data in the use of palbociclib and HER2-negative hormone-positive breast cancer, and during my extensive research of preparing for the talk, I came across an opportunity which is very good in Saudi Arabia, that we can lead in the field of real-world data of our practice overall for everything. We keep on mentioning that the tolerance of our patients sometimes might be a little bit inferior than in the West, which is something that we have observed. And I think the real opportunity for us is to work on the real world data of different topics, and the sponsor for that is ready to sponsor whatever work we'd like to do. I'm talking about breast cancer to start with, and also from GU. I had some talks with the guys in the pharmaceuticals, and they're very much willing to do this. And I think now, if you have attended the ESMO Asia, which was conducted just a few days back, half of the presentations were the real-world data, including, by the way, some RCC and the immunotherapy in bladder cancer, immunotherapy in HCC. They have presented beautiful data. Almost half of the presentations were for the real-life data. I think this is a golden opportunity for us to work. And I just I spoke on the phone during the presentation with Fahad, mentioning this and the importance of having a network, unbiased network, to get the benefit out of whatever we are doing. And I do stress on your point, Dr. Al-Hamad, of that the mentality of choosing medication should change, rather than just going to the blunt survival or sometimes the disease-free survival, which is also very hard to convince the people to license drug in the kingdom for so far, we should also look at the toxicity profile, at the other contributing factors like the comorbidities. Nevertheless to say that our community is suffering from diabetes, for example, which represent about 35% of the population. Obesity in our community is very common. So these things should be taken into consideration and should be the criteria to choose medications rather than going to the blunt statistical points of solid non-human point, in my view.
Dr. Muhammad, you want to comment?
I totally agree with all of you guys. I think having a national based practitioners who actually sit together and collect the data, and also doing the national guidelines for the use of these many options for our patients. So totally agree with all of you guys.
Like currently, Prince Sultan just is not advertising. We have almost 100 patients in immunotherapy, which is, I think it is big number for one institute. I think we can share with a lot of centers. I believe King Fahd also have similar numbers. So I think this is the time.
Exactly. We have immunotherapy now for 3 years almost. We've been using immunotherapy, and it's a treasure that we need to sit together and look at our data. I think, Abdulaziz, it's time to adjourn or conclude. So the mic is yours.
Thank you very much. I really enjoy, and thank you for you all guys to participate and to spare part of your valuable time for this meeting. Again, I'd like to, if it's my hand, I'd like to thank everyone individually by his name. However, I'd like to thank all my colleagues in Prince Sultan Military for Scientific Committee, Dr. by age, Dr. Majdi Qandil, Dr. Assam Murshid, Dr. Mirvet Mahrous, and Dr. Talib Hlega, all the participants from everywhere in Saudi Arabia. Dr. Mark Twithell, this is the first time I met with you, but it was my pleasure. I hope the situation in Oxford is better than other cities in UK. We hear this news is kind of striking, and I like to thank everybody.
Abdulaziz, before you conclude, can I just make one announcement, if you allow me, please? Okay, I will take this opportunity to announce the thing I've discussed with Fahad, the Saudi GU network, and expect an invitation, okay, in the coming 2 weeks for a Zoom meeting to establish this group and then to go ahead with it, please. So Fahad, spread the news to everybody. Muhammad Al-Ghamdi is here, Faisal Azzam is here, and I'm sure Abu Badr Abdullah Sharm is listening to us, although for the last few meetings he's not appearing by his face.
I am with you. I am with you, yeah, Dr. Assam.
But you don't put your picture.
He's always supportive, Dr. Abdullah.
I am with you.
We miss the beauty of how you look, ya Abdullah. We didn't.
I know, والله I try to change myself now.
So you are doing plastic surgeries, huh?
Yeah.
Okay, so most of the opinion leaders or the key leaders are here. So expect, please, an invitation in the coming 2 weeks to launch this group. Thank you very much, guys. And sorry, Abdulaziz, for interfering.
Enjoy the rest of your weekend.
Thank you very much.
It was a great pleasure. Thank you.
Okay, thank you very much, guys.
Thank you. Bye-bye.
Yeah, thank you. A special thanks goes to Abdulaziz and Mirfat.